Good morning and thank you for coming in today. I'm just going to be starting with a little bit of sort of a procedural thing that we have to go through, so just bear with us while I read out the script and then we'll start with the introductions. So welcome to the third hearing of the Committee's inquiry into birth trauma. I acknowledge the Gadigal people of the Eora Nation, the traditional custodians on the land on which we are meeting today. I pay my respects to elders past and present and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the land and waters of New South Wales. I also acknowledge and pay my respect to any Aboriginal and Torres Strait Islander people joining us today. My name is Emma Hurst and I am Chair of the Committee. I ask everyone in the room to please turn their mobile phones to silent. Owing to the nature of this inquiry, I would like to warn those in attendance and listening to this recording that evidence presented today may contain sensitive content or themes. If you feel distressed as a result of the inquiry's sensitive content and themes, please contact one of the resources available on the Committee's website. Parliamentary privilege applies to witnesses in relation to the evidence they give today. However, it does not apply to what witnesses say outside of the hearing. I urge witnesses to be careful about making comments to the media or others after completing their evidence. In addition, the Legislative Council has adopted rules to provide procedural fairness for inquiry participants. I encourage committee members and witnesses to be mindful of these procedures. Welcome to you both and thank you for making the time to give evidence today. Before we begin this session, I remind witnesses to avoid referring to specific names, hospitals or medical facilities in their evidence and to speak generally about the issues raised in the terms of reference. Could I ask now each witness, starting from my left, to please state their name and position title and swear either an oath or an affirmation.
Hi, my name is Dulce Munoz. My position title is that I'm a mother and I work in the refugee space. And the affirmation is that I solemnly and sincerely and truly declare and affirm that evidence now about to be given by me shall be true and the whole truth and nothing but the truth.
Thank you.
Hi, my name's Amy Madropoulos, and the affirmation, I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Thank you for both of you. Would you like to start by giving an opening statement? Perhaps I'll start on my left again.
Hi, yes, thank you. I'm going to read it because I get really nervous, and if I get nervous, my English goes in and out as a dyslexic bilingual person. So, first of all, thank you. Thank you for allowing us to share our experience. So, here we go. Here we go. I give birth to my daughter on the 30th of November 2010 in an inner city hospital after 72 hours of labor that ended up saving our lives, an emergency C-section from which I am eternally grateful, and that left me with an anxiety disorder and a life with lifelong consequences. There are three things that went wrong that day. One is that I'm a person of color with a very deep accent that at the time looked really young, with a normal pregnancy medical story and no complications. When my pain, discomfort, question were dismissed, ignored by the hospital staff. 2, I felt that there was an animosity between doctors, midwives during the last part of the labor, which created uncertainty and tension. And 3, that there was a lack of training and communication and compassion about childbirth trauma after the C-section. When I asked the nurse in the recovery room after the C-section about my baby, she told me, "Oh, I can't tell you about that, just rest," leaving me to create all scenarios possible, including burying my child, taking up jogging, rehearsing my phone call to my dad, telling her that her grandchild died. After 2 hours, when I saw Victoria, my child, in my mother's arms, I was completely in shock and denial. It took me days to realize that I had a healthy baby and that nothing happened. But then years to realize also that my panic attacks, my health anxiety, the extreme attachment to Victoria was PTSD for that day. It's funny how an old life like me at 40-year-olds can be marked by this traumatic effect still. But there are so many positive outcomes that came after that. My life work, my passion, and my vocation. I'm here because for all the incredible work our health system do, I truly believe that there is an underlying racism, sexism, and ageism that impact the way we treat people. I'm here today because for me it is essential that we address these systematic issues to ensure that no other expectant mothers, no matter where they come from, where their accent, their age, or their medical history, experience the same distress that I did. I'm also very conscious that I have a very good story because I have a healthy baby and I didn't have long life consequences in my physical health. But I'm here to tell you that my story, it's very similar to the tens of thousands of stories that I heard working with refugees and asylum seekers, especially young moms who birth in Australia and who feel disconnected. So that's why I'm here. Thank you.
Thank you. Thank you so much.
Okay, it's my turn now. I gave birth to my first child in February 2017. I was part of the midwifery group practice program, and I was working as a registered nurse in the hospital in which I delivered in. I want to use today's opportunity to discuss a few points: the importance of informed consent, the impact of birth injuries, and the importance of women's health physiotherapy. The details of my birth could be typed over pages and pages, but I want to be concise and refer back to my written submission under Section B. But to summarise these main points, the position and size of my baby was picked up in the antenatal period, but was not discussed with me at any point. I was left to labour for an extended period of time, and my midwife had been on duty for over 16 hours and had left before I was at the pushing stage, handing me over to a midwife who I had never met. By the time my baby was in distress, again, I wasn't informed, interventions were required. Prior to this, there was time to explain the risks. There was time for me to make an informed decision. I was not given that option. There was no informed consent. The midwife and obstetrician would go outside the room for their discussions. I was told by the doctor, we will use a vacuum to get the baby out and they may have a bruise on their head. They did try the vacuum over 5 times when recommendations are only 3 attempts. That failed. I then had an episiotomy, which was not discussed, and then the use of forceps to deliver my baby. Again, not discussed. Following the traumatic birth of my son, during handover, the staff would jokingly refer to my birth as a vaginal caesarean. Despite everyone acknowledging that my birth was traumatic both physically and psychologically, I wasn't provided adequate pain relief. There was no opportunity to debrief, no referral pathways for my ongoing issues and injuries. I had to do it all on my own. I felt a burden to my midwives because my injuries and conditions as a result of my birth were quite complex and clearly beyond their scope of practice. Comments such as, "Is this your first baby?" from other staff became insulting. It shouldn't matter if it was my first or my 10th. If a patient has a concern, they need to be acknowledged. I have been left with permanent and life-changing injuries as a result of my traumatic birth, including pelvic organ prolapse of bladder, bowel and uterus, urinary retention. I was unable to pass urine without the aid of a catheter for the first 6 months of my child's life. Bilateral avulsion, pudendal neuralgia, fecal incontinence, PTSD and depersonalisation disorder. I've had over 9 surgeries, including a hysterectomy and sacrocolopexy in 2021, and I will continue to need surgery for the rest of my life in order to be able to function. I'm in pain every day. I'm unable to work full-time. My life is planned around symptom management, my toileting needs, and pain thresholds. The rehab and treatment is constant. It's exhausting. It has impacted on my relationships with the people I care for the most, my wonderful husband and my 2 beautiful boys. I did seek legal action, and during this period, the hospital openly admitted that they were actively trying to avoid a caesarean, none of which was discussed with me at any point during my pregnancy journey. Without my knowledge, they were enforcing the now rescinded New South Wales health policy of towards a normal birth and trying to avoid increasing their caesarean rate. Had I known the risk of an instrumental delivery versus a caesarean, I would have advocated harder for myself. But I was under the impression that I was in the best possible care and the people in that room had my best interests at heart. The harsh reality is all of my injuries could have been avoided had I been given the option of a caesarean. It is my belief that what's important is informed choice. No program or treatment method is without its limitations. Not every woman can have a normal physiological birth, and interventions may be required. These interventions will be performed by obstetricians no matter what modality of care that woman has chosen. Risk versus benefit needs to be explained by the medical professionals that may be delivering that care. If these risks are identified in the antenatal period, they should be discussed then and not in the delivery suite. Postnatally, for me, it was a women's health physio that identified my birth injuries and my birth trauma. Women's health physiotherapists are key in diagnosing pelvic and treating pelvic floor issues. Their involvement in care for early intervention and treatment to prevent more invasive measures down the track. It's not midwives, it's not doctors, it's women's health physios. There should be more subsidies for women's health physio, and all women need to have access to them regardless of their mode of delivery. It's disappointing that their insights have not been heard of part of this inquiry, as they see firsthand the devastating consequences these injuries have on the lives of women like me. It's not enough for women to simply educate themselves. Health professionals need to ensure that their patients have an understanding. In my own nursing career, I've never witnessed the complete disregard for a patient's concerns until I myself was that patient. If you want to deliver care that is truly woman-centred, egos need to be put aside. Look at the research and listen to those that have a lived experience and make that case for change. Thank you.
Thank you. Thank you so much to both of you, and thank you so much for coming here today and for your bravery. I'm just going to start with a couple of questions, and I know that you've covered this both slightly in your opening statements and in your submissions. But as part of this inquiry, we will be making recommendations to the government in regards to anything the government can do in regards to funding, in regards to laws, things like that. What is it that you would like to see as recommendations as part of that report? I might start with you,
Yep.
Amy.
So yeah, as I've mentioned, women's health physio, even in the antenatal period, to assist with that education for a physiological birth and education. As I mentioned, if you have a vaginal birth without intervention, that's great, and you may not know that there will be problems until you're in that labour and delivery suite, but those options need to be discussed, and the whole line of you can't tell women everything that can go wrong in childbirth. No, you can't, but there's definitely room for improvement there. Yeah.
I think you also mentioned in your submission that the hospital was severely understaffed and
Yes.
that affected the care that you received. Can you
Yes.
talk a little bit more about that and around adequate staffing and good maternity care?
Yeah. So as I mentioned, my midwife, who'd been through with me for my entire pregnancy, was on duty for over 16 hours, and I was handed over to a midwife I'd never met before. And this is back in 2017, so I can only imagine it's gotten a lot worse now. But there were, I think, over 6 or 7 babies being born. We could hear them crying while I was labouring, and you wouldn't see staff. I was left in the room for hours. That's not an exaggeration. I was left alone for hours with my husband, my sister and my mum, and they would come in for a couple of minutes, check in, sometimes not even speak to me. They would come in, touch some buttons on the CTG machine, and then leave the room because they were just too busy trying to help other people.
Thank you. I'm sorry, and my original question was what recommendations would you like to see as part of the report?
I think child training on child trauma, no matter where you are, after a C-section and 72 hours of free labor after my C-section in the recovery room, no one knew what was happening to the baby. And you are pumped with drugs, hormones are going up the roof, and you're asking a very basic question. And the answer is, I can talk to you about that. And it's like 3 hours of recovery where your mind, especially a mind like mine, which neurodiversity goes and just, resolve things. So I bury my child, take on jogging, move from Australia, and then there is a shock. The other recommendation that I would do is cultural appropriate training, the way people see us still as migrants. I receive a lot of, oh, but you are so young. Your pain is completely normal. It wasn't normal. It was 72 hours that require some nip and tuck after that, so it wasn't normal. The fact that I was asking questions after my body was completely filled with rashes because of a reaction to one of the drugs, I think there is a lot we have to do to put racism and ageism and sexism. The fact that we expect that women go through pain, unnecessary pain, is in the root of all this. They're expecting us to hold pain as, what were you expecting?
Yeah.
What is pain acceptable?
Yeah.
So yeah, those are my recommendations.
I also had a follow-up question for you, and I noticed that you said in your submission that there was animosity between the doctors and the midwives, and that created different advice to you. I imagine that would have created a lot of confusion. Can you talk a little bit more about what was happening there?
Sure. I think, as you say, Amy, that there is a push for natural birth. And I was a perfect picture patient. I was young, I was fit, I didn't have a glucose, my baby was in a good position, everything was perfect. So they pushed during 72 hours to do a natural birth. And they even judged me when I went, I think I need epidural because something is ripping my hips apart. And they were really pushing for it. They break my waters, and then they were trying as much as they can for a natural birth. When my baby got in distress and my heart got in distress, then the last thing I remember is a doctor telling me, are you allergic to anything? But between those points, I remember doctors in different shifts coming and saying, I think it's a lot of time. I think this baby is gonna go in distress. And the nurses was like, no, this is absolutely perfect. She's fine. Look at her. I wasn't fine.
I would agree with that statement as well. There's almost like this unspoken battle that almost the midwives may feel that they have failed a woman by not giving them that vaginal birth. Personally, I had no preference of mode of delivery. But as I said in my statement, had I known the lifelong injuries I'd be left with, I would have advocated for a caesarean. But I had that trust in the health system, being a nurse myself. And I think health literacy is really important for some women when they give birth. It's the first time they ever go to hospital, and it's a completely foreign environment. For me, not so much, because I know what the drip is and things like that. And you can become overwhelmed with that alone, not never mind you're giving birth to a child, but the actual environment is quite overwhelming, and you might not have the courage to speak up and ask questions. And I do feel like there is this push for normal birth, vaginal birth. And then when the doctors get involved, it's almost as like they've been defeated, but it's really not about that. You've got to look after the mother and the child, whatever is safest, whatever poses a less risk, that's what everyone should be advocating for. And it doesn't happen in other areas of healthcare. If I had a patient come to me with concerns, I would do my best to address them, and I feel like that's missing in the training in the midwifery and delivery space.
Thank you. I'm just looking at other committee members. Dr. Amanda Conn.
I've got two questions, if that's all right.
Of course.
My first one is about that postnatal period. In both of your stories, you talk about sort of the delay between you realising that you needed some extra support in your recovery and actually getting that sort of diagnosis and support, Amy, with your physical injuries and we'll say with your psychological injuries. I was hoping you could speak to how that could be better. So when would you have wanted that follow-up? Who would you have wanted it from? How could we do that postnatal period better?
I think having the option for a facilitated debrief, and I know that's going to take a lot of resources, but it's essential. Sometimes just going through the events of what had happened could be enough for healing to occur. So facilitated debrief, they need pathways they have a pathway for a caesarean, for example. There's set pain relief and pathways to follow, but for my instrumental delivery, there didn't seem to be that. I was only offered Panadol, even though it was a vaginal caesarean, according to them. And I know there's some postnatal guidelines being developed. I've seen things about that happening, which is great. So similar to how the structure to, I guess, the antenatal period is, which also needs improvement, but there needs to be the same sort of structure in that postnatal period, a checklist or something, just to ensure that the woman might not need those services, but they should be offered anyway, because it does take time to sort of realise, what's just happened. So some sort of pathway, I think, for the postnatal period.
My injuries were mental health. So, and you don't know what it's normal after giving birth. You think that stress, that paranoia, that checking if your baby's breathing every 3 seconds is normal. And then you realize when your child is 6 months that it's not. So I think one of the things is that they check for the wealth of the baby, and they check that you are breastfeeding him, and they check if you are feeling blue when you are not feeling depressed. You're feeling something that it's insidious and something that you don't know. So I think for me it is about educating women that no matter what kind of childbirth experience you have, you will have consequences. I think we assume that childbirth is still not a life-threatening situation. We are so used to take women's health for granted. Check on moms, make it, again, culturally appropriate. I was so happy to have a partner that could support me so I didn't have to go back to work until I kind of sort out panic attacks. I was lucky that I live in the city where I have access to services and I'm able to pay for them. But a lot of people don't do, and it will impact economically and physically and mentally for the rest of their lives. Yeah.
My second question is about the antenatal period, and both of you have spoken to wanting to have had more information about what kind of interventions might be involved, and in both of your stories you've sort of met the obstetricians, you've met the doctors at the absolute 11th hour when things are already requiring intervention. So if you could have had perfect antenatal care, when and from who would you have wanted to have that information about risks and possible interventions, and when would you have wanted the opportunity to meet the doctor?
For me, I was overdue, so I had what's called a post-dates clinic, so I was induced at nearly 42 weeks. So even at that point, I met an obstetrician who looked over the ultrasound, and then there was an argument between the midwife and the doctor as to what date I should be brought in for induction. None of the discussions were had with me. It was like I wasn't in the room. So I think towards the end of your pregnancy, you should definitely be speaking to or getting opinions from, obstetricians, midwives, whichever you haven't heard from, because there are options. But a lot of it will depend on how you're carrying your baby, how you are, if there's other complications. So I think just, again, providing the option, and if the woman wants to take it up or not, that's up to them. But you don't get any options. And then in my first appointment with the midwife, I remember this clearly, I was given a stack of papers about this thick, and it had everything in there, how to introduce your dog to your new baby, like things like that. But that information pack was never referred to again. I was given it at the first appointment, took it home, and in that, after I'd given birth and, in the years since, I've actually gone through it, and it does mention a few things about labour and delivery, but it's never referred to again. It's almost as if we've given you the information, that's enough. I can tick that box and move on to the next patient.
So just to clarify, Amy, you're talking about those sort of last few week antenatal appointments before delivery, that the obstetrician did turn up, but not with enough time to actually discuss things in the level of detail that you wanted.
Yeah, correct, yeah.
When I was in my scan on week 20, my child, I was told that my child was going to be born with something called talipes, which is club foot. It is a very mind syndrome that, I don't know if it's a syndrome, but her foot is like this, and you will need to use certain orthopedic tools to open it. And I remember I felt so confused. I didn't know where it came from. I have never heard. So, but then they gave me all the information that I could need for my child. Like, she's gonna be fine. This is gonna happen. A note was made. So I felt that everything was about the child. They were there to save the child, and I felt so comfortable about that. But it was never mentioned to me what's going to happen to you if something goes wrong. I didn't met the people who were going to be in charge in the hospital at that time. I know that they were 72 hours, so that means there were like 4 shifts in and out. But at no point I talked to a doctor until this lovely man came and told me, "Are you allergic to anything? I'm about to put you to sleep and open you wide." My child was born after 7 minutes, after 72 hours. So again, I think we take for granted that a perfect pregnancy will be a perfect delivery, and that's not the case.
That's what I said.
Yeah.
Yeah.
Thank you. The Honourable Emily Savell.
Thanks so much, Chair. Thank you to you both for being here today and for your opening statements and your submissions. It's really important and will help us in terms of making recommendations. I wanted to follow on from the sort of line of questioning from Dr. Amanda Conn regarding the information that you received and whether or not, if we were to improve this information, what is the best mode that you would recommend to do this? Whether it's online, you mentioned being given a book. So, how can we better do this? Is it face-to-face classes? Is it apps? Is it?
Ask the patient. If the patient comes from a qualified background, they might not want written material. They might prefer the face-to-face interaction. I think you need to ask it of what the patient needs and have those options available. For some, written material may be enough, but for others it won't be. And if you want, patient-centred care, women-centred care, you need to tailor that care. It's not a one-size-fits-all. And we do it in other areas of health. I do it at work all the time. So it can be done. So we just need to ask the patient, and ensure that they have an understanding. And if they don't, what's the next step? Do we need to get someone in to explain this a bit better?
Thank you.
Yeah, I agree with that. I think there is no one solution. I think resources are important, and we know that education is not. I present you with a piece of paper or I'll tell you something. I think it should be repeated. I think it should be repeated as much as they repeat how important it is to vaccinate our kids and how important it is to go to our meetings. I think it should happen from the moment you are pregnant. Information of what it's up, so you can make an informed decision as much as possible. I think being a mom is surrender yourself to the uncertainty all the time. But it does help if you know what uncertainty looks like a little bit. So, yeah.
Thank you. And in terms of the information that we should provide, if we were to do, say, a standardised program, what topics would you recommend be covered? And do you have any suggestions for how we strike a balance between, providing enough information and then providing or providing too much information that it may be overwhelming or daunting for people?
I think there's enough information provided for your baby, as Dulcie mentioned. There's very little about the care of the mother, the partner, the husband. I think we educate about, the baby well. It's all about the baby, really, at the moment. So women's health physio needs to be included. What to expect in the fourth trimester, as they call it. What kind of support you might need. What does that support look like? What is available to you? As I mentioned, I had to seek treatment privately. I had to go and find a urologist to help me with my urinary retention. I made the call to find a psychologist because I knew it wasn't just the baby blues or anxiety. It was diagnosed PTSD, but no one through the hospital just washed their hands after 6 weeks. That was it. So I think there needs to be a lot more about the care of the mother, the care of the woman. I think the baby side is pretty well covered.
I agree with that. I would like to see also a lot more about mental health after the first 6 weeks of the baby. Most of us are just working on hormones, and I want to see also information for parents and family. I didn't understand that what was happening to me wasn't normal until my partner pointed out and was like, the last thing I remember before the C-section is a mobile phone ringing, and then even today when I get anxious, I hear it all the time. And that's part of your psychosis, and I didn't understand what was happening. It was he. So also support for the parents or the partners of people who are birthing is really important.
Thank you. That's really useful. Thank you to you both. In terms of the care, we've also sort of heard throughout this hearing that maternity care needs to be more respectful care, including acknowledging, when someone's in pain, obviously, or has concerns. What actions do you think need to happen to ensure this occurs? And I suppose also, could you describe for me a situation when you have received respectful maternity care and what that looked like? Sorry.
We're like the same person. pain's a difficult one because it's subjective, right? So I think that comes down to, your nurses and midwives and doctors in their training. But in terms of a positive birth experience, so along my recovery, I met an amazing pain specialist who happened to be an obstetrician gynecologist as well. And I had some surgical procedures that helped me feel a little bit better, and then felt a bit better and fell pregnant with my second. We were adamant we weren't going to have any more children because of the further risk of injury and all the trauma. And he honestly saved my life. I don't think I would have gone through with a second pregnancy had I not met him, because I knew I'd be looked after. So I had an elective cesarean with my second child, partly because of necessity, because of my injuries and because of the trauma. And he was just beautiful. He would take my hand and take me off the bed after an examination. When I went into that operating theatre for my cesarean, he introduced every single member of staff. Everyone then knew I had a bad birth experience before, and you could just see it in their faces that they really wanted it to go well, and it did. And we didn't know the sex of the baby. We found out we had another boy, and it was just joyous, and it was just that acknowledgement. This is Amy, she's a nurse. We've heard about what happened in your last experience. We're trying not to do that, and that carried right through that whole journey. But that's a cost, and I was fortunate enough to be able to pay for private care, and not everyone has that option. So trauma-informed care, if there is a history of trauma, if they've had a traumatic birth and this is their second, that needs to be asked in the antenatal period. And just some more training again with how you communicate to patients and stop being so dismissive. I get you have to be healthy, and having a baby is a happy occasion, but for some women it's traumatising and it's horrible. So we need to take account of that.
I agree. I decided not to have another child, so I don't have another birth story. But I had kidney infections years before having my child, and I had it in Australia. And everyone believed me that I was in pain because it was kidney infection. Everyone was like, oh my God, this is the worst thing that could happen. And it's nothing like what I felt. I felt I was dying inside in comparison from, like, Victoria's pain was worse. But no one believed me because I'm expected to be in pain because I'm giving birth. So it was something that, how do we manage pain? And I feel that it's because everyone knows what kidney stones and kidney pain feels, including male doctors. And I was like, they were like, oh, we know how to treat this. You take this. And I was in hospital for 7 days, and I received excellent care for a kidney infection. When I was in Victoria, after 72 hours of extreme pain, and I'm good with pain, extreme pain, everyone was like, well, this happens because you're a first-time mom. Yeah. And the question of, oh, is this your first baby? And then they dismiss your pain. Yeah. Then,
I even had, during my 20 plus hours of labour, I had a doctor lean over me and say, it's called labour for a reason, honey.
Yeah.
I'll never forget that. Yeah.
So I think pain should not be, there's no way to measure pain, but it's a way to train people to trust people. I wasn't there for drugs. I wasn't there to make myself a spectacle. I was there to deliver a child who was safely delivered, but at great cost.
Yeah.
Thank you so much.
Thank you. Yes, the Honourable Sarah Mitchell.
Thank you both for your submissions and for coming today. I just want to ask a question. I think, Amy, you might have mentioned the role of husbands and partners and support people. That's something that has come up in other witnesses as well, just about how, I guess, they're kept abreast of the situation and what's happening, whether it's, as I said, your partner or a family member. And particularly, I suppose, for migrant women as well, when you do have that barrier of communication that I know, Dossie, you said you experienced. Do you think there's any recommendations that we could make around how partners and support people are more involved or informed in the process on behalf of the birthing woman as well? Do you think there's anything that we could do in that space or improve?
Absolutely. One of the hardest thing is, although I have a thick accent, I'm highly educated and I'm come from a comfortable background. And for the first time in my life ever, and I live in many places, I feel racism. And I don't know if it was racism because I was a pregnant migrant and I wasn't asked my level of education or where I live. So it wasn't an economic racism. It was a race racism. They thought that, I don't know, it was very strange. And my partner couldn't fight it. Like, we didn't feel empowered to say, hey, maybe you should listen to her. Hey, I honestly think that he saved the life of my baby, my partner. So we were in the delivery room, and my child's heart rate dropped like completely, and he noticed, and he was like, something is wrong, and he went out. The alarm didn't sound, nothing. He went out and looked for it. And I remember going like, oh, it's normal. And he was like, no, it's not normal. And then I was rushed. So yes, I think education should come also to families. Again, we are so comfortable thinking that women should suffer by themselves when they have babies, that we forget to educate the rest of the community that surrounds them about what to look for, what to expect, what are your rights and what are your obligations to this person that is birthing.
And they know who's going to be in the room. The birth space is very protected, so there's time. They know in advance who's going to be in that room. They knew my husband was going to be there. So talk to them, acknowledge them. I think I was explaining to my husband at one stage what the drip rate meant, and what, with my nursing background, I was lucky I had a very good anaesthetist that gave my epidural, so I wasn't in any pain. But I remember the room after my son was born, and I was like, he's here, because I was numb. I was a little bit in shock, and then I looked at my husband, and I'm like, why aren't you happy? Like, it took me years to sort of recognise it was the absolute trauma of what happened in that room. It was a war zone. There was blood everywhere, people everywhere. And he was just kind of, wasn't even smiling. And I'm like holding our beautiful baby boy, and I'm like, he's here, like, and no one was happy. And he wasn't acknowledged at any point during that madness, and there was time. Yeah.
Thank you.
Hi, thank you very much for coming today. I just wanted to ask a little bit more about the consent process. Amy, you mentioned in your submission that at no stage consent was given, so I'm keen to hear from both of you, but also with your lens as a nurse and you understanding how you need to get consent from a patient. So I'm just interested to hear your recollection of the process, but also some recommendations.
Yeah. So I actually have a background in operating theatres, so I know consent policy inside out, back to front. And I know that in birth and delivery it's a little bit different because it's considered, an emergency situation. But part of obtaining an informed consent is you check with the patient, do they understand the risks of the procedure you're about to do? And they on purpose left out information. It was all about, you've been in labour for a little while now, we're going to get the baby out, we're going to use, the vacuum. But he didn't go on to say what the risks were to me, if I had any other option, and if the vacuum didn't work, what was the next option. They just left information out, and that's not informed consent, and, hence why I sought legal action. It's just, there's time. I know in some instances it is, flip of a switch and it's emergency and it's go time, but hopefully with some changes in antenatal education, it won't be as traumatic. But yeah, I feel like, again, it's all focused on getting that baby out, and they've got to perform the interventions to you as a person. So you need to ensure that there's an understanding of risk to mother and risk to baby. And I don't feel, especially in my case, that was done at all.
I think in the past few years we have learned a lot about the word consent, and especially referring to women's body. Consent comes with education, and we are very poorly educated about what happens when pregnancy is real, when pregnancy is not perfect, when childbirth is not perfect. So I think consent starts with education and understanding our choices, our rights. That was never explained. The other thing is consent about the levels of pain, maybe, that you are ready to manage. Like, this is it. I was giving my consent to be open. Like, please take me. And no one listened to that. Consent also comes with listening to the patient. So that's what I have to say. Yeah.
Thank you.
Is there any further questions?
One more if there's time. But I just wanted to talk about the word normal, because that's I know there used to be the towards normal, which I think Amy mentioned is now not a policy anymore. But certainly what I'm picking up over the hearings and the submissions is that I don't think there really is such thing as a normal pregnancy and a normal childbirth, and maybe we need to be looking at some of the language and terminology that's used, because every experience is different and every birth is different, and I just thought you might have a view on that as well.
Yeah, I would agree. There was nothing normal about my experience, and maybe in changing some of the language, it might help for people to recognise that they may need, you know, for example, referring it to as an instrumental delivery rather than, you know, vaginal caesarean. Yeah, it may, and we change language in health all the time.
Yeah.
So I think that would be a good suggestion moving forward. Yep.
Yeah.
I think in my case, normal was used against me. It was
Yeah.
a very normal pregnancy. It was just, you were in, like, glucose was fine, baby weight was fine, you were fine, it's normal. And I carry normal,
Yeah.
you know, and at the end, it wasn't normal.
Yeah.
So we use that normal. Suffering of women is normal, and we need to stop that.
Thanks.
If there's time. I just wondered if you could, either of you, perhaps expand somewhat on any of your experiences during the whole continuum of care, you know, antenatal, during the whole perinatal period, I suppose. And if you can outline to the committee whether there were any positive aspects and what these were and what we can do as a committee and as a government indeed to ensure things like this continue to occur.
I would say nothing about my first experience was positive. Everything about the second was, and that's because I had trauma-informed clinicians looking after me that acknowledged me as a person and were concerned for my health as well as that of my child. So there was really, on reflection, and I've reflected a lot, there's really nothing positive that came about from my first experience.
So better enabling clinicians to have understandings around trauma-informed care,
Yep.
for example?
Yep.
Thanks.
I agree with you. I don't have another birth experience, but I do have the incredible experience of working with people who work with trauma and the way they refer to traumatic events. It's not about how everyone will handle a situation. It's the way that situation affects you and how we are going to put resources in place to make sure that you understand what happened and you can move forward accepting what happened. I think we still are quite behind mental health in women's spaces and in family spaces. So yeah.
Thank you. Thanks.
Thank you both so much for coming today. It's been incredible for you both to come and share your story with us, and it's incredibly brave, both of you, so thank you so much, and it will go a long way in helping us put this report together and the recommendations to government, and hopefully we can get some change. So thank you both so much for your time
Thanks for the
today.
opportunity.
Thank you.
Chair,
Can I ask that we make an exception to
Absolutely.
parliamentary procedure and give them a clap?
Absolutely. Good morning. Thank you for joining us. I'm going to start by asking each witness, starting from my left, to please state their name and position title and swear either an oath or an affirmation.
Hi, my name is Rochelle Edwards. I am a community member and mother to a 2-year-old, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. Mrs. Ledger?
My name is Lynn Ledger, and I'm here as an individual. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. Ms. Yazdani?
I am Elahe Yazdani, member community and a mom, and I'm here to say my story. And yeah, I just ought to say everything, the truth. Yeah, okay. I have to read it? Sorry.
Yes, please. Yes,
All right.
thank you.
I solemnly, solemnly, and thoroughly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. Thanks for that. So I'm going to open it up to you to give a short opening statement. I might start with Mrs. Edwards and we'll move across. Thank you.
Thank you for inviting me here today to give evidence to this select committee. I'm sure I speak for the over 4,000 people behind the submissions to this committee when I say something needs to change. I fell pregnant with my son via IVF in July 2020. Prior to conceiving him, my husband and I had sadly lost 3 pregnancies and gone through the emotional and physically draining process of fertility treatment. When I fell pregnant with my now son, I believe my hardest days were behind me. Firstly, being a plus-size woman, I was judged by medical staff from the outset. I was not only diagnosed with gestational diabetes, but I was actually blamed for it. I was told not to gain any weight during my pregnancy, which left me so anxious that I would be sent to hospital regularly for blood pressure monitoring, almost at a weekly basis towards the end. I was offered an early induction as ultrasound showed that my son was going to be huge. The 7th of March 2021 turned out to be the best and worst days of my life. I was induced at 6 p.m. and sent to the postnatal ward with no monitoring. It felt like one big long contraction. However, every time I rang for help with the pain, I was dismissed by the nursing staff and not even given Panadol. It wasn't until 9 p.m. when the next shift came on and someone believed me enough to place the CTG on that they realised my son's heart rate was dangerously low and I needed an emergency C-section. My son was born at 11:04 p.m. and weighing 3.45 kilos, definitely not huge. He was not breathing and was blue and needed resuscitation at birth. After what felt like a lifetime, he started crying and with a kiss from me was taken to the special care nursery where my husband followed. I returned to my room to recover after my major surgery when about 4 a.m. the lights flickered on. My son was needing urgent transport to a level 3 NICU via nets, something that this hospital couldn't provide. I knew how important it was and just wanted to see him, but the midwife said they did not have enough staff to wheel me around to go and see him before he left, and it was unlikely that Nets would bring him around to my room before they left. My husband and paediatrician then decided to wheel me around despite the nurse's wishes so I could meet my son. After my son was transported with my husband is where the failings of the system really started to show. I was denied another support person to stay with me due to COVID restrictions, my dad and stepmom only being allowed in after I begged my obstetrician and he went and spoke to the num again. It was about 6 hours. I was left alone in my room with no person for support where my buzzer had dropped to the floor and no one came in to see how I was going. I was not taught how to express milk in the absence of my son and not given any breastfeeding information at all. I was not helped out of bed by the first time by the nursing staff. My stepmother, who has never had children, was left with this gruesome task. I was told that I was a challenging patient by my midwife, and I was also told that I'd soon want to be away from my infant son because he would be annoying me. I was told by the same midwife that I was a burden. I was denied mental health and social support I was denied mental health and social work support, even though I requested several times. I was encouraged to self-discharge by the nursing staff and to get into a car with my father less than 24 hours after a major abdominal surgery. I tried to speak to the nun to express my concerns and was told she was too busy. The most hurtful thing is that I was told I was not a priority to transport to the other hospital and it could be days before I was moved. Due to my extensive experience previously as a nursing case manager, I knew how to advocate for myself. But I struggled as I found myself tangled in a web of systemic failures at one of the most vulnerable times in my life. However, because of my experience, knowing someone in Patient Transport New South Wales, and the tireless support of the social worker at the hospital my son was at, I was transferred late in the evening of the 8th. The hospital I was at, I was told, had not even started looking at booking patient transport for me. My son survived and is now a happy, healthy 2-year-old. However, I need to see psychologists regularly and struggle to seek medical attention when needed for myself. I made a complaint to the Healthcare Complaints Commission and an internal review at my hospital was conducted. I received an apology. My biggest message I want to get across today is women are just as important as the babies we birth. Please hear us.
Thank you. Could we move now to Mrs. Ledger, please, if you're happy to give a statement.
I have a birth injury, bilateral avulsion of the levator ani muscle, as well as 3-compartment prolapse. I want to focus on 2 key points today: the extent of impacts of my injury and the prevalence of avulsion. I also want to provide my recommendations. So firstly, the impacts. I would like to table the mind map that I've put in front of all of you was part of my submission. It shows how my birth injury, which cannot be seen, impacts every aspect of my life. Everything from the physical aspects of the injury, managing a pessary, fitting in the required ongoing rehabilitation, to my work, home and social life, mental and physical health and well-being, my relationship with my husband, children and extended family, and my ability to look after my own children. At one stage, the impacts became so completely overwhelming that I got to the point of contemplating suicide. Yet I was told by more than one practitioner during the time of diagnosis to stop catastrophizing. As I age and go through menopause, there is only one certainty, and that is that my condition will worsen. In fact, it already has since I was diagnosed 5 years ago. This causes me great anxiety about my future. With longevity in the family, I have potentially many decades to survive and manage this injury. Currently, I use a pessary and work hard every day to build and maintain my strength and conditioning, to ensure I can be functional and independent for as long as possible, but who knows how long this will last. Moving on to prevalence. Since I was diagnosed, I have read many articles from peer-reviewed journals in an effort to understand my injury. I've been horrified by the statistics around avulsion. Approximately 1 in 5 women sustain avulsion during their first delivery. Some articles suggest this could be as high as 1 in 3. Between 10 and 15% of women sustain avulsion after spontaneous vaginal deliveries. Avulsion has been found in up to 66% of women after forceps deliveries, and 36% of women with prolapse have underlying avulsion. Realising how common this injury is, I thought surely there's a surgical fix for me, and searched for more information. However, I discovered there is no surgical solution for avulsion. At best, surgery for avulsion is considered experimental. Additionally, while prolapse surgeries are relatively common, they have a high reoperation rate, between 19 and 29%. And my urogynecologist explained to me that for women with avulsion, the failure rate of prolapse surgery is much higher, around 70 to 80%. To say these statistics are shocking to me is a gross understatement. Listening to the news on the radio one day, hearing about endeavours to send spacecraft to Mars and establish communities on the moon, I got incredibly angry. How is this fair? Somehow millions, probably billions of dollars are poured into R&D for these activities in space, but we can't fix a woman's vagina after she gives life to another. So now my recommendations. 1, immediately undertake a study into the economic burden of levator ani avulsion. Considering the prevalence of avulsion and the various types of impacts as I have shown in my mind map, the economic burden of avulsion must be huge. On another women-focused issue, endometriosis, the total economic burden has been estimated to be between $7.4 and $9.7 billion. Endometriosis affects 1 in 9 Australian women and has a similar range of impacts. Approximately 1 in 5 and possibly up to 1 in 3 women have avulsion, which is almost double or 3 times that of endometriosis. 2. Ease the ongoing financial burden on individuals, one of the key impacts of avulsion, by working with the Australian Government to put in place Medicare-funded care plans focused on birth injury and trauma. These would likely be similar in nature to eating disorder treatment and management plans, which provide for comprehensive treatment from both psychological services and allied health professionals. And 3, urgently invest in research and development for women with avulsion on 3 key areas. A, this one's the most important to me, research to develop permanent surgical fixes for avulsion. Additionally, where experimental surgery is occurring outside Australia and showing reasonable results, provide funding for our Australian surgeons to learn these techniques, improve on them, and make them available to women in Australia. B, research to improve outcomes and longevity of prolapse surgery for those of us with avulsion. A 70 to 80% failure rate is not acceptable. And C, research to develop new and better pessaries that work for all women with avulsion, potentially using imaging and 3D printing or other innovative techniques. We need this while we wait for improvements in prolapse surgery and development of permanent fixes. As one of hundreds of thousands, possibly into the millions of women in Australia with this injury, I need your help to put all these recommendations on the public record and ensure that they are implemented. Thank you for listening.
Thank you very much. Ms. Yazdani, do you have an opening statement that you'd like to give?
Yes, I do have. The first thing, I apologize about my English, and
Don't apologize.
I'm here to tell some of my story and also talk behalf of my community, refugee people, and all multicultural women. As I said, I'm Elahe Yazdani. I came to Australia 2020 by myself alone and on protection visa. And I just found I am pregnant after 6 weeks. I was in Australia, and it was such a big shock and also happiness for me, and also it was a miracle for me. I arrived alone and I experienced many forms of trauma, mistreatment, and also abuse before I came to Australia. And this pregnancy was like top of all that trauma for me. I was happy I am pregnant, but also I was alone and I didn't know how I have to do that. And I didn't have any support during pregnancy. I didn't offer any support or any information in my own language. I have to listen everything in English, and because I was very new and listening was so hard for me, and it was so hard to understand everything. It was the first thing, the first trauma. And also no family, no one, no friend, no family here. And the other thing I just recently found it was I could have a midwife during pregnancy and also after to support me, help me, and inform me, but I didn't even offer to have someone. My birth experience was one of the worst experience. And yeah, I still feel so bad. I feel sad. I feel anxious sometimes. I try to forget my birth, but I can't. And it's been 3 years. I still have to see psychologists every week. I have a happy, healthy son, but I'm not okay. I'm not happy sometimes, and it is so hard. And with all wonderful support I got from community and people, sometimes I got panic attack, I got anxiety, crying, nightmares, and all these things is with me. And I never thought have a birth could traumatize me. And yes, I was forced to have an induction when I was 41 weeks. and I didn't want to have it. And I asked them, okay, if it's something necessary, just please give me a reason why I have to do induction. And they didn't give me a good reason. They just, I could remember the midwife was laughing and even not looking at me. I was so nervous, I was crying, and I said, I don't want to have induction. And she told me, I think your baby is not growing enough. And I remember I just faint. And I start crying, and I said, okay, if you think the baby is not grow enough, why you don't do emergency cesarean section? And she just laughed, and she said, no, I don't. I mean maybe. And I said, you scared me, and now you say maybe. You cannot talk to a woman is pregnant, and is here without any support. Even if you have lots of support, your family, it's not the way to talk to a lady who is pregnant. And they with force and with pressure, I agreed to do induction, and they start induction in the morning, 8 a.m. and I was in the labor with lots of pain and lots of different things for 12 hours, and finally I couldn't have natural birth. And the baby got distressed, and they took me for emergency cesarean section. In just 10 minutes, they did epidural, and the person was trying to do epidural. I remember she tried 3 times to do epidural, and when they were moving me to the operation room, I told them my neck and my head is like heavy and very bad pain. Nobody didn't care about that, and they took me. They did cesarean section. They took me to the ward, and the day after, it was afternoon, a lady came. She was midwife, and she asked me to have a shower, and I said, I cannot walk. Can you help me? It was a bed rail. She took it off, and she said, you can go and have a shower, and she just left the room. And when I was at the shower, I couldn't move, and very bad back pain and neck pain, and I started screaming, and they came and they took me to the bed, and I couldn't move. And when the doctors came, they said, I think the epidural had leaked, and I couldn't move. They told me, you're not allowed to move. They take the baby. I couldn't see my baby for 24 hours, and I was on pain, screaming, crying, and I got ignored. Nobody didn't care. Nobody didn't come to the room. I even couldn't reach to the boss to ask them to give me pain relief or even some food, some water. And I remember the lady was in the room with me, and midwife was coming regularly to look after her. I asked her to help me, to give me some water, to give me pain relief, and she told me there is another midwife assigned to help you, and she didn't do anything. Even she didn't let the midwife to come to the room. And they did blood patch the day after for me, and I was in the bed for 3 days without any moving. I couldn't move. I have to stay in the bed, and I get ignored, very bad treatment. Nobody didn't come to the room. I could remember the baby was crying. I couldn't reach to take him. I couldn't change his nappy. I was so thirsty. Around 4 hours, I asked them, I buzzed the bottom to ask help. Nobody didn't come, and finally I start screaming and crying and ask help. And when the midwife came, I told them, why you ignore me? Why you think I'm nobody here? Because my hair is black, because English is not my first language, because I'm a refugee, because my skin is brown. Why you don't care about me? I'm here like another patient. Everyone comes to this room looking after the other lady. And when I ask about help, no one don't care about me. What's the reason? And after I talk this thing to them, they came and just tried to look after baby. They brought some food for me. And it was the way I treated. And also, I'm sorry.
It's okay.
It's been 3 years, and I still feel I was nobody on that hospital. Nobody didn't listen to me. Why you treat to people like this? Why there is still racism in the hospital? Why we have to treat like this? They asked me to sign the papers, and even when the English is your first language, when you are stressed, when you are under pain, it's hard to understand medical things. And they asked me to sign the paper. I even didn't know what I'm signing. And I asked them for interpreter, and the interpreter over the phone, she was explaining for me she was telling me wrong thing, and because I was an ICU nurse in my home country, I could understand she is telling me the wrong thing. And I think I had a little bit of medical experience and I could understand. Imagine people on that hospital without any English background. And yeah, I believe I was racially discriminated against because I was brown, I was refugee. Yeah, it was a very bad experience for me. And they didn't care about my pain. The blood patch was very painful. Nobody didn't inform me what's going on. They didn't tell me what they want to do. They just took me to the surgery room and they asked me very badly to do the position to do blood patch. And I was on lots of pain. And I think sometimes being kind, it doesn't matter about your position. It's just being kind. It's because we are human. It doesn't matter who you are, who am I. It's just we are human. But for me, it was having a birth was one of the worst, one of the saddest, one of the, I don't know, big experience in my life. And I'm still dealing and trying to cope with that, but it's hard. Last year, I remember I saw a psychiatrist for a while because still I had nightmares about my birth. And I think it's very important in this country. Australia is a multicultural country, and when people coming to this country as a refugee, it doesn't mean we are victim. We are not victim. We had life. Some of us, we had a beautiful life in our country, qualification. If we come to your country, we bring all our culture, qualification, everything for you. You have to thankful. Sorry, I'm sorry to talking like this here. And I recommend, I think the doctors and the nurse, the midwives in the hospital, they have to trauma-informed training. It is very important to people like me coming to this country. And I think all the refugees, when they come to this country, they had lots of trauma. Even the people decided to immigrate to another country, they got lots of bad experience. And I think it's very important. The second thing is the hospital staff needs to have racism training. It is very important. Being treated racist in the hospital, it is the worst thing in this country, and we have to care about that. And also for the people coming as a refugee and the English is not first language for them, I think have a medical interpreter is very important. It is very important. And I think interpreter over the phone is not a good idea. I think the interpreter needs to be in the room. And also, I think the people, they need to care about people like me, single moms, no family, no friends in this country, and very new in the country. They need to do plan for more support. And also they need to do plan for the multicultural people and other language people to have training in their own language for them. Thank you.
Thank you. Thank you very much. Thank you to all of you for those opening statements, and thank you again for coming and being so vulnerable to share your personal stories. We really do appreciate it. We're going to now move around the committee and just ask different questions. I'm just looking around to see the Honourable Mark Banasiak.
Thank you. Probably just one question to you, Ms. Yazdani. You obviously, being a refugee with no family, no friends here, would you have liked the hospital or a community organisation to provide a support person to be there during the birth? Do you think that would have assisted in having someone there to help advocate for you or advocate with you to get proper care? Do you think that would have assisted?
Yeah, I think it's very important. As I said, I recently found I could have a midwife with me during pregnancy and after, but I didn't even offer to have someone. Yeah, I had support worker from Red Cross and other organization, but they were not professional about having birth. And it was so hard for me. Absolutely, I think it is very important to have someone.
Thank you.
Thank you. The Honourable Emily Savall.
Thanks, Chair. Thank you to you all for appearing today and for your opening statements and submissions. My question, my first question to you, Mrs. Ledger, if you're comfortable answering. In your submission, I noted that you mentioned you'd be grateful to be given the opportunity to present to the committee to explain each impact in your mind map in detail. I wondered if you would like to do so, and thank you for providing a nice A3 version for us.
Yeah, thank you. So I guess just to explain a bit further the mind map, what my experience was that as I started to go and see a range of practitioners, most of them hadn't heard of avulsion. And so not only was I struggling to learn about it myself, I then found myself in the position where I was having to educate these people not on the actual injury, but then also how it was impacting me, because like I said earlier, I was told to stop catastrophizing, but when you see the scale of the impacts, it kind of is a catastrophe.
And could you just clarify in terms of the clinicians, who were those clinicians that
the
you saw?
first one that told me to stop catastrophizing was actually a GP. Needless to say, I don't see that GP anymore. And I was also told that by one women's health physio. I guess one of my other recommendations is that there's appropriate training on all these birth injuries for all of these practitioners that have to deal with people with birth injuries, and considering it's so prevalent, it's really important that happens. But I guess, just going back to my mind map, I did it at a point in time, and so as the injury and the impacts of that progress, and my children age and my work changes and things like that, I would effectively need to redo this. So this is just a snapshot in time that's from effectively a year or so ago. So the first part about understanding the injury, that just sent me down into a really dark place. It was hard to find information. I admit, like most people who end up with birth trauma, you do a lot of Googling because there isn't that information out there. And I got told to go to bed when I found out I had prolapse. And at the time, I had a newborn and I had a 15-month-old. And it was pretty much impossible to, just be in bed. So my husband had to stop work and things like that. But I went into an absolute panic because as soon as I read about avulsion on the internet, I just knew that I had that because that's what I was feeling. So I had to go through, I just can't even tell you how many appointments I went through. Like, it was hell. I just was going to appointment after appointment, having to juggle the babies. And then I started to figure out, what questions I should be asking, but even that was traumatic in itself because you obviously don't know what you don't know, so it's really hard to ask the right questions to get the right kind of information. So then obviously I went down the mental health hole, and there was the uncertainty about what was happening to me, how it would affect my family. I couldn't look after my children. We had to get my parents-in-law to fly over from France and basically stay with us to help me in the interim so my husband could go back to work. Had to pay for my mum to come back from a holiday so she could help out. I felt like I was a massive burden on my family, especially my husband. And yeah, as I couldn't look after my children, so when I did go back to work, I had to basically have help even on the days that I was at home, to help me carry my children and, be able to move around. I couldn't go out, I couldn't socialise, I couldn't do a whole lot of sport in those early days. I was actually told not to do sport to start with, until I kind of could increase some of my my strength and learn to use a pessary. The most heartbreaking one for me has actually been the inability to look after my own kids, and like even now, my son, he can't ride a bike, and he keeps asking me to take him down to the local oval and teach him, but I just can't run. I can't be at that angle with him to push him on his bike, and it seems like something so simple, but it's something that I always thought that I'd be able to do. And I can't be the mum that I want to be. My husband, I'm sure he won't mind me talking about it, but our sex life is now crap. I have to take the pessary out to have sex. I don't want to be taking it in and out every day because I find that traumatic in itself. So it's taken away that, it's changed our relationship, a loss of intimacy. And it's mainly because I don't feel that I understand my own body. I just have this part of me that is foreign, and I can't see it. I don't know what it looks like. All the diagrams in books, that's not what my insides look like anymore. My extended family, that's been a really hard one. They've tried to help, but they're very practical people, and it's really hard for them to. I have an injury that's effectively an invisible disability. They can't see what I'm experiencing, and even to the point one day I was on the beach with my kids, and my kids wanted me to dig a hole, and that position for me of digging a hole is actually a really hard position to be in. And my mum said, "Why don't you just get down and dig the hole with your kids?" And I just thought, I have told you everything. Like, how can you not understand that how that makes me feel? It doesn't make me feel good for, that she doesn't understand, but it also doesn't make me feel good that I feel like I'm letting down my kids again. So I effectively have stopped telling them how I feel. My friends, I've effectively made new friends. It's really hard to talk to lots of my male friends from uni about my vagina. I really struggled in those early days, particularly to make mum friends, because I couldn't take the kids out on my own. My work has had to change. And I guess I've been lucky enough to be able to apply for a different kind of role at work. But that's actually meant loss of my technical skills. And then I guess my home life, I can't really look after my house properly. Every morning, I think this was mentioned in the session before, I have to prioritise myself and having a bowel movement over everything. So basically mum's coffee and breakfast and lots of water comes first before kids get anything. So I often have to get up quite early to make sure that happens before I go out. And so, because if I don't do that, then I can effectively feel the prolapse because of the avulsion as well, all day. I could go on and on about this, but that's probably enough because I know other people need to say things too. But thank you for asking the question.
Thanks for sharing. Thank you.
Dr.
It just sort of follows on.
Yes, sorry, the Honourable Sarah Mitchell.
Thank you so much, and thank you for being so open and honest. And I think you're the first witness that we've had actually talk about some of those physical traumas that, many women unfortunately do have that experience. But I just want to ask two specific things about, you mentioned about having potentially sort of access to the same supports as someone with disability, and you talk about having kind of invisible disability, whether it's parking and that kind of thing, which to me just seems like a really common sense thing that the committee should be recommending. So thank you for that. I don't know if you want to add anything to that.
Yeah, I could just tell you about one experience I had really early on. I got to the supermarket and, I'd seen all the other mums going to the supermarket with their kids and thought, surely I should be able to do this.
Yeah.
And then I parked the car in the normal parking. There was no pram parking or anything. And realised that there was no way that I could carry my two children, because they were both, fairly close in age, over to a trolley, or then I would have to get the pram out of the car, the double pram, and then put them both in it, which I also, at that stage, I was not doing the double pram on my own, so I would have had to, do the double pram on my own, put my children in, and then I wouldn't have been able to have my shopping in the pram around my children. And so I was kind of just stuck there. So I went and parked in the disabled parking, and I remember just sitting in the car thinking, if I get out and walk over and just put my kids in the trolley, could I then go and park the car? It was that moment where I realised I need, even if it's just temporarily for a few years to get through this period where my kids can't walk, I need to be able to access that disabled parking. And it, even now, like being able to carry heavy shopping and things like that, if it's not a supermarket where you've got access to a trolley, like having those, just even the rolly bag things, and then if you can't fit it in that, then what do you do? It's like there's so many aspects, and it is something that is probably quite common in consideration for a person with a disability, but because we're not classed as someone with a disability, then we have these just enormous hurdles that stop us getting back out into the community and being able to do normal things to look after our families and ourselves.
Thank you.
Dr. Amanda Conn.
My question is for Mrs. Ledger, because you touched on this in your submission, but I'd be open to answers from all three of you as well, about the financial cost implications of your injuries and sort of that cost of care and all of the changes you've needed to make in your life over these years.
Yeah, I know I'm going to forget stuff because this is just so massive. And also, I guess it's important to think about the fact that there's the cost in that early days of like the diagnosis, attending all those appointments, having to have my husband off work, so it's family financials rather than, necessarily just the direct financial impact to me. The cost of all those appointments, I'm fortunate that I was able to seek, care through kind of private means as well. I've got private health. But as soon as I got my first pessary and started to try to figure out whether I could claim for that, I was immediately shocked that I can't even claim for a pessary under Bupa. Bupa, you should be ashamed on the record, because I know that some others do. And then, so there was all that cost in the early days, and then I had to have effectively someone with me all the time. So we needed to get, I couldn't rely on my family for that. So they were nice enough to let an au pair stay in their granny flat. They lived not far from me, and so basically I had that au pair there every day that I was off work. That au pair was with me, helping me care for my children, doing all the lifting, getting the pram out of the car, and all of that kind of stuff. So that was a huge expense. And then COVID hit and we were stuck at home, but I also went through the stage of then realising I couldn't clean my own house, I couldn't do my own shopping, I couldn't do all these other things. So my husband had to do the shopping, we had to get a cleaner, and then I guess from managing the physical aspects alone, well, let's say physical and mental, I've have lots of GP appointments, I have a psychology appointments, I have women's health physio appointments, I have weekly appointments where I do exercise physiology for strength and conditioning and Pilates, and the Pilates is something that I think I put in my submission that that's been taken off private health, and that is the number one thing that I need. And it is so damn expensive to have a one-on-one session, and I really need that attention because I'm learning about a new body. I have a new body to learn about. So every single movement I do is new, and I need to learn how it functions and to be able to do all the movements that I do on a daily basis safely so I don't make my problem worse and it can last for as long as possible. So that everything just on my annual, monthly, weekly appointments currently adds up to, I think I put in there 10,000 plus, but I would say there's way more than that. And I guess looking to the future, and I've been told that, I might need changes to my laundry. like, we're getting into real functional, simple stuff, but like, occupational therapy type stuff where you look at how you manage your laundry, taking bits out to the line, one at a time, or changing the laundry situation so you can pull stuff out of the laundry. Like, it's super simple stuff, but it greatly affects how I can manage this in the longer term. Cleaners, yard maintenance, it just absolutely anything. And to be honest, like, I have had massive breakdowns over the thought of my husband dying before me because I have no idea how I'd cope. So one day just driving home, it just kind of hit me that if he hops on a plane, I know this sounds pretty extreme, but if he hops on a plane and the plane crashes, what the hell happens to me? Because I rely on him so much. Like, he is my absolute rock. He does everything for me. He lifts everything. So I honestly don't know how I'd survive without him.
Did you want the others to answer that same question? Or?
Yeah, if the others have anything to add.
Look, I think with the cost of mine, I live in a small rural community, so I see a psychologist nearly weekly. It's costing me about now that my mental health support plan has finished, which you only get the 10 for, it's costing me about $240, $250 a week in mental health support, which I am very, very lucky that I can afford that, but it is a huge burden on myself and my husband. When I was actually looking at transferring to another hospital, I actually reached out, because of my background, I reached out to a private company to transfer me, and that was going to cost like $2,000-$3,000. So, it's all implicated, I guess. Yeah.
Thank you. That's really extraordinary, and I'm just thinking about the impact that this sort of injury would have on someone without the financial means to actually seek all of those supports. It's quite astounding.
Absolutely, and I guess that was one of the reasons that I put in my recommendations about the government care plan, because at least as a start, you can access more kind of allied health professionals, but we need to look at exactly what is required, and it's totally individual. Everybody's injury impacts them in a different way. So they need a different range of practitioners.
I was just going to say, short of pursuing legal action like one of the other witnesses does, there is no way that most people can afford to fund this kind of recovery. And also the mental trauma that going through legal action and the dragging out of the worst moments of your life, but not just at that point in time, but prior to that, they'll drag you out through everything because they want to avoid paying. So really, you're in a no-win situation. Yeah,
and you also then have to go through a lot more appointments.
And they're just dragging everything out.
Thank you.
Definitely.
Yeah.
I recognise we're running tight on time. I've got one quick question for Ms. Yazdani. Yeah. You called for specialised care for refugees and women from other countries. Specialised maternity care. Can you talk a little bit more about what you would hope that would look like?
I think the hospitals need to have a program or something like that to, when a refugee person going to the hospital, a pregnant lady from multicultural background or refugee background goes to the hospital, they need to refer them to that ward, and they made the plan for them. I could remember they referred me to the social worker. They gave me a card and they asked me to call her. I called her, I introduced myself, and I asked about help and any support, and she never called back to me. And she was social worker. She was there to help me, to support me. It was her job. She get paid to do that, but she never back to me. I think we need to do something about that to the hospital, to follow the people like me, the people who English is not their own language. And just, I think they need to, some people, they need more information before birth, having birth training, and we need to do that in their own language for them. And also, I could remember after birth, I still have back pain. It's been 3 years. I need to use pain relief every single day. Without pain relief, my life is like nothing. I cannot do anything. And I remember for a few months after birth, I was crying to do my things, my normal things. And I didn't have any support. No one wasn't at my place to look after my baby, to take me for the appointments. And I think they need to do something about that, to look after those people. And also the other things I want to mention, is I remember I asked them to, I cannot clearly remember what I asked the midwife, and she was telling me, if you need this one, go to the private hospital. And I was thinking, this is not my answer. Go to the private hospital.
Can I just say something on that?
Yeah.
I birthed in a private hospital. I would have preferred to birth in a public hospital.
Can you
I would-
expand a little on that?
I don't feel as though, well, I was moved to the public hospital eventually once my son needed level 3 NICU. But when I was birthing in the private hospital, I was subject to poor ratios. I was also part of a burnt out monetized system, and they just did not have the expertise, nor did they have the resources, the mental health resources like social worker, any kind of mental health support. To deal with a complex situation that I found myself in, and they probably haven't seen it in years. They didn't know the next steps to move me to the next facility. They had no idea. And I don't work as a registered nurse anymore. I'm an early childhood educator now, but my background was complex case management. And they had absolutely no skills in it. And I was left in the hospital bed doing my own complex case management to get myself moved to my son. Yeah.
Excuse me, may I say something else?
Quickly, yeah.
I think the nurses, the midwives in the hospital, they need to care about people. They need to be respectful. They need to be responsible. As I was a nurse, I worked as a nurse for 8 years. In my own country, I know how to care about people, and I know how they have to treat. I think it is very important. It doesn't matter which color your skin, which color your hair, and which color your background. It is very important to do your job, your responsibility, and your everything for everyone. We are all humans, and hopefully someone can hear us.
Yeah, thank you.
Thank you.
I do have one very quick question. We have gone over time, but I do have a question for Rochelle, if that's okay.
Yep.
Just in regards to being separated while your son was rushed away, I know one suggestion has been that that mothers are able to sleep with their sons if they're in an emergency space. Is that something that you would like to see as a recommendation, or is it something you've heard of happens anywhere?
Absolutely. NICUs are tight. My son was in a level 3 NICU, so this is where the sickest, most babies in the whole entire state are. There's not a lot of room for me to sleep down there, but I guess my recommendation is that most hospitals that we birth in don't have a level 3 NICU. There's only a couple, I think, in Sydney. And if it is warranted that the child needs to be moved, the automatic response is that the mother is moved as well, because the trauma that I went through because my son was on the other side of Sydney and I had my husband was there. I had nothing. I felt the most alone I have ever felt in my life, and those nurses just did not care. They told me that I was a burden because I fought for myself, because I didn't lay down and take it, and I'm here today because I'm not laying down and taking it anymore. I'm never going to have another child because of this. And it's their fault. And I hold them fully responsible. I can't go through the legal system. I don't have it in me. But I can stand up here today and say what happened to me should not happen to a single another woman in New South Wales.
Thank you. Thank you, all of you today, for coming here, and it's very brave of you all to come and share your stories. Look, there might be some questions on notice. I feel like we've sort of run out of time on this session. If there are questions, the Secretariat will be in contact. And thank you again so much. The evidence that you give today has been heard. You've all been heard today here, and it will go towards the recommendations from this inquiry. So thank you.
Thank you.
Thank you so much. Thank you. I now introduce Ms. Amelia Batt from Maternity Consumer Network. Ms. Batt, could I please ask you to state your name and position title and state either an oath or an affirmation?
So my name is Amelia Bard. I am the president of the Maternity Consumer Network, and I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you. Would you like to start with an opening statement?
Yes. I just want to thank the committee for inviting the Maternity Consumer Network to give evidence today. So the Maternity Consumer Network is a not-for-profit organisation founded by Alicia Staines and other consumers in 2015. We are a maternity and birth advocacy organisation. We are now one of the largest consumer organisations in the country and have successfully advocated for the creation of the National Women-Centred Care Strategy, are involved with trying to implement Medicare for midwives, and we liaise with other maternity organisations. Most of our work comprises of advocacy support and referral services to women who are victims of obstetric violence or need help navigating poor maternity care and understanding their rights.
Thank you. We're now going to ask some questions. I might start with a few, and then I'll look to other committees to ask questions as well. As you mentioned, in your opening statement and also in your submission, that you created a training workshop program, the Better Birth with Consent, and it's now been endorsed and it's being used in Queensland. Can you tell us a little bit more about this course, why it's important, and if that's something that is missing in New South Wales?
Absolutely, I do believe it is something missing in New South Wales. So I believe our founder, Alicia Staines, made a submission to the Governor-General in Queensland under women's safety to get funding for this training, and basically it's about, it's run with a lawyer from Human Rights and Childbirth, Bashi Hazard-Kumar, a perinatal psychologist, Heather Matner, who has midwife training, and then Alicia Staines does the consumer side of it, and it covers from the consumer perspective how birth trauma and obstetric violence affects them. Then we have the psychologists go through also again how it affects them from the psychological standpoint, and then we have Bashi, who covers women's human rights and basically understanding women can have the right to decline care and maintain their bodily autonomy. So that's the course in a nutshell. Why I think it's important is even with feedback we've gotten from the course and relevant to New South Wales, we find a lot of clinicians do not understand consent, and a lot of them, I think it's a societal problem that comes into medical care, but a lot of them think that women lose their bodily autonomy when they're pregnant, and that in an emergency that they don't have the right to say no. This is despite the fact New South Wales Health does have a very thorough consent manual in Section 6 and Section 10 that does outline women's autonomy, but as an advocacy organisation that has helped other midwives and nurses when I mention it to them, their response is usually, what manual? New South Wales has a consent manual. And they're very surprised to find out that women can say no to certain things. Yes, we really endorse this training to help them understand consent and women's human rights, and how, I guess, when those rights have been compromised, how it can affect women.
Absolutely. Thank you. We've heard quite a bit of positive feedback about Queensland generally in terms of reforms they've made around maternity care and informed care. Is there anything in Queensland that you believe is working well that we should be implementing here in New South Wales?
Sorry, could you repeat that?
We've heard quite a bit of positive feedback about some of the reforms that have been put into place in Queensland around maternity care, and I'm just wondering, was there any that you had noticed that you feel that are missing in New South Wales that we should be?
I think the reforms is the hospitals that have engaged our consent training have been giving us feedback that it's, I guess, had a positive impact on their workforce, and their, I guess, the clinicians are actually making efforts to make sure they have respectful communication and get women's consent. And then some of the feedback we've had from women that, like, things have changed for them, and they're finding, at least in antenatal care, they're being given better information, and providers are careful to actually get their permission on things. So that's what I would say one reform I've seen that's better there. Others I'm not so sure about, so I might have taken on notice.
That's okay. That's okay. We've also had some submissions through in this inquiry. We've had a lot about continuity of care, and some of the submissions say that continuity of care can never be guaranteed in the public health system. It's not something that we can ever that it's a gold standard, but it's not feasible. It's not possible. I just want to get your thoughts or your response on that, and whether or not you, because I think in your submission you actually had a suggested goal of 80% of public hospitals to have continuity of midwifery care by 2030, and I'm just wondering if that's an achievable goal, and how do we get there?
I do think it would be tricky to get there just because of the way the system is set up. Internally, I'm not sure how they would do that, and the reasons they give for not being able to implement it. But giving women access to MGP programs has slowly been rising. So many years ago it was 8%. I'm hearing it's getting closer to 20%. So it's slowly rising, and they're able to do it. I'm guessing to get it is just to, I guess, encourage midwives to want to go in there. I believe there is research, I'm not 100% sure, but that a lot of midwives, when they come out of uni, maybe it's from a survey, that they were interested in that kind of continuity of care, but that doesn't become apparent for them later down the line. So I do think it could grow, and it has been growing. So I guess some hospitals in Queensland, I believe, has been managing to do it, but it remains to be seen how they would implement it in New South Wales. I'm not sure of the actual number of access at New South Wales specifically, but there is that rise we're seeing.
Yeah. Thank you. And obviously, in regards to the complaints process, and working with the HCCC quite often with your organisation, do you think that complaint system is working, and if not, what needs to change to support women through that process?
Okay, so that system is not working at all. In every complaint I've ever lodged, and I've lodged complaints where there has been some severe acts of violence against women, even with a witness, like a doula who's given their version of events. Now, I understand they're not a court of law, but most of the responses I get back recommend no accountability, not even that this midwife go and take some training, nothing. And often I have to warn women, look, I can write this complaint for you, but you need to be prepared for a very poor response. And it concerns me because this lack of accountability, not even recommending training or even to hospitals to do X, Y, and Z, means the health services aren't improving their services, and this situation continues. And we get worried about providers who are very concerning, who have done something quite violent to a patient, isn't being taken to court by the Healthcare Complaints Commission, and that they're still there being able to do things to patients that they're not supposed to be doing. So that system, I believe, does need a huge reform. in terms of accountability, and at least making recommendations for changes in staff training, and if I guess as evidence, taking what they do is they do take some clinicians to court, as I understand. But no, the system's really poor at the moment, and it's pretty demoralising having to have that conversation with women, that the chances of anything coming out of that complaint are very low. Group complaints are a little bit different. I do find in some cases, whether to a hospital or like to a regulatory authority, they do tend to yield a better response and make recommendations. So I guess power in numbers, but I shouldn't have to I guess get a group of women to do that.
What system would you like to see instead? Like, I know that on day one of the hearing we had a suggestion of a legal clinic set up to support women. Other people have talked about, reviewing the policies and the procedures around hospital complaints. What would a change in that position look like to you?
That's a really good suggestion, but I would also, again, doing the complaint process, I find the investigative officers in the Healthcare Complaints Commission don't really talk with the patients to get their perspective or clarify things. As far as I know, their investigation is just looking at a clinical notes, and if the clinical notes say this didn't happen, it didn't happen. This is even if you have witnesses, a couple of them, the woman's partner or doula, and the woman herself saying X, Y, and Z, they don't communicate at all. So to kind of get the story, that's just kind of how they, at least how it appears they're investigating. So communicating with patients would be a big one for changes. I do think that other suggestion was good, it might be a stretch, but I think it should be considered some sort of a government-funded independent service to help navigate them through the complaint processes. We do it, but we are an underfunded, under-resourced organisation. We can't keep up with it. I do the majority of it, and I'm one person serving all the women in Australia. Most women I have to turn away and just kind of quickly guide them through the process.
Thank you.
A couple.
The Honourable Sarah Mitchell.
Thank you, Chair. Just a couple of questions coming from your submission, if that's okay. You said that you've got about 1,000 members and members' organisation. That's across Australia. Do you know, and it's fine if you don't, but how many in New South Wales? Like, is that a big proportion of your membership?
No, I wouldn't know how much we had in New South Wales specifically.
Yeah, no, that's okay.
Sorry.
That's all right. And then I just wanted to ask about where in your submission, I think you talk a little bit about, I guess, informed choice and consent. That's quite a common theme. You wouldn't be surprised across some of the submissions and the witnesses that we've had, and we've been looking at whether there are things we could do to improve that antenatal period and the information that women get, while not frightening them, but also making them, I guess, more aware of what could go potentially wrong or complications. From the experience of your organisation, what do you think would be some of the things that we could recommend to improve, particularly that information that women are getting before they give birth that might help them when they're in that situation?
So I do find that sometimes by choice and sometimes because of the way the system is set up, there is this inability and sometimes failure for providers to give women informed consent and education, which they're supposed to as per their legal obligations and professional standards and codes of conduct. Antenatal care as it is, it's usually here, take these tests, and then there's no communication about why they're doing this or education about interventions in birth or what to expect, and that's pretty common from our organisation's perspective. And the problem is, even if the women we find when we get complaints ask for information, we get some women told, like, I guess it's omitted or it's downplayed or overplayed, or it's from an emotional perspective. So they'll say, let's say a woman who wants a VBAC and the hospital doesn't support that, they'll tell her your uterus will rupture and you will die, instead of having a respectful discussion. Well, these are the risks of a VBAC. These are the risks of a repeat cesarean. And giving them a resource that doesn't happen. So in terms of I think to help that antenatal period, I do think staff need training on respectful communication and how to give that informed consent, because that is lacking, and it's, I guess, understandably, maybe they have their own trauma and they see something like a bad outcome, and that affects them being able to give women information effectively. So I think they just need training on how to actually give the information. That's a problem. In some places, I understand it's been told to us there's time constraints. At least in the public system, they're seeing so many women, and they only have like about a 15-minute appointment, and then they can't give that information. I do think giving women information sheets with links and resources can help, that are consumer friendly. Obviously things will need to be designed for culturally and linguistically diverse women and women who don't speak English. And I do think health providers should also encourage self-education from relevant places if they can. So women can come back and actually ask questions, because there are some women who obviously trust their provider that's doing right by them. And in part of our submission, unfortunately, we've had providers, I guess, prioritise their own agenda, sometimes by choice, sometimes through no fault of their own, from pressures from the system to schedule an induction for staffing or something like that. And so the women think, okay, yes, there's a real medical reason for this, and that hasn't been the case. So we think encouraging women to ask them questions, encouraging women to also educate themselves, which is important for their own birth, would help in those antenatal appointments.
I think I just like one more. And then in the postnatal period as well.
Yes.
Thoughts on ways that could be improved in terms of information care, sort of postpartum issues?
So with the women who access continuity of care, they have 2 weeks worth of appointments from their MGP midwives. But unfortunately, I find with the community midwife program, which is the general program they send to some women 3 days post-birth, that's also really quick. So I would also kind of recommend the same, actually sitting with them and talking with them about what to expect. And also, again, giving that information and numbers to call, but go through it with them, not just throwing the papers at them. And it's very clear what these services offer. I know a lot of women, I get sometimes in New South Wales, they get like this information pack, but how many of them read that or know that these are services to call, how it's important? I don't know if someone's not actually telling them. I think it helps to actually have someone tell, hey, we do actually have these support services. I'm happy to help call them for you if you feel you need them, that kind of thing, to help get that education and that there's all these support services out there, postpartum early, instead of waiting until they've realised there's like an issue. That would help. But yeah, all that communication. But again, I acknowledge there's also that time constraints, and to help women get the education and knowledge they need.
Yeah, thanks.
Dr. Medicon?
I'm interested in your submission. You talk about a trend of focus during pregnancy or during birth on the well-being of the fetus over the well-being of the birthing parent.
Yes.
It's something that's come up in other evidence as well, and I was wondering if you could speak to that a little bit and perhaps give us some examples that you've heard from your work.
Okay. So it does go back to a little bit what I said before. I understand, obviously, women want a healthy live baby out of their birth, but there becomes a problem where we feel that providers forget the woman is their main patient, and she actually takes priority. And unfortunately, despite Australian, I guess I understand it as case law, women's autonomy is paramount. So, and like I said, with the New South Wales Health Consent Manual, women can make a birth decision, even if that choice does result in a bad outcome for them and themselves. So the problem we have is during birth, one of our complaints is, for example, there was, fetal tones were going down on the CDG monitor, and the doctor wanted to do a forceps delivery. The woman has said no, and then she's held down by midwives and has that forceps delivery against her will and often without pain relief. This is contrary to, I guess I understand, as Australian law and their human rights. They have the right to say no and risk the outcome of refusing that intervention. And I do find a lot of, again, prioritising the fetus over the woman's autonomy is the issue. That's what we're trying to explain with the consent training, that, women can make those decisions you may not like, and that's what we experience. Sometimes it's not a case of the actual fetus being in danger, but women are told they have to make this choice for the sake of their baby. So I guess a provider will tell them the baby's stuck when it's not, and they have to do an episiotomy. The woman says no, they cut them anyway, again without pain relief. And then when women complain, they told them, well, they did it to save their baby. even though women, legally speaking, have the right to make a decision that could result in a poor outcome. I'm just going to say not many women are going to make that kind of choice, but it is important. You still have to get their consent in those scenarios, and they can say no. I understand. I'm not sure about New South Wales because I haven't seen a guideline. I know Queensland has guidelines on partnering with the woman that declines recommended maternity care, and they have advice on what to do in an emergency situation when a woman is declining that life-saving emergency treatment. And that's what we are kind of going over. The other thing from our organisation's point is we find that the health and well-being of the baby is the only thing, I guess, they consider prioritising the baby, and not so much what the mother wants and her emotional health. So, for example, I'm trying to give an example. I guess it would be a woman's, I guess, similar, trying to make decide things outside of guidelines. So, wanting to decline, again, certain tests. It's not going to result in a bad outcome. She's just, I guess, declining something. Again, she's told, we're going to call child protection, or you're not prioritising your baby, you're selfish, at these emotional responses. And so it's not putting women as centred at the centre of care. Or we will have women who, in later pregnancy, are put on a CDG monitor. They might have high risk factors, not told why they're on there for hours and hours on end. And they're asking, like, what about me? I want to do X, Y, and Z. I don't want to be on these CDG monitors for hours on end. And they're told all that matters is a baby, and that makes them feel like their wishes and needs don't matter. And when they try to question that, they're treated like they're selfish, or that they're just they want to kill their baby, which obviously isn't true. They've just made that informed decision for themselves, but that's not being respected. So that's kind of what we mean with the fetus being prioritised and the woman not being prioritised.
The Honourable Anthony Diadam.
Thank you for your submission and your attendance today. In your submission, you make a recommendation about creating laws to criminalise obstetric violence.
Yeah.
Can you first just explain what you mean by that term?
So we follow the UN's, definition, and that is the abuse and mistreatment of women in pregnancy, birth and postpartum. My legal understanding is very limited here. But when we say laws against obstetric violence, it would be specific to pregnancy, birth, and postpartum. Simply, in my limited understanding of law, a lot of any kind of medical abuse or negligence cases, often when people have to go to the civil arena. And when women are assaulted in childbirth, so for example, again, forced into a forceps delivery when they've said no, had a episiotomy against their will, that is assaulting someone. And we do believe women should have an option, I guess, in the criminal arena under specific laws to try and get justice. I do understand criminal system has a very high standard of evidence beyond a reasonable doubt, so I'm not sure the particulars how that would work, but we do think some of them should be held accountable in that way for a very severe kind of act of violence that's obviously resulted in harm and things like that. And I guess that's what we mean by laws against obstetric violence. We do police reports for women, but often they don't go anywhere. Often the only place we go to is the police sexual violence unit. If they've a woman's being assaulted, had fingers inside her against her will, has been given an episiotomy, again, forced interventions into her genitals. That's kind of where we go, but it is still a bit separate from, I guess, a sexual assault. And I guess as far as I'm aware, it hasn't really gone anywhere to court, maybe from a lack of evidence, or there's just no specific laws against it to do anything with it. So women have to try and rely on the civil arena. But we do think laws, I guess, would hold people accountable and understand that it's not okay to assault patients in childbirth.
Why do you think that criminalising obstetric violence as opposed to dealing with these cases through the civil, why do you think that would be more effective in terms of achieving outcomes for women?
I guess it's another way to hold someone accountable, and I guess it's just, I could argue, a common sense thing. Assaulting someone just because you're in a medical setting doesn't give you permission to in any other context. If you assault someone, if you put something inside their genitals, it's assault or sexual assault, and you get reported to the police, and you go through the justice system to be held accountable. Obviously, if that depends on the evidence and what happens there. It should be the same for women. Should have that option to seek their personal justice through the criminal justice system. When that happens to them, it's not okay that it can only be a civil thing, just because it's in a medical setting and done by a medical professional. They should be held to, I guess, the same standards any member of the public is if they do those things.
Okay.
Can I just ask a follow-on question from that? There's, I think others have talked about these laws elsewhere. Do you know much about that?
I know a little bit. I do know they did enact it in Brazil. If that's had a positive effect or if anyone's been charged with it, I don't know, but they did manage to get it, I think, not Brazil or Venezuela, pardon me. If it's been effective, I'm not sure, but I believe they did fight for it in that country. I might have to take that on notice to see what effects it's had since then.
Yeah, that would be useful. Thank you. And I guess the other follow-up question I have around that is some of the women, in the panel we just heard from, were talking about how difficult it is to take that private legal action, and that for many people it's not affordable. Is that part of the reason why you think that there should be some kind of legislative change so it's available to?
Yeah. Obviously, going through the civil system law is going to cost a lot of money, as from what we understand. I could be wrong about this. I'm just going off limitedly understanding here. From what the women have told us, a lot of lawyers don't take on their case because, let's say, they're upset that a provider did something to them without their consent. A lawyer won't take on a case because the act of the harm wasn't enough. There had to be all these other physical, serious injuries to actually get anything from the civil system. So they have no choice but to go through the complaint process, like the Healthcare Complaints Commission, and hope for something. And so, again, there's that lack of accountability for that provider assaulting that patient. But I am talking about severe cases here. And then, it shouldn't be fair that, there has to be all this injury when there's a wrong being done to you. So I do think more mental health should be counted because as a result of being assaulted, they have mental health problems afterwards, as anyone would after that. And I guess from what we've been told, it's not enough for a lawyer to take on in the civil arena.
I also wanted to ask about funding, and I noticed in your submission you mentioned that Maternity Consumer Network doesn't receive any funding. Do you think that there should be more funding broadly for support services for women who experience birth trauma, and both, for, I suppose, within a complaints process, but also with some of those support networks as well? Is that something that's really missing?
Absolutely, and just from our organisation's perspective, we obviously get a lot of phone calls to help with complaint process, to link them up to support services, but most of us are, unpaid volunteers, very small. Often many of us are just mums using our free time because we're passionate about helping women. So having, I guess, a specialised service of people doing that will be able to link them up better, instead of with our limit having to turn people away or just write a quick email, well, you can go here. Instead of, and I guess having that good support services that's fully funded, they'd be able to, I guess, properly link up, and it would do wonders, I guess, for their mental health to see that people care and there's actually these services being properly linked to. Not just something I've got to quickly write, but just letting, having, I guess, deep conversations with them. And the support services are actually good because sometimes what women are looking for are financially out of reach most of the time, or again, if they're in a regional rural area, they can't access the service. And so we sadly got to kind of deliver bad news. And what we do in that case, we kind of do a call out in the community. Anyone wanting to provide free services, so like a doula, can you cook some food for this mum, or can we be this community support? She can't afford psychological services, so can she come to your mum's circle and have someone to chat to? So we kind of got to make do like that.
Yeah, thank you. One of your recommendations is also to review all the policies and procedures and ensure they enshrine structural support for women's informed consent. Can you expand on this? Like, how are current hospital policies and procedures stopping women from being able to make informed choices about their birth?
One of our problems we have is the term in shared decision making, because the ultimate decision maker is actually the woman, and women have given us feedback when they thought that they couldn't make the choice, and the ultimate decision actually rests with the provider, and we have to come and tell them, no, that's only in an emergency. If you are falling unconscious or unconscious, until then you can decline or say anything. So some of the language there isn't kind of worded for their autonomy. I do find with the policies and procedures, the way I reckon there should be a consumer version. There are some, but a lot of the New South Wales Health policies and procedures that, yes, you can look up, are obviously written for clinicians with a lot of complicated medical lingo. So if you're a woman trying to educate yourself or read this policy, it's very long, full of that medical lingo, hard to understand, and it'll be easy if there's like a smaller consumer info sheets on it. They do have some, but not for everything. And why I believe also policies and procedures need to be reviewed is just to be keeping up with evidence, because I guess some policies are not caught up with the best evidence, or just need to be reviewed a bit more frequently. And I guess what we mean by that is also to have staff training on some of these policies and procedures. Again, we've helped midwives who have come to us, and when I do complaint letters, I have to pull up policies and guidelines, and I tell them, did you know New South Wales Health had this and that? And they were surprised. There's actually a whole clinical guideline or a policy or a procedure on it. So it's a bit worrying that the staff that work in the system who have come to us for help as a consumer don't even know this. So policies and procedures are great, but then I guess they don't mean much if there's no training on them. And that's what we mean by they should be reviewed.
Yeah, thank you. I suppose as part of this inquiry, the committee will put together a report with a whole range of recommendations. I'm just wondering what sort of main top priority recommendations that your organisation sees will make the biggest difference if they were implemented.
We think the biggest thing that would make the difference is some form of consent training, either from us, we have our own, or whatever New South Wales wants to develop, because that's one of the biggest reasons our organisation gets called. They did things without my consent. I didn't know I had these rights. So I do believe there's consent training based on the New South Wales Health Consent Policy to the staff about women's rights in pregnancy, their consent, and I really do feel they need an emergency section. It's been a while since I've read it, so if they've updated, then I guess disregard. But when I did check the New South Wales Health Consent Manual. Unlike Queensland, there isn't scenarios for birth, which can be tricky. They have scenarios for other situations if a patient's declining something, but there isn't that scenario for birth. So I think they need advice on what to do in XYZ scenario, just like I guess Queensland has. And I think that would help, and they can, support women's autonomy, be able to respect their consent, and I believe that would help alleviate birth trauma if the woman's made the choice, of her own volition.
Absolutely.
Yeah.
Was there any other questions, Mr. Benazir? No. Okay, good. I've got one more question. Obviously, your organisation was heavily involved in collating and submitting a large complaint just recently with and I think you mentioned over 30 women for one particular hospital. Is the stories of birth trauma, is it isolated to this one hospital, or is it something that your organisation has been hearing across New South Wales and across Australia? Issues of birth trauma.
So these birth trauma we hear across Australia. I will say what happened with that hospital was one of the worst, just for the fact that it was so many in so little time. Normally we'll get, we get lots of complaints about disrespect, but the more severe cases where there's been like assault and negligence, we'll get like a few here and there around Australia, a couple a year from a particular hospital. But with this particular hospital, it was so many. I do want to point that out, and in such little time. A lot of women had given birth between 2019 and 2022. So that particular hospital and district was concerning. I do understand regional health also has, in general, that's where a lot of our complaints come from, regional, rural as well, do have a lot of issues with having as much services or equipment or staff compared to the city. But look, we do hear birth trauma stories, obstetric violence stories from all over Australia. We weren't expecting, when we made that complaint or call out for women, we weren't expecting that though. just to be clear, yeah.
Okay. Actually, just a follow-up question in regards to regional and rural hospitals. And it's something that's sort of been briefly mentioned throughout this inquiry, but what sort of recommendations should we be making that would be specific to regional and rural areas and the support that's required there? I mean, I know that there was an inquiry in the last term of Parliament about the impact of staff shortages and everything was kind of magnified when it came to regional and rural areas. What sort of specific recommendations would you like to see from this inquiry to support women in regional and rural areas?
I guess accessible transport services, because a lot of women, I do think a lot of get risked out. We don't agree with some of the reasons they're risked out, but there's a lot of, I understand, bureaucracy in the level of the hospital and what they will take on. And then some of these women live very far away, 300 kilometres or more, having to make arrangements to go to a hospital. I know in some cases, I'm not sure specific to New South Wales, but I'll just make a comparison. I know in Queensland, up in Cairns, and women in more rural areas like in Cooktown, they have to get on a plane they get supported to get on a plane at 36 weeks, but they've got to make their own arrangements for accommodation, and you can give birth between from then on 37 weeks at term to 42 weeks or onwards. That's like 4 or 5 weeks, trying to make accommodation unless the hospital lets you stay there, and they might not be able to, because of bed arrangements. So there's not that accessibility. For some women don't even have that plane service, and some places, I'm guessing, same in New South Wales, and they've got to make these accommodation arrangements to be near the hospital. And then what happens is a lot of these women are being recommended inductions, and it's not for a clinical indication, it's just for a convenience. Unless they're happy to do that, that's not a problem. But then women who are not happy to do that, they feel like they have no choice because they don't want to be stuck birthing so far away from a hospital and something going wrong. So some sort of, accommodation accessibility service for those women would be the issue in regional rural health in terms of access. And of course, there is an issue with staffing. I do think there needs to be ways to, attract staff and midwives especially to these regional and rural areas, and find out why the staff don't want to stay there, or they're having staff attrition, or they're just not, people just don't want to work in these places. So some incentives there, but for the women, accommodation and transport.
Fantastic, thank you. Was there anything else that you wanted to put to the committee that you felt hadn't been asked in a question?
No, I'm good. Thank you.
That's all right. Fantastic. Well, thank you so much. You did take a question on notice.
Yep.
So the Secretariat will be in contact with you in regards to that, and if there's any other further questions that the committee has to ask, the Secretariat will be in contact. But thank you again for coming in today. I know it was a bit of a trip for you to come into Sydney, so we really appreciate it, and thank you for your evidence.
Thank you for your time.
Thank you. The committee will now break for a short morning tea break.
just saying that's what it is.
Great. Thank you, and thank you both for coming today. Before we begin this session, I just remind witnesses to avoid referring to specific names, hospitals or medical facilities in their evidence, and to speak generally about the issues raised in the terms of reference. Could I ask each witness, starting from my left, to please state their name, position, title, and swear either an oath or an affirmation?
I'm Sharon Coulter-Stollier. I'm a PhD candidate, a midwife and an author. And I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you.
I'm Rakim Elmi, and I'm a senior lecturer at Western Sydney University School of Nursing and Midwifery. I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you so much. We'll now start with some opening statements. I might start with Dr. Elmira, if that's okay.
Sure. Before I begin, I would like to pay my respects to the traditional owners on the lands of which we meet, and pay my sincere respects to elders past and present. I recognise their continued connection to the land and waters of the place and acknowledge that they never ceded sovereignty. I would also like to thank the Select Committee for the inquiry into birth trauma, which will no doubt shape and change the provision of maternity care in New South Wales. I present my evidence to you today as a Muslim woman, a mother, a midwife with 20 years experience, an academic, researcher and advocate for migrant, refugee and Muslim communities. I'm also here to give voice to the forgotten partners, that is fathers that are all too often sidelined in the maternity care system. In 2021, Islam was the second most common religion in New South Wales, and according to the 2021 Mothers and Babies report, women born in Southeast Asia and the Middle East accounted for the highest proportion of births. Published and anecdotal evidence highlight the systemic, cultural and spiritual barriers for women and their partners accessing individualised, culturally safe and sensitive maternity care. We know from existing research Muslim women have been stigmatised, stereotyped as oppressed, uneducated and most importantly disempowered from openly and freely practising their Islamic beliefs. Women and their partners are not being difficult. All they are after is compassionate and culturally sensitive care. Our maternity care system needs to understand when a maternity care provider cares for a Muslim woman, they are caring for the entire family. The woman's family is her community. Her community is her village that protects, supports and nurtures her. We need a system that empowers Muslim women to make informed choices and decisions that are culturally and spiritually appropriate to her needs. Our hijab, the veil on our heads, is our shield that empowers us and gives us strength and comfort in times of hardship. We feel more at ease donning our hijab, listening and reciting Quran and praying. Our spiritual needs are nuanced and complex. We need maternity providers that understand us and are sensitive to our processes and timelines, particularly during traumatic events such as stillbirths and neonatal deaths. Due to our beliefs surrounding death, time is of essence. We need to see a Muslim chaplain as a matter of urgency. We need to have family present around us to comfort us. And we need to bury our precious one as soon as practical. We want to see the midwife after we give birth. We want to speak with a counsellor or psychologist and have an opportunity to debrief when appropriate. Let's not exacerbate grief and trauma for women. We have evidence of Muslim women refusing to book into hospitals due to the systemic bias and previous trauma experienced. We have Muslim women accessing more midwifery continuity of care models such as MGP and private practicing midwives, and we have more Muslim women request a doula to accompany them to the births, to their own births for a more positive experience. Women know what they want. Let's not forget our fathers now. I have looked at the impact of birth on fathers for the past 10 years. Existing research I have published highlighted that men are not prepared, particularly first-time fathers, for the events that may unfold at the birth, yet expected to be present and support their partners. They are excluded from decision-making processes and often feel out of depth. They feel helpless, emasculated, and merely as a bystander, yet they so desperately want to be involved as parenting partners. For our culturally diverse fathers, they experience additional challenges such as employment, financial pressures, and socio-cultural expectations, particularly around gender roles, and seeking support for what many cult fathers described as taboo. These challenges impact on men's mental health and well-being and their transition to parenthood. 1 in 10 fathers experience postnatal depression. But why don't we hear about this? How can we reduce the incidence of depression and the impact of birth trauma on fathers? We need father-inclusive maternity care where fathers are welcome and support is available for mothers and fathers. Why is it that inclusivity of women and their partners stop at the doors of maternity? How can we reduce the incidence of birth trauma in culturally diverse women? Continuity of care models are great, but they need to be publicly funded, accessible, and holistic, and they need to be equally distributed across districts. We need more culturally diverse midwives caring for our cold women. We need cultural and religious processes and guidelines in place to support women's journeys, particularly in times of adverse events. We need a maternity care system that supports mother, father, and baby. We need cultural competence training mandated across New South Wales for maternity care providers, and this needs to start with our midwifery students. We also need support for midwifery students and midwives caring for women to retain our midwifery workforce. Care cannot be optimised when we have skeleton staff and midwives that are burnt out and run down. We need change now, not for us, but for the next generation of birthing women and their partners, for our children and grandchildren. Thank you.
Thank you. Ms. Sharon Colton-Stollo.
Thank you. Before I begin, I'd like to take a moment to acknowledge the traditional custodians of the land on which we gather today. I pay my respects to the First Nations people who have cared for this land for thousands of years. I also acknowledge the elders, both past and present and emerging, who have stewarded this country and their rich culture through generations. It's a privilege for me to have been able to grow up here in this country since the age of 5 and make the most of the opportunities available to me. I also want to thank the brave and courageous women who spoke up and raised their voice and were the catalysts for this inquiry. I honour you deeply. I must first offer a disclaimer and clearly state that what I'm going to say are my own views. I am not representing nor speaking on behalf of any organisation today, workplaces or universities that I have previously graduated from or am currently enrolled at. I give evidence here today before you as a midwife and a nurse, a PhD candidate and a Sri Lankan migrant who's experienced birth trauma and clinically diagnosed birth-related PTSD. In my submission, I've detailed my personal experiences of birth trauma, from having my excruciating, agonising pain ignored and dismissed until it was far too late to prevent permanent damage and lifelong physical and psychological consequences. I wasn't listened to at such a crucial point of my life. When maternity care providers don't listen to women, there is a cost. The impact of not being listened to, not having my pain addressed properly, and not being believed when I complained of pain was that I had an acute compartment syndrome that was left undiagnosed and untreated, causing permanent nerve and muscular damage in my leg. Undiagnosed and untreated acute compartment syndrome almost always results in amputation. I'm fortunate I didn't lose my leg. I was highly dissatisfied, disappointed, and angry with the postnatal care that I received.
Over the years, I've reflected a lot about my experience and even published a book called Scars of Gold, which is about my experience of birth trauma through the eyes of a midwife. I've learnt a lot and read a lot of research on birth trauma. I'm still learning. But knowing what I know now, particularly about the experiences of childbirth in women of colour, I would like to make some further comments in addition to my submission. And please bear with me because this is very important that you hear this. Australian research has demonstrated that First Nations, refugee and migrant women from non-English speaking backgrounds have poorer pregnancy outcomes and lower satisfaction with care than women from the general population. In the research, immigrant women have said that health professionals, as in maternity care providers, do not always remember them between visits, do not make an effort to get to know the issues that are important to them, do not keep them informed about what was happening during labour or take their wishes into account. A qualitative evidence synthesis of 27 studies which represented women from 42 different countries of women who gave birth in Australia has found that migrant and refugee women experience hostility and discrimination in our maternity care system. They have described a sense of being unwelcome, talked down to, treated differently from Australian women, and made to feel like a nuisance. Anecdotally, there are insinuations made about different groups of women from different cultures. For example, oh, she's a typical Indian or Sri Lankan drama queen complaining of pain with a low pain threshold. Call it hostility or discrimination, call it whatever you want, but let's call a spade a spade. This is racism. Australian research has also found that maternity care providers often lack adequate cultural knowledge. Some hold stereotypical assumptions, and the healthcare system in general is not culturally responsive. Even the maternity care providers have admitted to this. In recently published research about refugee and migrant maternal health in New South Wales, maternity care providers themselves have described witnessing displays of judgment and bias in their co-workers. One midwife has been quoted in this one particular study saying, "There's a lot of racism in health sectors. I've seen it quite often working as a midwife." So whether we like to hear this uncomfortable truth or not, implicit bias and systemic racism exists in our maternity care system. Even though I was a midwife, gave birth in the hospital that I trained to be a midwife at, grew up here, has an Australian accent and am highly educated, I still wasn't listened to and I didn't have my pain taken seriously. I have often wondered if the stereotypical assumptions of people from my cultural background and race played a role in being dismissed and not having my pain addressed. According to the latest AIHW data, the 10 most common maternal countries of birth were Australia, followed by India, New Zealand, UK, China, Philippines, Vietnam, Nepal, Pakistan, and South Africa. Furthermore, of those born in Australia, 5% of women identified as being First Nations. In New South Wales alone, South Asia, as in the Indian subcontinent, women who look like me, visually look like me, was the second largest region for maternal country of birth, accounting for 9.2% of all births in New South Wales. These statistics should illustrate just how many women of colour are giving birth in Australia, specifically New South Wales. While Australia, however, might hold the largest maternal country of birth, we don't actually know how many of those categorised as Australian births were second-generation migrant women of colour whose cultural backgrounds play an important role in their transition to motherhood. To highlight my point, I'm going to share a comment posted on my own social media from a woman who has a very white-sounding name, but is a second-generation migrant from Sri Lanka. That means she was born here to Sri Lankan parents. Here is what she says. I myself have experienced the racism you speak of, from back when I was a child to even now. I have a running joke with my white husband that I must be invisible because people walk into me, I get ignored for other customers, or I'm immediately placed into the category of I can't speak English and I'm likely uneducated. Even in my care on the postnatal ward, the same thing happened. I received better treatment when my white husband was present, but when he left, I was ignored and had horrible insinuations made about me. For data collection purposes, this woman was categorised as being born in New South Wales and still experienced racism in our maternity care system. This experience of racism in the country of her own birth caused birth trauma for her. And she's one of many women like that. According to the latest ABS data on our last census night, more than half of our population in Australia, that's 51.5%, were first or second generation migrants. If 1 in 3 women experience birth trauma, and more than half of our population is made up of first or second generation migrants, then we really need to begin to talk about colour in maternity care, and we need to consider the importance of culturally safe maternity care to reduce avoidable causes of birth trauma for First Nations, migrant and refugee women of colour. We know that this group of women would benefit the most from continuity of midwifery care. The last 2 hearings have made a clear case for midwifery models of care, for continuity in order to prevent avoidable causes of birth trauma. But although there have been major efforts to increase midwifery-led models of care in the last couple of decades, specifically continuity of care for women, the findings from 2 consecutive population studies in Australia show no change to immigrant women's experiences of care. And so I raise the following questions here to you. Are we encouraging migrant women to choose continuity models of care? Do they know about midwifery group practice? Is our advertising of these models inclusive? When I say inclusive, I'm meaning do posters around the hospitals, digital media and information sheets about this model of care visually represent the migrant, refugee and First Nations women of colour who could benefit the most from these models of care? Do they know you pretty much need to book yourself into MGP the moment you get pregnant in order to get it? Or is that little piece of knowledge a luxury afforded to those who sit on the lucky ledge? A luxury afforded to those who have health and language literacy, autonomy and agency to research the best models of care and navigate the system to get it? I'll be blunt and say that we don't live in white Australia anymore. This is 2023 and we live in a very multicultural and multi-religious Australia. But we have a maternity care system that systematically fails to take into account the cultural needs of almost half of the population it serves. We need more maternity care providers who are midwives of colour in our workforce. We need a workforce that can more accurately represent the population it serves, because feeling able to identify and connect with one's maternity care provider is very important if women of colour are to feel comfortable, confident and able to ask the necessary questions about their health care, if they're able to feel comfortable to express what they want for their pregnancy, labour and birth experience. Feeling able to identify and connect with your care provider, especially when you're in the ethnic minority in a traditionally white country, is very important. As Antoinette Lattouf says in a book, it really isn't rocket science, it's just social science. So, if we work on encouraging and supporting people of colour from different cultural and religious backgrounds to choose midwifery as a profession, then in the long term, we'll see midwives of colour in our workforce. We'll see a midwifery workforce that reflects our population. We'll have more women being able to visually relate to their midwives, more culturally sensitive and culturally safe care, and less avoidable causes of birth trauma. We might even hope to see more midwives of colour in academic positions across universities. But in the short term, there are easy solutions to this. Basic cultural training and education to maternity care providers would not be difficult to implement. A recent study of New South Wales recommends that we need to understand the needs, experiences and identities of refugee and migrant women. But without education and cultural training, it is absolutely impossible for white midwives from Western countries to understand the significance of cultural practices, heritage, religion and family relationships for women from different cultural backgrounds, especially when they're becoming a mother. I myself have developed a very basic short course on culturally sensitive postnatal care for women from the Indian subcontinent. And something like this could be very easily expanded into other cultures and used to educate our midwifery workforce. This is just one example of something that's so easy to implement, and we could see immediate changes in how this group of women perceive their overall experience. So to finish, I just want to remind everyone here today that there are numerous examples from community development projects in Australia where well-meaning white project teams have gone into rural First Nations communities with the aim of implementing a health intervention program but found themselves to be unsuccessful. During the planning and implementation stage, they failed to include stakeholders from within the community they aim to serve. In the same manner, we cannot address this issue, this horrible issue of birth trauma in all women and birthing people unless organisations, committees, policymakers and people in positions of power listen to, include and ensure input from women and people of colour who understand the cultural context and nuances of the First Nations refugee and migrant women. It's clear that implicit bias and systemic racism exists in our maternity care. Maternity care policies and guidelines created by well-meaning white people in positions of power systematically do not adequately address the needs of women of colour. I urge this committee to listen with their ears wide open and ensure you seek appropriate involvement and input from women of colour from different ethnic backgrounds during the process of making recommendations from this inquiry. This should include women and people from different religions and faiths as well. I note here, based on what was being circulated on social media, that the advisors to this committee did not include any people of colour, not visually at least. I am here only because of the fierce advocacy of Sharon from Better Births Illawarra and Alicia from the Maternity Consumer Network, who both separately wrote to the committee to urge that I, a midwife and woman of colour with a lived experience of birth trauma, speak here today. So I must emphasise again that a failure to seek input from women of colour when recommendations are made from this inquiry will only further perpetuate the systemic racism and implicit bias that currently exists in our maternity care system today. Thanks.
Thank you. They were both very powerful opening statements, so thank you, both of you, very much. I'm looking to the committee. We're going to be throwing some questions around. Wonderful. Thank you. The Honourable Sarah Mitchell.
Thank you both for your submission, and I echo the Chair's comments. They're really powerful opening statements, so thank you for being open and honest and giving the committee guidance as to some things that we can look at. I want to start with you, Dr. Almira, and you spoke a little bit about it in your opening submission, and it's in your written submission as well, just about the role of fathers and greater awareness and support for them throughout, I guess, the entire process of pregnancy and birthing. What do you think are some of the things that the committee should look to recommend in terms of how we can better engage partners in the process, the information about what may happen, particularly when there are sort of traumatic birth experiences as well? Any sort of suggestions for the committee to consider?
Thank you for the question. I think that's really important. When we're looking at supporting fathers, it's really important that we look at how can we engage fathers in the maternity space, and it's really important to engage them from the beginning, so perinatal or antenatal education. A lot of the antenatal education at present is at a cost, and so that's a financial burden for many fathers and partners. And so I think having that accessible for fathers and after hours, because as we know, fathers work, are the main breadwinners. And so I think something after hours would be quite ideal. And having more consumer organisations that fathers can tap into and are aware that that's a form of support, because from the research that I've conducted, many fathers don't think any support's available, even though it's come a long way since I first began my research 10 years ago, and so there's a lot more consumer organisations. But my recent study around culturally diverse fathers does suggest that there's still really nothing available, or it's not being publicised, it's not being advertised that that's something that they can go to for support.
Yeah, and I was going to ask particularly around culturally diverse families as well. There's a gap there you would perceive in terms of the information that particularly is available to fathers?
That's right, particularly when it comes to the availability and accessibility of information in their own languages. So when we're looking at migrant and refugee fathers in particular, they want something as well that's accessible, that they can go online and access, and that's really short. So I've recently developed some videos in in partnership with a consumer organisation, and that's just really short snippet videos that they can just go online and access those videos and have a look at the lived experience of culturally diverse fathers, for example. So they're just the sort of innovative ways that we can try and get fathers to really access this type of support.
Okay.
Yeah.
I have one more question as well, Chair, to Mrs. Colton-Stollier. Just in relation to, I thought in your written submission when you spoke about how when you're at work in your uniform and badge you were listened to, but when you were like, that was really powerful, so I thank you for giving that, because for me particularly, and you said, for women who don't have a medical background, how would they feel when you felt like that as someone who was educated and knew exactly what you were going through? So I thought that was really pertinent point that you make. But particularly in relation to investing or making sure that we have more midwives of colour and working in hospitals so that you've got that cultural awareness and that continuity of care. I don't have a medical background, but I'm curious, do you think that there are any sort of, again, practical recommendations that the committee could be making in terms of, making midwifery more attractive to people of colour? Is it scholarships? Is it training? Like, what could we do that you think might help us to get more culturally diverse people into the midwifery sort of career?
Thanks for the question. And there's actually, I think, a few layers to that, because you first need to look at, let's just focus on my cultural background from Sri Lanka, and that's the Indian subcontinent. You need to understand the cultural nuances there as to why we don't have many women like me from where I'm from being midwives. So you need to understand how midwifery and nursing is seen in those countries. And migrants are coming here to give their children a better life, generally speaking. So, what they know is your professions such as being a doctor, an engineer, a lawyer, accountant, they're going to set you up with a good life, a good future, a good, viable, stable income. So that is what they know, generally speaking. Okay, so if we're going to try to encourage people of colour, students of colour, coming into the university system to do midwifery, we need to have education out into the communities. I think in the long term, I think it needs to be planned. For example, schools, but also in the communities for the parents of those children, students in the schools, to actually present midwifery as a viable option with a decent income and job stability, and you can have a great future with it. So that's one aspect where that's something we need to tackle. But I think we also really need to pay attention to the differences in the ATAR cutoffs. Midwifery is ridiculously high when you compare it to nursing. We have so much more diversity in our nursing students in universities. And if you just look at, if I make a very generalised comment, midwifery is white. Midwifery students generally are white and English speaking, and by default they have a better command of the English language. And when you have such a contrast in the ATAR, to get into midwifery compared to nursing, you are, like, if you look at midwifery, you are disadvantaging people from whose first language is not English, just by default already. So we need to look at that. We need to look at why midwifery is so high and what's the difference. Like, is this the thing about valuing lives? I don't know. I'm just putting it out there. But if we want more people of colour, migrants, refugees, whose first language isn't English, we do need to implement some kind of access schemes. We need to implement support and education. We really do, because we won't see a change. Our universities, faculties are white as well, mostly in midwifery. So, there's a lot to think about. There are a lot of things that need to be done if we're going to get more people of colour going into midwifery whose first language is not English.
Yeah, thank you. That's useful. Thank you. That's good.
Can I just, just a question following on from my colleague. Do you have any stats on the number of nurses and midwives that are from non-English speaking background? And you may not have it at hand, and if not, you could take it on notice.
I don't think we collect that. I don't think ARPA collects that.
No.
Have you ever been?
That's
No.
Me either.
Sorry. Yep, that's fine.
The Honourable Emily Savell.
Thanks, Chair. Thank you to you both for coming along today to give evidence to this inquiry and for your submissions. It's a really important perspective for us in terms of making recommendations. I just wanted to ask quickly, which you've touched on briefly, about the need for better education for our workforce. But is there, if you were to recommend anything in the antenatal period, and I know Dr. Emily, you spoke to this briefly about education methods. What is it that would be ideal in terms of the mode of education, how they could be provided, and do you have any suggestions about sort of topics that should be included or how we can improve in that way?
Sorry, do you mean antenatal education
Yes.
for partners,
For
fathers,
generally,
Okay.
with specific focus on culturally and linguistically diverse peoples. Yeah.
I think, look, there is a current module, providing culturally sensitive care module for all nurses and midwives to complete, but that's general. It's really generalised. I think there needs to be a specific training targeting maybe the main populations, the main groups, particularly around spirituality. I think that's a really important factor to consider, and many, rightly so, many people are not very comfortable. They can't possibly be well versed in every culture, every religion. But I think if you give them the tools and education around maybe the main populations, and also some of the cues to look out for, because as Sharon highlighted, it's really about, and even if they don't have that education, really, do we need education on how to provide, just humanistic care? And if you're unaware, when I used to work in a very large tertiary hospital, very culturally diverse, you would ask the woman and her family, okay, what are your cultural needs? What can I do that will make you feel comfortable and safe? And I think, beyond training, just ask those questions, and that makes a real difference. And we really did hear that from our consumers this morning.
Yeah.
Thank you.
In terms of antenatal, look, I think if we're going to look at culture, Western culture, compared to non-Western cultures, again, I'll just deflect to what I know from my culture. We value community, we value family involvement from the beginning. Western culture places a high premium on autonomy, agency, choice, independence, self-sufficiency. So we've got all very good things, but realistically, when a woman has a baby, she wants help, she needs support, she needs connection. So we've got this maternity care system where I've seen it time and time again, with very well-meaning, amazing white midwives telling women from places like Sri Lanka, India, now I know your parents are going to want to come in and get involved and do this for the baby, but set your boundaries, keep them at arm's length, and it's not good. That causes so much trauma and conflict, because from a Western perspective, that's seen as a good thing, to do it all yourself, to be independent. But from my perspective, we don't see it as a bad thing. We see it as our culture. There's nothing wrong with that. We don't see it as anything like, oh, we need to keep our parents away, our sisters, brothers. We don't need the help. We've got to do it ourselves. So that causes such a chaos and conflict internally, and the damage it can do to relationships and within the family dynamic, and often that's all you've got, your immediate family in this country. So if we're being told, and I say we as in other women like me, we're coming from a cultural background. I was raised here, but to a culture, my parents are from, they're here, with that culture in my household. And then I'm getting information like, keep them away because that's good, that's better for you. And the conflict is enormous, and it's that kind of information and training that needs to go to our maternity care providers, because they don't know this, they don't realise it's causing trauma and harm and issues down the track. Because I'll just put it out there, midwives and obstetricians and nurses, we don't go to this profession to cause harm and trauma. It is not what we go to do. So I think it's more a matter of educating how the impact of their actions impact on the women. And we've got this really romantic idea that midwives, we are equal to women, right? That we're equal to women, but the reality is they are not equal to women. They hold so much power over a woman and her family and her life that it can make or break her. And it's when maternity care providers realise that and are made to see that power that they have, that's when change happens. When we engage them from a perspective of kindness and compassion and empathy, and have that heart connection with them, that's when change is going to happen, right? So I think it's more, instead of saying you are doing this wrong, you are causing trauma, or instead of painting them all with the same brush, that you are all perpetrators of obstetric violence, I think we need to take it back a step and approach it with kindness and compassion for our care providers as well, because they're stressed and exhausted and understaffed and burnt out. So we need to see it from both sides of the coin.
Thanks so much. And look, that's something that we certainly heard a lot in evidence earlier on in the hearing about care providers. Nobody goes to work intending to cause harm. So thank you. And I just wanted to acknowledge through you, Chair, that the Minister for Health has just walked in the room. Thank you, Minister, for attending today. In terms of one of your earlier statements as well, I just wanted to ask a question. You mentioned the ATAR for midwifery, which is quite high. As we know, ATARs come about, it's a supply and demand principle, right? So more people want to get in, there's less spots. Do you have any thoughts or considerations around perhaps overcoming that obstacle?
Look, at my university where I work, it's not just the ATAR as well that makes it difficult. It's also based on an interview process, so they have to get in based on ATAR or equivalent, and also do really well in an interview process where they sit a number of stations and they're marked on their performance. So, look, I think there's always scope to relook at that type of approach and see how we can have a more diverse group of midwifery students enter our workforce. Yeah.
Sharon, do you have anything to add?
Look, I can't speak from a university perspective, but yeah, I'll echo what Rakeem said, but I don't know if it's having different pathways to get into midwifery, having more positions open to get into midwifery. There are a lot more positions in nursing, in the Bachelor of Nursing across the universities. Yeah, look, I don't think I can comment further about that from my perspective, yeah.
Thanks so much. Thanks, Chair.
Thank you. I'd also like to thank the Health Minister for joining us. So welcome here today. I know both of you have done quite a bit of research in this space, and so I wanted to talk to you both a little bit about some of that research and some of those research findings that you think could be useful for the committee here today. I might start with Dr. Elmire in regards to your research around dads and support for dads and what some of that research findings are.
Okay, sure. So sorry, what is it in particular you would like to know? The demographics, how the fathers were
Just
selected, or how
Sorry,
they...
more about the findings of your research.
Okay.
So with some of those research papers, what were some of those key takeaways from the actual research findings that you think could be useful for this committee and recommendations for the inquiry?
Yeah, sure. So really what interested me in looking at fathers was my primary research, my doctoral work, and during the interviews with mothers who had quite a traumatic experience, and that was focusing on women who had a severe postpartum hemorrhage and emergency hysterectomy. And throughout the interviews with the women, they were mentioning how distressed their partners were, so the fathers. And so that prompted me to look more into fathers' experiences of witnessing traumatic births. And some of the findings from that research back almost 10 years ago now really did highlight how unprepared fathers are when they enter the hospital system. So many want to be present, but they just feel really underprepared. And it doesn't matter how much reading they do or how many people they speak to, other peers, fathers they speak to. They enter the room as really an extra person, and they don't really feel included as part of the maternity system. They also did mention that they would like antenatal education classes to be run by male educators. So many parent education classes are being run by females, and some fathers thought that was okay, but that was just one of the recommendations fathers had, that they be run by male midwives or male facilitators. Now, male midwives, females dominate the midwifery profession, so they're very limited. But definitely, I think male facilitators, that's something that could be possible. And the other thing was that they really did value peer support and support from consumer organisations, particularly our culturally diverse fathers, where it's often taboo to talk about birth and show those signs of weaknesses, and them needing to uphold those roles of masculinity and being the protector and the supporter. They did really find a place of solace with these peer groups. And they also suggested that parent support groups don't tend to include fathers because they are mainly female dominated. So fathers then are excluded, particularly our stay-at-home fathers. So I think support groups tailored for fathers is definitely a need. Yeah.
Thank you. Miss Colton Stella, sorry. I know you're doing a lot of research as well. I'd be keen to hear more about the research that you're involved in.
So my research is, my PhD research is on midwives' own experiences of pregnancy and birth and how that experience impacts or influences their professional practice. So that's what I've been doing for the last 7-8 years. I've published a couple of papers. So one of the papers one of the findings was that midwives generally have the chance to choose their individual care provider. So 75% of this national survey were able to pick exactly who they wanted, which is a professional privilege that women in general don't get to have. But 45% of the midwives in this survey actually got continuity of midwifery care, whether that was a private midwife or whether there was MGP caseload midwifery. And what we can see there is that, with those numbers, and most of them, I think about 86% birthed at hospital, so 11.2 had home births, which is so much higher than the general population. But even with the majority birthing in hospital, we had a normal birth rate of 66%. 16.3 had instrumental birth and 16.8 had a caesarean, and they were all for medical reasons. So big differences really in the general population. But again, that all comes down to having a known and trusted care provider, because these midwives in this survey chose those care providers based on having prior professional relationship or a personal friendship, but they'd already established a trusting relationship, which is continuity by default, right? So that's one of the papers. I am in the middle of publishing a couple of others. I can't give out all the details yet, but in terms of birth trauma, PTSD and postnatal depression rates in this cohort of midwives, those numbers I'm seeing are much higher than what we are seeing in the research for the general population. So that is definitely, when that paper comes out, will definitely come with recommendations. But it's something that we do need to think about, because if we have, so we've got midwives who are traumatised by witnessing trauma, but if we have midwives who have birth trauma from their own experience and then are coming back to provide care to women we need to look at the impact of that on midwives, because there is nothing really in place at the moment to help midwives process, debrief, bracket their own experience before they provide care to the wider population of birthing women. So there is some need to look into midwives' own well-being when they come back to work after giving birth.
Thank you. And can I, if that paper is published before this inquiry completes, could I invite you to submit that to the committee as well?
If I can get that
yes,
one.
If it happens. I've just got one more question. I know you've spoken online about the intersections between systemic racism and birth trauma, and I know you touched on it as well in your opening statements. I'm just wondering if you could unpack that a little bit further for the committee around some of your observations regarding racism, but also, like we've talked a lot about education, but whether there's other recommendations that you'd like to see from this inquiry as well. And I think I'll put that to both of you.
I think that education is really important. I go back to your point, education and training. And just merely, we live in such a culturally diverse country and we're so inclusive, but for some reason in maternity that tends to change. And so it's just really a continuation. And you think the most vulnerable time in a woman's life and a partner's life, things tend to change. So definitely education and just being inclusive of different practices, and we really should be embracing diversity in our maternity settings, and the diversity that women and different cultures and religions bring. I think that's really important. In terms of processes and guidelines, there needs to be clear processes and guidelines for certain adverse events around death and dying, particularly in maternity. And there needs to be more support for culturally diverse communities, because that is really diverse in terms of how different communities process really the processes around that. Yeah.
Thank you.
I think so. I don't think there's been a lot of research done in Australia in terms of racism, specifically in maternity care, but discrimination, hostility, it all comes down to it. There is research in the UK and the United States specifically talking about this very explicitly, and these are other traditionally white countries with a large population of different people of colour, different ethnic backgrounds. So I think we can start to look at some of that. And that research is showing that women of colour, black, brown women are experiencing birth trauma on a high rate than white women. So it is there. I didn't refer to that in my speech today because it's not Australian research, but I think also just what Rakeem said, like even if we take race out of it, we take culture out of it, I think the bottom line is common sense, and I think it needs to come down to conscious maternity care, which is what I talk about in my book. And it's really just common sense. It's about, we're conscious about our eating, we're conscious about everything else in our life, and maternity care providers need to remember their actions and their words, their non-verbal cues, non-verbal communication. That matters. They will forget what they do and go home and come back to another set of women and families the next day. But the women that interacted with them will remember that interaction for the rest of their lives. And I think it's just about, like, we need to, maternity, again, education, but it's common sense education. They need to be aware of their own biases, beliefs and fears and their own concerns, realise that their words matter. Every single word that's uttered in that room, the facial cues, the expressions, they all matter, because that's how women will remember that experience. They need to mind their body language, the frustration. Yes, they're burnt out. yes, they're exhausted, and that is a system issue. But on an individual basis, you know, we can make, maternity care providers can make little changes immediately that can see big changes for women immediately as well, you know, and most of all, they need to remember empathy. They need to think about how they would feel receiving the care that they're providing, I think. So that's what I would, I think education on that to maternity care providers is absolutely crucial, and I think it could be done really easily and fairly quickly and would see changes immediately.
And would you advocate for funding for research in Australia so that we can get some of that data?
Absolutely, absolutely. Funding goes without saying, or maybe I should say it. We need funding to look at birth experiences of women of colour, different cultural backgrounds, ethnicities, races, and to see what it is, especially if our Australian population is made up 51% is first or second generation migrants. I think it's really time that we look at that.
Yeah, absolutely. Dr. Amanda Conn?
My question's just been answered.
Is there any other committee members seeking?
Just if there's time, I noticed you spoke a bit earlier about continuity of midwifery care, which is something that's come up a bit in this inquiry. How would you define continuity of midwifery care that you would like to see provided?
Me or?
Both, sorry, open to you both.
Do you want?
Look, for me, it's a one maternity care provider providing care for the woman and her partner from pregnancy right through to the postnatal period. And so the same care provider and potentially, hopefully, in a few years, the same, culture from the same culture as well. I think that would be wonderful. Yeah.
Yeah, I would echo what Rakeem has said, but I would say that it should go up to 6 weeks at least, because those are such crucial weeks, and really that's when the mother has become the mother. That's when she needs that support, that extra support, and it's always, we know it's always better from the same care providers. So really, privately practicing midwives would be amazing. Or if we could implement some kind of model of care that sees women get that all the way through, even within a hospital setting, because let's face it, 97% of women in Australia give birth in hospital. So while it would be absolutely ideal and amazing to have MGP, private practicing all throughout, we need to see what we can do now in the hospital to, as it is right now, to make change now and not just in the long term when we do one day get all those ideal models of care in.
Yeah, look, I think you both raised very important points, and in a perfect world, it would be the same maternity care provider throughout. Indeed, from the same culture. We have heard other evidence in this inquiry just about some of the complexities with midwives being unable to work the requirements of a 24/7 on-call roster, which is, as you would know, a requirement often with the midwifery continuity of care models. How would you propose, just in terms of recommendations, how would you propose that we kind of balance both of those, respecting midwives' personal caring commitments? They're often working mothers themselves, and their caring commitments and work-life balance, when, in order to achieve that goal, it would require them working an on-call roster.
Yeah, I think you would look at like a shared model. So I work really closely with our midwifery students, and I facilitate their clinical placements across New South Wales, including rural and remote. And many of them want to be placed in a continuity of care model because they want to experience what it's like. And I always have a debriefing session with them and brief them beforehand, just so that they are aware of what the model involves. And many are not are not aware of they need to actually be on call pretty much 24/7, and so then that's just a bit of an eye-opener for them. But in terms of addressing your question, I think there's definitely a need for this, and we heard this from this inquiry, but potentially a shared model would work well. We know our culturally diverse communities often see their GPs because they speak the same language, they're from the same culture, but the only barrier there is that loss of continuity when they enter the hospital system. So potentially having our GPs enter that hospital system so that the woman sees a familiar face would work quite well. Otherwise, in our MGP models, I think, working with, on call, working in a shared model may be the way to go.
Sharon, did you have anything to add?
No, not in addition. I agree with Raquel there.
Thank you. Thanks.
Thank you.
Thank you, Chair.
Wonderful. Well, thank you both for coming today and providing your evidence. It's been very powerful evidence and very, very useful for the committee. So thank you both so much for your submissions and also for coming in today. If there is any questions that the committee has to give to you on notice, the Secretariat will be in contact. And thank you both again.
Thank you.
Thank you.
Fatima, can you hear us?
Yes, how are you?
Wonderful, thank you.
Thank you. I now welcome our next witnesses. I know that we have 4 witnesses in the room and we have one on teleconference. Before we begin this session, I just remind witnesses to avoid referring to specific names, hospitals or medical facilities in their evidence and to speak generally about the issues raised in the terms of reference. I now invite each witness, starting from my left, starting inside the room, to please state their name and position title and swear either an oath or an affirmation.
So left would be me.
Yasmina Bayraktarovich-Hayward. I'm the Community Services Coordinator at the Service for the Treatment and Rehabilitation of Torture and Trauma Survivors. I'm a social worker. I have worked in this field since 1994. I'm also a person with refugee background who has had experience of giving birth in a New South Wales hospital. An affirmation: I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. Ms. Gould?
My name is Deb Gould. I'm a South African trained general nurse, midwife and clinical psychologist. I've been working in Australia as a registered psych at the Service for the Treatment and Rehabilitation of Torture and Trauma Survivors for the last 25 years with Yasmina. And my role there is I'm a senior consultant. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Ms. Metwally?
Good afternoon.
Hi.
My name's Yusra Metwally. I'm from Zamzam Mums in my capacity as advocacy liaison volunteer. I also come here as a mother of a 4.5-year-old who birthed in a state hospital. I'm giving an oath today. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you. Ms.
Hi,
Bourne?
my name is Saltanat Bora. I am a co-founder of the mothers group Zamzam Mums and Bumps. I am a mother of 4 and have birthed in both public hospital and in a home birth context. My oath now, I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you. Dr. El-Assad, I think you might have been emailed the oath or the affirmation. Are you able to give that for us now?
Sure. I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. And do you want to give just quickly your name and position title?
Sure. My name is Dr. Fatima El-Assad. I'm the director and founder of the Still Nest, and I'm also a senior research associate at the University of New South Wales.
Thank you. I now open to witnesses wanting to give a short opening statement. Is there somebody from the STARTS organisation? Yep, thank you.
So, STARTS would like to thank the New South Wales Select Committee for undertaking this inquiry into birth trauma and for the invitation to provide evidence to the committee today. We have been supporting survivors of torture and trauma in the context of organised violence and state terrorism since 1988. Majority of our clients have arrived to Australia under the Refugee and Humanitarian Programme, and in over 3 decades we have assisted to over 80,000 individuals through our different services. You have our submission, so what I will bring today is I'll just take a moment to discuss a case study of a client. The name has been changed and identifying details have been changed, but it is an example of something that has happened. So Zara is a young woman who is seeking asylum in Australia. She has witnessed violence, experienced persecution herself, and has experienced numerous accounts of sexual abuse. Zara is the mother of 2 children. Her first pregnancy took place in Indonesia, where she was living alone. During her pregnancy, she had intense fear of birth. She feared that she would die at birth and worried of who would look after her baby if she were not to survive. For 8 months, Zara lived in Indonesia alone with her son. The 2 of them resided in an unhygienic and unsafe room. Zara did all she could to support the needs of herself and her baby to survive. Since then, 3 years have passed, and Zara became pregnant again, and this time she was resettling in Australia, or residing in Australia. During this pregnancy, Zara began to recollect the fears and anxieties of her first pregnancy. When attending appointments for her pregnancy, she would feel uncomfortable when male practitioners were present, due to her previous experience of sexual assault. Zara's history of trauma, isolation, and stress manifested in high anxiety and low mood throughout her perinatal period. For Zara, there was lack of awareness or consideration made to her previous experience and trauma, as this was not reported to her pregnancy care professional. They were not aware of Zara's previous experience of trauma, and she was not aware of how health system works in Australia. For women like Zara and other clients at Starts, the experiences of traumatic events often occur over prolonged periods of times. These experiences of trauma are compounded by the impact of loss, grief, dislocation, and cultural dissonance. Therefore, in addition to the recommendations we made in our submission, we further recommend to the committee the need for the implementation of trauma-informed care for all those accessing maternity care, including refugee clients. There is a need for a robust system to be put in place that ensures that the principles of trauma-informed care are adhered to in practice. This will ensure that those accessing maternity care have the capacity to freely and clearly communicate with healthcare providers, where they have informed choice and control. And it will ensure health professionals and care providers have an understanding of and capacity to respond to when faced with interconnected or compounded experiences of trauma, including birth trauma. Thank you.
Thank you. Was there an opening statement from Zamzam?
Yes.
Yep, thanks.
We have two, if that's okay, me and yourself.
Yeah, that's fine.
I'd like to first acknowledge the traditional owners of the land, the Gadigal people, elders past, present and emerging. I thank you, the Inquiry Committee, for inviting Zamzam Mums to this hearing. My experience in this space comes from being a founder of a grassroots mothers group. It also comes from being a mother of four myself. In 2019, two fellow mothers and I came together to create a support group for Muslim mothers in southwest Sydney. We believed there was a gap in support services for women from this background. Data from our own research, which we show in our submission, shows that 80% of the women that we surveyed had not attended a playgroup at all. Although it was also a playgroup, activities were organised for children. Primarily, the group focused on creating a safe space for mothers to share their experiences of pregnancy, birth and child rearing in each monthly session. More than this, however, we wanted to engage in discussion of issues mothers face in an honest, sincere and meaningful way. To achieve this, we engaged professionals in the field to discuss a wide range of topics such as nutrition, motherhood, positive parenting, balancing religious practice with parenting, and so on. Sessions included dhikr at the onset, which is a recitation of religious litanies to connect to our Muslim identity. Each session was an open discussion where we sat in a circle on the same level with mothers rather than speaking down to and throwing facts at them. Mothers were welcome to contribute to the topic in a conversational manner. As each session wore on, we found more and more women sharing candidly their experiences of birth trauma, of neglect in postpartum care, of a lack of knowledge about the physiology of birth and breastfeeding, of the purpose and consequences of intervention. Most women expressed dissatisfaction with their birth providers, sharing heart-wrenching stories of bullying, of cultural and religious values not respected, and of experiences with postpartum depression due to these incidents. Not only did women feel safe in this space to share these stories, but individual experiences of birth trauma were validated by what they shared with each other. This brought women back month after month. This helped the process of postpartum healing, acting as a tool for mothers to find support in this oft-neglected time. Some months into the project, however, we realised that it was not enough to support mothers in this postpartum phase. There were too many ongoing issues of birth trauma being shared, and it was at this point that we realised that expecting mothers, first time or not, needed a support group of their own. To this end, we created a second monthly session entitled I'm Expecting, Let's Chat, which aimed to provide birth education support to expecting mothers. These sessions focused on understanding or educating women about the physiological stages of birth, partnering with pelvic physiotherapists to speak to women about pelvic health and how to prevent prolapse, the importance of focusing on a positive mindset going on to birth, discussing birth plans, and so on. We also discussed how to advocate for our specific cultural and religious needs as Muslim women. We engaged doulas and other professionals in the field. It gave mothers an opportunity to connect with these professionals, and some of the mothers who attended our sessions went on in their births to hire these professionals and had more positive birth outcomes. And then after they gave birth, they attended our mothers' sessions. So it was like a full circle experience where we were able to help mothers in their pregnancy, in their expecting phases, and then afterwards, after they had given birth. These sessions emphasised the importance of birth education that was framed with a positive rhetoric, not one based on fear, that focused on the dangers and risks of birth. A core message we wanted to deliver to attendees was that having a healthy baby at the end of the birth was not the primary goal, that the health of the mother, her emotional and physical state was just as important. Unfortunately, with the disruption of COVID and a lack of funding and volunteer base, Zamzam Mums has not been operational at its former capacity. We believe that community services such as Zamzam Mums can provide culturally specific care and detailed and empowering education to birthing mothers who are not receiving supportive, positive and culturally nuanced knowledge and care from public and private hospitals. Furthermore, community groups such as Zamzam Mums can work in conjunction with hospitals to help provide this culturally specific training. We have seen that a systemic change in the broader public and private health model is required to address birth trauma, as most women who came to our groups who had positive birth outcomes sought help outside of the system. The term Zamzam comes from the well of water that God provided from the dry desert for our mother Hagar, Abraham's wife, in the valley of Becca, or Mecca known as today, after she ran from hill to find help for herself and her infant son. It represents our spiritual connection to a mother who did not give up in the harshest situation to provide for her son. With her efforts and unfailing faith in God's mercy, the spring of life-giving water, which still runs today, was made hers. Although our situation as birthing mothers today in New South Wales appears dire, the thousands of submissions to this inquiry is proof of this. We take strength from our ancestral mother and believe that unfailing effort and faith in the humanity of people will overcome the lack of political will, embedded systemic challenges, a skewed and damaging view of birth to lead mothers and society to a place of life-preserving, life-treasuring care that upholds the status of women as life-bearers and deliverers. Thank you.
Thank you. Ms. Merwallen?
Good afternoon. I firstly like to acknowledge the traditional owners of the lands on which we meet, the lands of the Gadigal people. On behalf of Zamzam Mums, I'd also like to thank the Select Committee for reviewing our submissions and for inviting us to present to you today. We are sharing today the experiences of culturally and linguistically diverse women based in southwestern Sydney, and we are grateful for the opportunity to be able to share and highlight stories that have been shared with us for the very first time by many women as part of this inquiry. We acknowledge the physical, emotional and psychological trauma that many women and their families have experienced during birth and the re-traumatisation that women are facing as they share their stories with us, part of this inquiry. Standing here today, I also like to acknowledge the birth trauma faced by my mother in birthing me in a southwestern Sydney hospital as a migrant in a new country without many supports, and I did think of her throughout the hearings shared by migrant and refugee women today. Seeking support for trauma does indeed have an element of privilege in understanding the very nature of birth trauma that is only available by virtue of education and informed consent. We welcome the government's commitment to hosting this inquiry and to better understand the nature of birth trauma, especially for culturally and linguistically diverse communities, and we remain hopeful that this process is matched by a level of political will to see a change in policy and funding frameworks to improve the birthing experience for all women and families. My role at Zamzam Mums began as a new mum in 2019, where I was a recipient of the care and supportive space the day after I was discharged from hospital. And there are days I look back on fondly, and I'm glad that I was able to experience it pre-COVID. Our submissions, of course, do talk about the intense level of isolation that many women, including my own sister, who faced when they weren't able to access community supports or family visits while they were in the maternity wards in hospital. And that really just shines a light on the very role of family support that needs to be part and parcel of the birthing experience. As a trusted grassroots initiative, Zamzam Mums was able to receive a number of survey responses, but also there was a level of facilitation that was required to support women in sharing their stories. And one of the things that became very evident is that to formally share a story requires a lot of emotional energy that many women do not simply have postpartum, and many women are not engaging with the formal mechanisms through the hospital process to share patient surveys. And what this really highlights is that there is a need for for feedback to be collated throughout the process, and by really involving patient consumer representatives, and that's a role that I've also played that allowed me to provide support to some of the mums at Zamzam Mums. According to New South Wales Health, providing socially and culturally respectful maternity care assists with ensuring physical and wellbeing outcomes for women, her partner and the baby. Each person accessing maternity services must be respected without assumptions, judgment or cultural bias. Sadly, our survey responses don't indicate that such a level of cultural safety is present. There are numerous case studies which I'd like to highlight to the committee. One of those includes being questioned about domestic violence, a standard protocol, part of interview processes, and when a respondent shared that it didn't apply to her, the midwife went on to add that it's quite common in her culture. Another example is a woman sharing her experience where the nurse was being rude to her because of the way she wrapped her baby culturally. The nurse went on to say, in your culture, I've seen your people do this a lot, but we don't wrap babies like that here. And she was a supervisor. Another story shares a woman's experience who wanted to have a level of spiritual comfort during her birth, during her labour, and the response that she received by having a statement of the written portrait of Prophet Muhammad in her hand, peace and blessing be upon him, was receiving an eye roll from one of the midwives, and that made the woman feel uncomfortable during this vulnerable birthing state. Another issue that's very evident part of our survey responses is that, first of all, from the outset, birthing is a process where a woman is feeling exposed, and this applies to all women, regardless of their cultural and religious background. And it's really important to ensure that a woman's dignity is respected throughout this process by all members of the hospital, from the staff through to the doctors. For many Muslim women who were surveyed for this inquiry, they expressed that observing modesty was a key element of their cultural practice. And a significant portion of them expressed their preferences of interacting with a female healthcare team. Of course, the degree to which the hospitals accommodate this varies between the respondents. And the Muslim women who observed modesty also expressed that they observe religious practices to varying degrees. So for some women, having a female healthcare team is not as important, and rules around modesty are much more relaxed in a medical setting. What's important to note is to ensure that a woman and her preferences are at the centre of interactions, to establish clear preferences right from the very first interaction, and to respect these choices. This is what woman-centric care is all about: establishing effective communication between a woman and her midwife or other health professionals is essential to determining how culturally safe care can be instituted. This essentially highlights the need for a level of cultural safety and competency that needs to be discussed throughout the antenatal care process. In addition to this, we need to see stronger workforce capabilities and targeted recruitment of midwives from multicultural backgrounds. To complement the New South Wales blueprint for maternity care, we also recommend that a strategy is put in place for a culturally safe antenatal and maternity care that reflects the Federal Department of Health's pregnancy care guidelines, Pregnancy Care for Migrant and Refugee Women, which covers a lot of these principles. Our surveys have highlighted 6 recommendations, and it goes into some of the details which have been shared by our survey respondents. This includes highlighting issues that have been discussed throughout these hearings, including funding postpartum support and women's health physiotherapy within antenatal maternity care, particularly due to the fact that accessing women's health physiotherapy often is limited to those who have the financial means through private health insurance. We all know that not having access to these services has long-term impacts for women's well-beings and their quality of life. Incontinence has a long-term cost it's got an economic society cost. And it's really important that women are provided the support post-birth to assist them in their recovery. Our submission also highlighted some of the concerns around lack of mental health support. And of course, Zamzam Mum has played a really important role in providing women with a space to feel that they are part of a village and to access the support that they require. In conclusion, and lastly, partners, again, they play a very important role as part of the birthing process, and there should be opportunities for them to be involved during the hospital stay. This provides an opportunity to be able to take off the pressure of night midwife staff. And of course, we saw the impact of fathers who were not able to be present during the maternity wards during the COVID period, and the mental health impact this had on women. Women have a right to a dignified birth, and we believe in the utmost importance of gentle and a compassionate maternity care system, with the goal of preserving the dignity and honour of women and who bring life to this world, and to ensure that their cultural needs are respected. Thank you for listening.
Thank you so much. Dr. El-Assad, did you have an opening statement?
Yes. Thank you to the Select Committee for the inquiry into birth trauma, and to you, Honourable Emma Hurst, for chairing it. Thank you for selecting the Stillness submission and for the opportunity to represent culturally and linguistically diverse families impacted by birth trauma. I'd like to begin by acknowledging all women who did not get the level of care that they needed, including my own mother, a migrant woman who birthed 6 children with little English in a new country with no support, carrying her own mother's birth history of 17 pregnancies and 5 losses. I also acknowledge all our precious babies and children lost and their bereaved communities. I also acknowledge the diversity across Australia, including our Aboriginal and Torres Strait Islander cultures, their languages and practices, and that it's also vital that healthcare services respectfully manage protocols and provide a culturally positive healthcare experience for all women. I'm a mother with lived experience of birth trauma, early pregnancy loss and stillbirth. I consult on developing national stillbirth research priorities for Australia through my consumer positions on the NHMRC Centre for Research Excellence in Stillbirth Migrant and Refugee Advisory Group, as well as the Stillbirth Research Priority Setting Group. I've engaged with New South Wales Health to develop a statewide educational resource, Conversations about Perinatal Postmortem, and I'm also a policy advisor at the Early Pregnancy Loss Coalition. I founded the Still Nest to support CALD families who had experienced birth trauma, infertility, pregnancy and child loss. Now, this was born out of my own lived experience of birthing my daughter Aya on the 14th of January 2021, still. Although I did experience the best possible clinical care in the worst circumstances, it wasn't until I was being referred onto bereavement support services that my obstetric social worker apologetically said, I just don't have any cultural, ethno-religious resources that I can refer you onto. She was recognising the importance that faith and culture has on our rituals surrounding birth, death and grief. Now, in that moment, admittedly, I did not understand how important this would be in my own journey. We were left to navigate the hospital to funeral to home journey all on our own, and I was unprepared for the physical, emotional and mental postpartum bereavement period. When a baby dies, it impacts the entire community. The mother is central to this. However, the father, partner, healthcare team, grandparents, wider community are also inadvertently impacted. I've actually captured some of these stories, particularly of culturally diverse Australian Muslim women with lived experience of birth trauma and baby loss, and also the healthcare teams who work with them in the first season of the Stillness podcast. The second season, which is recorded and yet to be published, actually explores a wider communities of diversity, including stories from First Nation midwives, multicultural, multi-faith communities, and stories of fathers. I believe that through storytelling, we can actually raise awareness around the nuanced approach needed to support bereaved families from CALD communities, moving towards a culturally inclusive and responsive support system. Many groups of CALD families in Australia are actually at a higher risk of experiencing stillbirths and infant deaths. The rate of stillbirth in women from CALD communities is double the national rate. And this large disparity is not reflected in the number of resources available to women from CALD communities. And unfortunately, the support that is culturally responsive is not available. After listening to the birth trauma stories of my own community and all the brave individuals in this very hearing, you know, I'm reflecting more deeply about the recommendations that I actually made in my submission, and I can just now envisage a much broader recommendation, which is to bring back the mother to the centre of her own reproductive health. I would like to see a version of the blue book we see for our babies, but for the mother. This could be co-designed by mothers and their healthcare professionals. It could begin way back at preconception, where we know that the preconception health is so important to the mother's health as well as the baby's health. We can include signposts in time to actually understand the cultural and spiritual wishes of the woman. It could have signposts for self-directed antenatal education modules, what to expect during pregnancy, what possible roadmaps are out there in terms of navigating the system, at what point different clinicians and practitioners could be useful in their journey. It could also be an inclusion of all the resources that have been mentioned in the hearings in one centralised place, including and not diminishing the importance of postpartum bereavement care in the cases where losses have actually occurred. And this could become the gold standard maternity care or platform or roadmap for New South Wales. The mother could potentially opt in to share it across both the public and private care and with her allied health professionals when she goes to seek that support. It needs to be available in her preferred language and obviously translated back to English for the healthcare professionals to be able to access. It would act as a birthing roadmap for parents, and it would continue to collate subsequent pregnancies and losses. And in addition to this, to echo some of the other recommendations, just a bit more core funding for some smaller community groups like ours who could actually provide those bespoke services needed to support CALD communities, particularly those impacted by birth trauma. Thank you.
Free flow questions, so we'll start with Dr. Amanda Conn.
Thank you. My question is for STARTS specifically. We've had discussion earlier in this inquiry about the need to identify a history of trauma in people presenting to birthing services. So I'm interested in how you think that process can best be done, noting that if poorly implemented, it can end up as just another tick box exercise. So are there validated ways to assess histories of trauma?
There would be many validated ways, but they can be done badly too. And it essentially comes down to the clinician or the practitioner or the community worker being able to engage appropriately and decently with the person involved. Trauma questions can get asked at any time depending on readiness, but usually, because you're asking a kind of technical question in a way, like when do we go in and ask? Usually there would need to be some degree of rapport built with whoever's asking the question, so that it could never really be stuck on a piece of paper that a woman ticks off somewhere. Some places do have those private spaces to indicate trauma, so where the woman's able to, she's informed that if she has a trauma history, she can put a red dot on her thing rather than having to articulate it in any other way. That's one possibility, so a non-verbal option. But I think, look, it's going to come down to the sort of finesse of the interviewing environment, really. Some communities we can expect there's a trauma history, like with refugee women. We expect that there's trauma history, and we're not necessarily talking about capital T trauma, where there's been an incident which is traumatic, but the life of a refugee woman is traumatic. The whole trajectory is a traumatic one. And the issue with trauma is that it sensitizes us to future trauma. So that's why we want to know, is so that A, we don't repeat, but B, we're aware that there might be a heightened response already for that. Yes?
And I mean, it is about knowledge of your local community as a healthcare provider. So it is about knowing who lives in your community, which refugee communities are around, and making the assumption it's better to be safe and say, okay, if someone is from Afghan community, there's a great likelihood that there was some form of trauma. The other way of identifying is, and I know some departments do that, and understanding the visa class system. It's not fail-safe, but if someone has arrived on a refugee visa 200 or they're on bridging visa, it's very likely that there might be a history of trauma. And then it comes to, like you said, the building of trust and a relationship, and that then comes with the ability to communicate to the person and the use of bilingual health professionals, creating cultural safety to start with, use of interpreters and the right interpreters. All of that would allow women to talk about things.
In this respect, we speak about trauma-informed practice, which doesn't say that we have to know the trauma history of every woman, that we make an assumption that it's possible that any woman's had a trauma history, and that we provide our services always. It's always money well spent to be trauma-informed.
And if I can just follow that up, we've also had a lot of discussion in this inquiry about continuity of care, and obviously it's the preference of a large number of people to have either one or a small group of practitioners throughout their pregnancy. I just wanted to clarify, it sounds like what you're saying is an additional benefit of continuity would be an improved ability to build the rapport you need to pick up on that trauma. Thanks.
The Honourable Natasha McLaren-Jones.
Thank you very much. I refer to Zamzam. You've put in your submission one of the recommendations, which is about building on from the blueprint for maternity care and looking at the federal government's health pregnancy care guidelines, particularly around migrant and refugee women. This is a question for all witnesses. It's in regards to the New South Wales government has a number of health plans. We have multicultural health plans, policy procedures. There's also the New South Wales Refugee Health Plan. I'm interested to know, is the issue that there are too many plans, that districts are not sure how to implement it properly, or is it that there are systemic issues within the current plans that need to be looked at? So, just your general views.
I think plans shouldn't be sitting on a shelf collecting dust. So it's about how it's implemented, and there needs to be reporting on those measures and actionable items such as staffing numbers who are bicultural workers, training that's provided to all members of a hospital. And one thing that is really critical is for each local hospital to be very aware of its cultural needs in the local area. So it's a level of really just, looking at a plan and actually breathing it into every single process that is undertaken. So those reporting measures need to be done in a way that are practical and that do see results in for patients and for women. And there needs to also be a way for collecting data around patient experiences in a way that's actually doesn't put the onus on a woman to come back and share her experience. It personally took me 4.5 years just because of this process to finally write an email to share things that I was not happy about with my birthing experience. And I reflect on my privilege as someone who's educated, who's a lawyer, who's worked at New South Wales Health and understands the system, and know very well that for people who don't have that level of privilege, then it's very hard to engage with the system to share your experiences. And so there needs to be systemic changes and systemic reform to essentially change the policy, and the gap between policy and practice needs to be needs to be a lot smaller.
Look, I'm quite closely acquainted with the refugee health plan, and I think as plans go, it's a decent plan.
Okay.
It's a newish plan at the moment, so I think the jury is still out on the implementation.
Okay.
But as far as plans go, the refugee health plan is pretty good.
Okay.
But it is that implementation and practice and making sure that it's monitored, same what you've said. Yeah.
Did you want to ask Dr. Allison as well?
I've got one.
Yeah.
Oh, sorry.
Oh, sorry, just before we move to...
No, sorry, I didn't realise that...
I was just going to ask if Dr. Ellisad had anything further to add to that question.
Yeah, so further to what Yusra has already mentioned, I think it's the implementation of those plans that is quite important. And I guess further to my own recommendation in my opening speech, if women were actually well versed in those plans, they could actually also sort of supplement what is happening in the healthcare system. So it's a collaborative approach to ensure that those plans are actually being enacted. But most of us are so unaware that these plans even exist, and it's only when something goes wrong that we are looking to understand what policies do exist and what plans do exist.
Thank you.
Thank you. The Honourable Anthony Diadam.
Thank you. I'm really curious about the process that was established to get Zamzam mums and bubs up and running. It seems like an excellent model, and I suppose I'm curious about how replicable it is and whether it was just a unique set of circumstances that enabled you to set it up with, people who have a degree of expertise and sort of capability. Perhaps if you could tell us a bit about how it got started and whether you think what the circumstances are that might enable this model to be replicated elsewhere.
Sure. So it was literally three mothers who were friends who had an idea. Obviously that's the very beginning of it, but the practical steps to bring it to life were that because we weren't an organisation, a registered organisation or a not-for-profit ourselves, we allied ourselves with an organisation that already existed, which was the Muslim Women's Association, to be able to have access to their insurance, possible funding, although most of our money came from charging women $10 at the door, and we just raised that money and saved it to basically filter back into the organisation. So funding is a huge issue. All of our volunteer base were mothers who had young children who were working part-time or full-time, so the sustainability of it wasn't feasible given that we didn't have that broader support. Somewhere along the line, the bigger organisation that we had partnered with fell apart, so we lost that insurance. But another thing that we did was to partner with a particular community council, so that we could use their venue spaces, because the biggest practical steps to making it happen was essentially having a space. Was having a space that was in the local area that most women could access. So for us, it was Southwest Sydney, so that it was accessible, we could get prams in there, and it was consistent so that we weren't scrambling every month to ensure that that venue was guaranteed for us, ensuring that there was a volunteer group who could organise registrations of mothers who could come, social media marketing to give alerts about when a session was happening. We made sure that it was essentially the second Tuesday of each month at the same time, 10 to 12, so mothers knew exactly when it would happen, and it didn't diverge from that time either. Other things like trying to organise a childcare worker so that the mothers who brought their babies with them could actually sit and engage in the conversations, and to be honest, that was a problem we could not solve. When you're in a huge community hall, the noise level gets very loud, so you're trying to have conversations with 18-month-olds scrambling over you. So it was important to have an outdoor space that was also accessible for the children, but the mothers could also see the children playing. There were a lot of kind of moving pieces, which some of them we solved, some of them we didn't, but we managed to pull it together, and I would say that it is entirely replicable by any community who wants to provide that kind of a service for their mothers. It didn't take too much for 3 mothers to put it together, beyond having the practical things like the insurance, the venue, and things like that. Like I said, COVID was a huge hit for us. We lost our space. We could no longer come together as a physically. We did Zoom sessions, so that was helpful. We tried to up our social media presence to discuss some of those issues online. And then when COVID kind of fizzled out a little bit and we got to meet up again, we did start the sessions again. But ultimately it came down to volunteer burnout, a lack of money. We lost our sponsorship with the community council venue that I was talking about. Trying to find another suitable space was very difficult. But like I said in my opening speech, it made a huge difference for the mothers attending and for myself. I went on my own journey through Zamzam Mums to kind of understand birth better and have a more positive birth outcome with my 4th. And we saw it in the mothers as well. So yeah, I think it is something that can be done.
Do you think it's
we
something
just need more
that
support.
the local health district should be actively
Yes.
facilitating, or is it something, or would you say that it's critical that it's at arm's length from government?
No, I think that we definitely, and we spoke about this in the 2 years that we were running, that it would be ideal to partner with local health districts, to partner with local hospitals, so that we could reach the mothers who were birthing. So we could reach the mothers who had just given birth, to say, the midwives, to tell them, look, there is this community group for you to go to, and to work in conjunction with them to give them, like we've been talking about cultural training, culturally relevant training. Although we're not experts in that area, we come from that demographic, and our own experiences inform how we are helping these mothers. And we speak about plans and policies, but the experience of the women on the ground is that they are being treated badly, and that's putting it lightly, in hospitals because of their cultural backgrounds. They are not, that is not all women experiences, obviously. There are some brilliant midwives and birth workers who are very accommodating, but the majority of the experience of the women on the ground is that there is trauma related to their cultural backgrounds. So if we were to work closely with hospitals to give them the understanding of how to treat women, understanding what religious rights they may come with to birth. This is what you can expect. They'll come with their little books and their litanies. They may bring a prayer mat with them, and to just have that open communication between a group that's serving the community on the ground in conjunction with a hospital, I think that would make a big difference.
If I can...
no, sorry, you go. I was just going to follow on.
If I can just add one point to what Sultanat said regarding how it would be delivered. I think one thing that I've observed throughout my motherhood career, if I can say that,
it's a career,
is that there is in Western Sydney there doesn't seem to be a huge take-up of parenting groups, and parenting groups. Essentially, this is what Zamzam is doing. It's about providing that postpartum community of support. Now, I only ever knew to join my local mum's group because I was recommended to, but had I not had a friend suggesting that I do so, it would have been up to me to filter through the bags of pamphlets that they give you when you're discharged, and somewhere along the way is ringing the 1-800 number and putting there's such a mental load when you get out of hospital. You've got to register your child's birth and learn to breastfeed, and the list goes on. And so there's such a huge mental load. And in my personal experience, I didn't see that it was encouraged or facilitated for women to attend. Most of the women that I speak to in Western Sydney, regardless of their level of education, didn't engage with their mother's group because they simply didn't know about it. And it's one of those things of, when the onus is on you to pick up the bag and call the 1-800 number, you're not going to really do it. And so it needs to be done in a way where it is encouraged for these spaces to be provided. I also noticed that when I was living between two different LHGs, where some mothers groups, for example, in the Auburn area, weren't running, and there was quite a significant distance of travelling. So I think those groups play a very important role, but we don't see the same level of promotion in encouraging that take up for women, and they obviously play a very important role in that postpartum care. I think like throughout the survey responses as well, there was such a really positive impact of women who've had what we call a redeeming second birth after they've been empowered and gaining the information they've gained from the Zamzam Mums space, the different health professionals, to have an empowering second birth, whether that was going through models of care like midwifery group practice or a home birth, and that's been the core of how our recommendations have been put to place based on the experiences that we saw. Personally, I've in trying to help and assist women in making complaints to the hospital, they also gain the confidence in addressing their needs in the second birth and building that level of confidence. So yeah, there's a lot of work to be done to sort of build that trust in the hospital system.
Can I add to you, Yusra? There's a model in Victoria, the group pregnancy care in Melbourne, which is a partnership and model that was co-designed by a refugee community and the health system. And that model has resulted in provision of care in language of bicultural staff, collaborating with midwives and those groups starting very early on in pregnancy in language with women from that community. So it's collaboration between
partnership approaches are very important.
Between the health system and the community.
Could you perhaps on notice provide us with some information about that particular initiative in Victoria?
Yeah, the program is in our submission, but it's called Group Pregnancy Care in Melbourne, and it was a partnership. There's a reference in our submission by Riggs et al. Where they describe the collaborations and the outcomes of the collaboration, but it was specifically co-designed with the community in mind and the hospital, maternity hospital. I don't know, Deb, is there anything else?
Can I add something about a kind of process and content stuff? That we're talking about information as well as support. And we could easily give all of the information, the technical stuff, which you have said, Zamzam can't really provide. But the local health could provide, but they could completely stuff up the methodology of the teaching of it. And when anyone is provided information in an environment that is supportive, calm, familiar, etc., we learn better. We don't learn, our frontal lobes don't operate when we're under huge amounts of stress. And so there's something about that, whether we call it a sharing circle or learning circle, that facilitates learning of content, so not just the support, which I think would be an important crossover.
So sorry, I know you have a question, forgive me. One of the most important intentions with Zamzam Mums was that it was not a place for women to receive more facts. We were not going to provide women with a single brochure, okay? It was not going to be a PowerPoint presentation with someone standing at the front. It was a circle, very much like how we're sitting today. Oftentimes we were sitting on the floor, sharing babies between us. And the idea was to speak to the mother, not at the mother. And that's a huge difference. And it wasn't, like I said, a fact delivering session. It was building a relationship. It was building a warm environment so that women felt safe. And then when we eventually established the pregnancy I'm expecting sessions, honestly, they were brilliant. They were so brilliant, because the very first session we had was not even what to expect in birth. It was, if you're expecting, come talk about your fears. Just tell us what you've been going through in your pregnancy. Let's just have a session where we get it all out. And that was our very first session. There was no professional expert there. It was just a group of mothers who were speaking in solidarity to validate what we were going through. And then from there, we went to empower them with knowledge that was culturally sensitive, that was positive, that wasn't framed from risk and dangers. And I'm looking at, news headlines from the particular news outlets after the inquiry, and they are still framing birth in terms of the dangers. The inquiry shows that women do not know the dangers associated with birth. We are still using that type of language around birth, and that needs to change, because as a particular doula who came to one of our sessions said, when you frame things from a negative fear-based perspective, you're setting off the fear tension cycle, which results in the physical tension of your muscles, which when you're in birth, it actually slows down labour. You need to be relaxed. You need to feel safe and comfortable in your birth for your body to relax and for that labour to progress as easily as possible. And that was our focus.
Sorry, you actually just answered my question, which is great, because I was going to ask you about the I'm expecting Let's Chat. Can I also just say for the record, I love when you said it was 3 mums that got together that had an idea. I reckon we could probably change the world if we did that a little bit more often. But I do have one other question that I actually just want to ask to Dr. Elazad, and changing to a bit more of a serious topic, but firstly, thank you for sharing and thank you for being so open, and I'm sorry for your loss that you've experienced yourself as a mother. Just when you spoke in your opening statement, and you also mentioned it in your written submission, about that health literacy preconception, and particularly around taboo or secrecy around things like pregnancy loss and stillbirth and what that means in different cultural communities. Obviously, you've been working in that space, which is an incredible thing for you to be doing, given your expertise and your lived experience. But is there anything, I guess, for the committee that we could recommend that might perhaps assist in that space? Have things improved, do you think? Is there more information that is becoming available that recognises, particularly for those from coal communities who have that experience? Is there something there that the committee could look to recommend in your expert opinion?
Yeah, I think that's an excellent question. I love that you're thinking in that way. And I just want to borrow from Sultanat's comments just earlier that sometimes in these communities, we don't need to be giving them a lot of information. It's just to try and create some safety and lowering the barriers for them to access it. And enabling them to feel like they're actually in control of their own journey. So I feel like there's a few things to do before we just jam them a lot with the information. And I feel like that's where the stillness is trying to lower that threshold by, speaking a language that they do understand. And I'm not just talking about a cultural language. It encapsulates a lot more than just that language, is understanding that intergenerational stuff, the trauma, the taboo, the secrecy. So it's about lowering that first and allowing them to feel safe enough and empowered enough to go and access that. And because I do work in academia, and I have dipped in and out of New South Wales Health and a few other organisations, I know that when we do get together to create a project, and it is multidisciplinary, it is crossing a lot of health professionals, we can produce something that is of an exceptionally high standard. But it's no good just having that if you can't get it down to the community that absolutely needs it.
Thank you.
Thank you. I've just got a question for starts, and going back to some of the programs, and I know in your submission you talk about some amazing services in Brisbane and Melbourne, like refugee midwife group practice. Can you tell us a bit more about those models, and if there's anything that's similar that's being trialled in New South Wales, or if they are quite unique?
I think they're quite unique, but did you
I
want
think
to
that they are
describe?
quite unique, and I personally don't have experience of either of them apart from reading the submission. So probably can't add to that. But apart to say that one is a group practice model, and the other, so there's the casework midwife model, which was discussed in an earlier submission quite really well. So
But there's some principles, I think, that both of them follow. And
Yep.
the principles are around cultural safety, around being trauma-informed, around collaboration with the community, around bilingual staff, around continuity of care. So I think those things are quite relevant, just looking at the principles of both models. You could be in touch with our sister organisation in Victoria. They were closely involved with the Victorian one. And I'm sure they would be happy to provide further information about the details of how that unfolded. I believe in Victoria it was largely focused on a specific refugee community as a pilot, and it would be good to actually look at the findings and extend it to other communities. I mean, Southwest Sydney would be a great place to actually have a pilot. And to me, a pilot would also entail something beyond what was done in Victoria, and that would be partnerships with community groups and refugee-led organizations who are doing a lot of this work as volunteers, like you are. There's others as well. And I think if we were to pilot something in Southwest Sydney, it would I think include a partnership with groups like yours and co-design as well.
And one of the research authors that in our submission, Dube, which she's thing here, we've been talking with her, and she's very open to. She's the Brisbane person. She'd be very open to providing extra information. She's done probably the best explicitly refugee-oriented research in Australia.
Could we sort of get something like that on notice, just to sort of, if you're able to reach out to them and if they can provide us some further information,
Yes.
that would be really useful.
I could reach out to the Victorian Foundation
I'll
and
go
you
to
could reach
Judy.
out to the
Yeah.
researcher. Yeah.
Thank you. Thank you so much for that. I've also got a question for Zamzam Mums. You talk in your submission about a lack of funding to be able to continue the programs that you are currently running. What sort of funding is needed to make sure that those programs can continue to run, and what numbers of women do those programs reach?
I wish I was better placed to answer about funding, but I think having somebody who, for example, having a full-time worker who was paid to do all the admin work would be fantastic. Like we've said with volunteers, they burn out easily. It's admirable to continue volunteering your time, but when that time isn't compensated, it's very difficult to continue. So being able to have 1 or 2 even full-time paid workers would be fantastic. Covering the money for the venue is very important. That's probably the biggest cost. And then being able to pay experts to come into each session to speak to the mothers, because they need money for their time as well. So in terms of the funding, those are the things that we would need covered. What was your second part to your question?
Just sort of with those sort of programs, do you have any sort of projections as to how many women that would reach?
So in the 2 years that we ran, we had something between 15 to 20 women attending each session. And that was over 2 years. And that was just the Mums and Bubs group. For the expecting group, we had similar numbers for each session that we organised.
Okay, and I think also, Sultana, important to emphasise that the group does have a significant online presence where we're able to reach and share that content with many of the women who are on the social media page.
Yeah, because if you look at our submission, I think there are about 5 to 6 women who attended Zamzam Mums who shared their stories, but the rest of them were from our circle of influence in terms of who we could reach out to online. So having a social media manager, for example, would be very important as well. Yeah.
Fantastic. If you could also take on notice just a bit of a breakdown of kind of what funding you are looking for, and a few more sort of specifics as to costs and what that could do, that would be really useful for the committee as well. Is there one more question? Or? Nope. All good?
Okay. Is it okay if I just say one last
Please.
thing? Sorry, forgive me.
No, please.
So I spoke a lot about how Zamzam Mums is able to support mothers and empower mothers through delivering them education through a safe context. What we realised, however, is that Zamzam Mums is an organisation outside of the hospital system, and that men and women who do not have access to this kind of a group do not have access to that kind of information, and therefore their birth outcomes are vastly different. So what this shows us is that a systemic change has to occur, that the burden of dealing with the system cannot always fall on people outside of that system, such as community groups. If we want to work with local health districts and hospitals, then it needs to be a collaborative effort where they recognise that things need to change at their policy level.
Thank you. Thank you all for coming in today and providing your submissions and providing us with answering questions and also your opening statements today as well. And thank you to Dr. Elisad as well for coming online. Thank you all very much. There was some questions that were taken on notice. The Secretariat will be in contact about those and any further questions that the committee may have in regards to the evidence given today. And thank you again. And thank you for all your amazing work as well, to all of you.
Thank you.
Thanks for your time.
Thank you.
Thank you.
Welcome back to the third hearing of the committee's inquiry into birth trauma, and I welcome and thank my next witnesses that have come today to give evidence. Before we begin this session, I remind witnesses to avoid referring to specific names, hospitals or medical facilities in their evidence, and to speak generally about the issues raised in the terms of reference. I'd like to start by asking each witness, starting from my left, to please state their name and position, title, and swear either an oath or an affirmation.
Thank you. My name is Melanie Briggs. I'm a Darawal Gumbaynggirr descendant, and I'm the manager of Birthing on Country at Waminda. And I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. Ms. Wellington?
Cleo Wellington, Kalangari Jirinja Wandi Wandandian woman. I'm executive manager of Waminda, and I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Wonderful, thank you.
Hi, I'm Shana Quayle, Barkindji Amalian Upper woman from Far West, currently the acting CEO of the Aboriginal Health and Medical Research Council. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Wonderful, thank you all. We can now move to short opening statements. Do any of you have a statement that you would like to make? No? Ms. Quayle?
Yep. So I'd just like to start off by saying that whilst there has been an increased awareness around the implications of racism, particularly from an institutional lens, there's much work and acknowledgement required. Birth trauma is complex and should not only be limited as being a life-threatening experience and or medical trauma, and rather is the event that may take place whilst in the care of institutions. The experiences of Aboriginal women is underscored by institutional racism. So broadly, the AH and MRC are taking two approaches by way of providing recommendations, and these are being, I wasn't very prepared for this part. So their three recommendations, is to there needs to be increased investment for ACHOs-based maternal and infant health programs and strengthened partnerships between ACHOs and local hospitals. The Aboriginal workforce needs to be strengthened through increased funding and retention strategies, and the cultural safety of hospital maternity units and mainstream services needs to be reviewed.
Thank you. We're now moving to free flow questions, so there'll be different committee members asking some questions. We'll start with Dr. Amanda Kong.
Thank you. My question is for Ms. Briggs and Ms. Wellington. Throughout this inquiry, we've heard that the New South Wales government can do better to support culturally safe care for First Nations birthing women, and the reputation of Waminda is quite outstanding. We've heard Waminda referred to as the best way to do this. Could you explain to us what your model is, how it works, what are you doing, how is it different to standard maternity care?
Thank you for your question. I know that our model of care is, it's been developed by the women in community, and the program, it's not only maternity care that we provide wraparound support services in terms of, being able to access early maternity care, and we live in a regional rural setting, so that transport and things like that is really quite complex where we live. There's hardly any transport, so making sure that the services that we provide actually go to the women, and also encouraging really professional and personal relationships with the women in our community. We're from community, so it's just. Yeah, birthing on country is, that continuity of care by your known midwife. Also having an Aboriginal health practitioner-led clinic where the women see the health practitioners prior to seeing any midwife in our clinic or any GPs as well. It's it's all around Aboriginal leadership and governance. And that's why the women feel safe coming there, because they know that, you know, that we are Aboriginal, and we understand, you know, everything that they're going through, you know, in community, and we have that, you know, that lived experience, you know, and putting that into practice. So I feel like that's really important when it comes to implementing a birthing on country model, that you need to have people that work in it with lived experience. And, you know, we talked about investing in our workforce, you know, having Aboriginal health practitioners studying to be midwives, and, you know, having more Aboriginal midwives and more Aboriginal health practitioners, child and family health practitioners and doctors, and, you know, so, you know, at Waminda we encourage that through the staff wellbeing framework, which is about, you know, capacity building for staff. So, you know, for example, we've got staff that have come through school programs who are now, you know, Aboriginal health practitioners and executives of the organisation. So, you know, birthing on country is not just about birthing, it's also about what happens outside of that realm for that woman and that family.
Yeah. Can I add to that?
Yes, please.
Yeah, so, you know, Waminda being an Aboriginal organisation on the South Coast, as Mel has said, we're Aboriginal women led. So for us, we've been in operation now for 39 years in our community, and that's a long time. And through those 39 years, we've fought to keep Waminda open. So being a women's Aboriginal service, it's been really difficult and really hard. And I believe that in the last 10 years, you know, I've been at Waminda now for 15, and talking about capacity, when I first came, I was a receptionist. Now I'm the executive. Now next year, the CEO's moving sideways, and us 4 executives will be running the organisation. We have 150 staff. We come from, when I was there, 8 to 10, and that was pretty much how big Waminda has ever been. And so when Mel talks about birthing on country, it's so true. Birthing on country cannot exist without Waminda, because Waminda is about community. It's about truth telling. It's about reclamation. It's about community. Our community own Waminda. And when we talk about the 150 staff, 75% of us are Koori. That's our community that we're working in. So when we talk about birthing on country, and when people talk about that being the answer, the reason why it's the answer is because it's us. Like it's what we want it to be and what it needs to be. We have the answers for that. And so for us, it's like a no-brainer. And especially being strong, staunch Aboriginal women, you know, it's taken us a long time to find our voice, to find our platform. And we're not gonna let that go, you know. And so for us, when talking about making decisions for our people, we have to be involved in that, and we need to be the ones who lead that. And then we need those people beside us to walk that walk. So when people talk about Waminda and what we're doing, and saying, well, Waminda's the answer, but it's the community. The community's the answer. The community has the answers. And so for us, you know, we feel very proud and honoured to work in Waminda and the work we're doing, and having birthing on country and being able to build our own birth centre, and being going back to our culture, you know, and being able to do our cultural practices and have that part of our birthing, you know, that's amazing. And for us, that's what the work is about at Waminda. And like Mel said, it's that holistic wraparound organisation. So it's not only working with birthing, it's working with the woman when whatever she brings, whatever she is carrying in her life and her family. She might be struggling with, you know, with money, so she needs support with housing, or she might need support with her other children at school, or, you know, there's multiple different issues and challenges that us as Koori people face every single day. And so when those women come to our service, that's their service. What do they need? We just hold the space. So I feel like when people say Waminda's the answer, well, the answer is the community. Communities know what they need. They just need people to support them to create structures and governance, and then they can do the work. And that's what I believe Waminda is and does.
Thank you. And where does Waminda currently get its funding from?
So both. So we get federal funding. We've got over 60 buckets of funding of money. So federal, state, regional, we get it from everywhere. And for us, the reason why is because we don't work in silos, we don't work in buckets. And so it's taken a long time for government departments to actually get their head around that as well, to understand that if we're running, a DV program, we can't run the DV program without, the counselling. We can't have the counselling then without seeing a doctor, seeing the Aboriginal health practitioner. We then can't run that session because if she's going to heal, then she needs to heal. And what does it mean to heal? Well, she needs to connect to her culture. So then we have women's gatherings, we have language sessions, or they go to the gym. We have a gym. So for us, our funding comes from all different levels of government. And for us, we're getting to a point where it's like we want to get to a point where we have some sort of self-sustainable income, but at the end of the day, we still believe in government has a responsibility to Aboriginal people or First Nations people. And so for us, it's, we get money from everywhere that we can to run what we need.
I have one more question. My question's now to all three of you. You've spoken about the importance of having Aboriginal staff and Aboriginal health practitioners in a variety of professions, and I know that was in the submission as well from the AHNMRC. What are your recommendations to us about how we can better support the development of that Aboriginal workforce?
Okay. Well, I believe there needs to be a three-way partnership. It needs to be a tertiary, an archo, and a hospital setting, because at the moment, and also that pathway into tertiary level studies. So the AHNMRC have an Aboriginal health practitioner course that they actually run. I won't speak on behalf of this, but they do that. They have a pathway. So, utilising what's currently there, right? So we have a pathway into university. We have universities that facilitate bachelor and midwifery degrees, medical degrees, all degrees. And then, that university then needs to recognise lifestyle factors of Aboriginal people and also the content in which they are presenting to the students, whether it's appropriate around racism, colonialism, and all of those things. So there's that, and then there's supporting students to have placements within ARCHOs, and also funding to support ARCHOs to facilitate student placements, because at the moment tertiary, universities, they do place students in ARCHOs, but not as much as they should. And, for Aboriginal students, it's really important because of their cultural safety and their cultural identity, because we know that being within a system such as mainstream, it can be very debilitating for our people because we are seen as tokenistic, and that's not safe for the patient or the staff member. So I think that, and that's just my view, that it needs to be a three-way partnership, like a triangle partnership between, that.
I think generally, so the AHNMRC work with a number of Aboriginal medical services across the state, as we are the peak organisation for our member services. And, although, Wominda have 60 buckets of funds, it's not the case for ACHISs across the state, and it's not consistent funding at all. So we obviously know that Commonwealth funding is through IAHP funding is the core funding for these services, but this only provides funding for a GP, a Aboriginal health practitioner, and very limited funding that services are required to actually operate from. And it is the services' responsibility to then generate income to be able to provide further services to their respective communities. So definitely when we're looking at Aboriginal health practitioners and training local community, we also lose those staff members to local health districts who have, further funding to be able to provide to that person. So the pay parity needs to change. We have to look at, the pay scales of ACHISs that they're operating off the Aboriginal Community Controlled Health Services Award, I can send it through later, but yeah, there's pay parity and obviously supporting the sector to be able to retain their staff. But again, as Mel was stating around relationships and partnerships with universities, it's so crucial that when they're going through and doing midwifery, that there is placement in a culturally safe organisation. So that way they're learning Aboriginal people's ways of knowing, being and doing, and able to support communities in every single way possible from a holistic approach. There's a number of things that we could be doing to support the retention of, staff and increasing maternity services. Sorry, I'm going to ramble.
Mine sort of follows on from that. Thank you. Thank you all for coming today as well. We heard earlier today from some witnesses just about the importance, and it was sort of in ethnically diverse communities and coal communities, actually going out and talking to people about, whether it's school students or, have you thought about a career, not just in nursing, but in midwifery specifically, so you get better representation of different community in working in hospitals and in health systems and in organisations like yours. Do you think that's something else that, there could be support? Obviously, I think you said that the AH and MRC do some training and specific courses, if you want to tell us a bit more about that. But would it help to raise awareness of this is a good career, these are some of the ways we can help you, this is how you could look at scholarship? Is that lacking at the moment? Is there something in that space that you see, particularly on behalf, I guess, of, First Nations communities? Yeah.
I think there's an opportunity to provide further scholarships, particularly for Aboriginal health workers and Aboriginal health practitioners.
Yeah.
From the AH and MRC's registered training organisations perspective, we don't really receive any core funding to be able to provide further workforce training opportunities for the sector. So generally at the moment we are providing the Cert 4 in primary healthcare practice, which assists in becoming an Aboriginal health practitioner. But from there's not actually any model around supporting further training and upskilling opportunities for the sector.
And can I just add to that?
Yeah.
We actually used to be funded for a program that went into schools that talk about opportunities and also talk about healthy relationships with their own bodies and things like that, like supporting the young people in community to really value themselves and have healthy relationships with themselves. So then that can then become self-determining for them when they do choose to have a baby or do choose to become a family. So we did used to have funding for that. I'm not sure what it was called, but that no longer exists. So, obviously there is an opportunity there to go into schools and do healthy programs for youth, but we also have youth programs at Waminda where we do go in and we do talks with them around what is relationships and things like that, but around the employment side of things. I mean, we just held a massive evening where we invited community in and on a recruitment drive, and we had how many participants? I think
20.
it was like 20 participants that showed up. And every one of them got a position at Waminda, whether it was casual or part-time. But we saw the need in community that people wanted to be employed. So, there's definitely, and that were young people just leaving school too. So, there is an opportunity, and I would highly recommend education, body education from ARCHOs or Aboriginal practitioners. And also, around what are we doing for schools in, year 10 and to year 12 around work experience placement and things like that.
And that pathway, presumably.
Yeah,
pretty much.
Yes, yeah.
Thank you.
The Honourable Emily Savell.
Thanks, Chair. Thank you to you all for appearing today before the inquiry. I understand some of you have travelled to be here, so thank you. My question is to Waminda, but I invite Ms. Coyle, you to chip in as well in terms of your perspective around this. We understand from New South Wales Health's submission that Waminda is working with New South Wales Health to implement the birthing on country within the Illawarra Shoalhaven Local Health District. So I'd invite you to comment on what that process has been like for you, but also how can we
what additional things could we be doing right now within health services across New South Wales to ensure or enhance culturally safe care?
That's a big question.
That's a great question.
I think, and I'll let Mel talk to it as well. But for us, the journey of birthing on country. So now, when I talk about birthing on country, that's just what I'm talking about. So there's been many stories that are similar to this, to other programs that are within our organisation. But it's actually it took us 7 years of lobbying, 7 years of back and forth to this place, to Canberra, meeting with ministers, meeting with secretaries, meeting with New South Wales Health, meeting with our local health district. It's been a really rigorous and really complicated journey. Now, it hasn't been complicated for us because we've been we know what we want, we know what we need, we just need people to get on board. So that's been the biggest challenge for us, is actually talking about that and trying to convince that we actually have the right to have a birth centre, and for us, we've even had comments of, you're going to have dead babies. Pretty much, that's what people have said directly to us. So for us, it's talking to people who possibly were sitting on the fence, were like, well, I don't know about this, I don't know if this is going to succeed. So over that 7 years, that's what the conversations have been, back and forth. We've created over 1,000 documentations just to prove ourselves that we can do this. We're more than qualified, we've got the skill, we've got the governance. That was another thing that came up against us. So they took on board that, our past history, when we were quite smaller as an organisation. We went through a lot of challenges and people still thought that we were back there and didn't realise how much we've grown, how much we've changed. And I feel like it's been a journey, but it's been a journey of educating people, bringing people along with us, pushing back. For us, when we talk about pushback at Wominda, it's a two-way relationship. So we're actually teaching people as we go along. So when you talk about cultural safety, that is massive for us. So wherever we go, that's number one on the agenda every time. And so for us, when we're talking about birthing on country and when we're talking about our birth centre, that is actually built from culture. That's the very foundation, as well as what Wominda is. So for us, when we talk about New South Wales Health, and you're talking about Aboriginal health practitioners, even for me, I think, Aboriginal health practitioners, when they're in the setting of New South Wales Health, they're not always valued at what they can do and their skill level, in comparison to what they can be in an ARCHO. And so for us, our Aboriginal health practitioners are doing way more clinical than what our other Koori people are doing in New South Wales Health. So I believe there's a lot of work to be done within New South Wales Health. It can be done though. And I feel like we've started down home, so we run something called cultural immersion or decolonisation workshops. So that's where we actually go in as an organisation. New South Wales, our local health district have paid us, and we've done it with, I think we've done about 5 or 6 different sessions with their executives, their managers, and then all their staff on the ground. And we've educated people on impacts of colonisation and on what it is to be an Aboriginal person, and then talk about white privilege, talk about right fragility. So the hospital, not just the hospital, I mean everyday life for us is unsafe, right, because of colonisation and because of racism, and it's in the systems. That's that systemic racism. So for us, it's really important that as an organisation, we keep bringing that to the table and we keep having conversations about that and calling it out, because we know it can change. We see it. We see it before our own eyes, We see people who go through a cultural immersion session who knew absolutely nothing about Aboriginal and Torres Strait Islander people, let alone know the local history, of where they've lived their whole life. And that might be, they say, their 3rd, 4th generation. And it's like, well, you can't compare that to 65,000 plus years. But when we sit in that space and we're open, we're honest, and we have those conversations, then people walk away going, they take them lenses off and they can't see it any other way. They can't ignore it. And then, because I feel like that responsibility then is a part of everyone, is a part of that work, and they've got to work towards cultural safety. And yes, we lead it, we say what it is, but then it's up to the other people who are non-Koori, non-Aboriginal, they're the ones who've got to make that effort on that cultural safety, because it isn't us, it's everyone else. And I believe that's the problem with the system.
everything that Cleone's just said. Everything.
And I think I could add to that if that's okay. So generally the LHD constitutions consist of, it is required, not a requirement. It's along the lines of where possible there should be an Aboriginal person that's representative, that is a representative on the boards of LHDs. I think that broadly that needs to change to ensure that there is Aboriginal representation on local health district boards, to ensure that it is good governance and, there are Aboriginal people informing policies and processes around, the healthcare and accessibility for Aboriginal people in their respective communities. Additionally, there is mandatory training, obviously respecting the difference within local health districts, but a recent midterm evaluation of the Aboriginal Health Plan showed that there's two components of that, 86% of which was online training and was completed by New South Wales Health staff, and only 44% actually attended the face-to-face training, which is obviously problematic in itself. I think you would receive more out of the face-to-face component than you would from, the online components. And I think the work that Waminda are doing around cultural immersion, sorry if I pronounced that wrong, sis, but it needs to be localised to the community members, that, it can't just be a one-toned particular one-tone training, and it doesn't fit across the whole state. It needs to be worked with by community members, and continually updated as well.
Yeah, and can I add to that, that, there's no ongoing unlearning within the system. It's continuous. So you can go into your training and tick that box, but then you go back into a service where you are a majority, right? We are really small in terms of that beastly system, right? So definitely, decolonisation, imperfect ally workshops. And back to birthing on country, we have, for the last 7 years, as Cleone was saying, developed over 1,000 documents, right? So we look at other programs that we've bought, for example, the Nurse Family Partnership, for example. These programs have not been developed from the ground up, from community. They've been imported and implemented into community, which haven't, been successful in some communities. So, birthing on country is actually an opportunity for Australia to have its own developed, community-controlled maternity program. Where was I going with that? I was going somewhere. And also so 7 years, right? 7 years is a very long time to be talking to people. We've conducted 5 risk assessments, risk matrix. We've developed business cases, multiple business cases, with very minimal feedback. We've got the solutions. We know that birthing on country and the model in which that it fits within Waminda works. When we had a risk assessment with the Ministry of Health, and so the recommendation to the local health district, the Ministry of Health, would be that they need to facilitate open arms when it comes to implementing birthing on country within the system, because at the moment there are too many barriers and too many challenges and too many things that we've actually had to develop along the way to get here. So, how many risk assessments do you have to do? Who needs to have the risk assessment done on them? Is it the ministry? Is it local health district? Is it the obstetricians? Is it the midwives? Is it the front desk? It is everything, right? So we found that exactly what Cleone said, we're not the problem. It's the system that doesn't allow us to be within it.
And in terms of the system, was there any, you've sort of articulated many barriers along the way, was there any, one thing in particular, or
and I commend you for your work in
Thank
terms
you.
of,
Yeah.
not relenting and continuing with that conviction around knowing, what you want and what is right. But have you got any suggestions for, because it's not like, obviously, I would hope that you have in some ways paved the way for others to follow, and that there are many other, local groups out there like Wominda within other LHDs that could indeed continue with this fantastic work. Do you have any suggestions for how that scaling or scalability works, or what those significant obstacles were and how to overcome them?
Well, I can name a
name
few.
it.
Yep.
Talk about it.
Ministry of the policy for so Wominda employed midwives are seen as privately practicing midwives or visiting endorsed midwives, and there's been a couple of barriers with that. One is the policy for privately practicing midwives accessing public hospitals. Right? So you might have heard of those problems over the last few sessions. So that applies to us as well. So in order for us to be able to access I'm an endorsed midwife. So I am trying to apply for credentialing to admit women into the hospital. And the barrier is that only one hospital that I'm aware of in New South Wales does it right now. So that's challenge number one. Well, the policy, the guideline then into the policy was the first problem. Now there's only one hospital that does it, so now we want to roll it out to all the hospitals. So how do we actually do that? So they've changed the policy so that privately practicing midwives can now have access agreements with local hospitals, local health districts. So now what needs to happen, those local health districts now need to develop visiting, I think they're calling it VEMs or endorsed midwife policy that outlines how that will work. And that is relationship, right? That's you've got to have good relationships with the other party to create a really beautiful document that will work for everybody. And that's been a challenge. And then you've got the credentialing. So to apply for credentialing, that it's massive. It's a huge document. Our team are going through it at the moment, and it's almost like you have to write your life story all over again.
Is this the credentialing to become an endorsed midwife?
No, well that's another, right?
Yes.
There's many
That's
layers.
Yes.
Yeah. So credentialing it's an application to the hospital to say, I'm endorsed, I want to start providing intrapartum care in your service. Will you please allow me to do that? So that's what we're going through at the moment.
Right.
So that'll be done at the end of the month. And then, that's just one. So there's the policy, and then there's the credentialing, and then there's the local policies, and you could write a book on this. And then there's the policy, and then there's insurance. So there's only one insurer for privately practicing midwives in the country. You would have heard about this as well, I'm sure, over the last few inquiries about insurance. No. It's a problem. No. It's a major problem. There is no... So midwives who are employed by the government are insured by the government. Midwives who are not employed by the government are employed by one organisation that provides insurance cover for privately practicing midwives. And it's quite expensive. And in terms of what we want to do at Wominda is have an organisational insurance policy that covers midwives providing intrapartum care within the public health service. So we've had to then negotiate with our insurer to provide us a package which is very, very expensive to the government too, because we have to get grants from the government to support us to pay for insurance. So not only, there's so many layers to this, but we've done it. We obviously have to pay for insurance because this is what the women want, right? We have to always remember that the reasons why we are sitting here today is because it's what the women have been saying, it's what they want, so we have to make sure that we're getting it done. So insurance is definitely happening.
What type of insurance are you talking about?
Professional
Intrapartum professional indemnity insurance. Yeah. So yeah, that's a major issue. It's costly. It's and there's for those midwives, like this is not for us, but midwives who are wanting to do home births, there's no professional indemnity insurance for those midwives either. So a lot of the women who are walking into privately practicing midwives' offices or home, like they're coming into their homes, they can't provide a full ironclad service because there's no intrapartum home birth insurance package. So it's a major issue for those midwives that want to just work in home birth. And then, oh my goodness,
But on top of that as well with the insurance, even for our midwives that we employ, what they've actually came back and told us that each individual midwife still has to have their own insurance.
On top of that.
So they expect us to take out this massive policy on insurance as an organisation, and then also they expect then the women we employ under our insurance to actually have their own insurance as their own practicing midwife on top of that. So that's a major cost. And it's not, I know if I was a midwife, I wouldn't want to pay my own policy of insurance, then I should be I should be covered by my organisation who I'm employed by. So that's a major concern.
Yeah, that's what government employee midwives get. They get insured and they get a wage and they get.
And that's because the private practicing midwives because of that.
Continuity of care, midwifery continuity of care. We don't have MGP on the South Coast. The closest MGP that we have is Wollongong Hospital. That's publicly funded. So we will be the only MGP service in Shoalhaven come February. February. So we'll have the women will have their own known midwife providing that whole care from pregnancy confirmation all the way up to 6 weeks postpartum, including intrapartum. And, Wominda will be the first ARCHO in this country that will employ their midwives, have intrapartum insurance cover, and be able to admit women into the hospital for their birth. So we will be the first, which is great.
It is. So again, thank you. Commend the work that you've done so far. And, it doesn't sound like it's been at all simple, straightforward, but, it's wonderful. What a great initiative. Thanks, Chair.
I've got some questions. Melanie, I think I read, and correct me if this is wrong, that you're the first endorsed Aboriginal midwife in New South Wales.
New South Wales.
And that was in 2020?
Yes, I think so.
And you're only the and you're the second in Australia.
Well, at that time, I might have been. Yes, I think so.
Yeah. I mean, it sounds like that there's a desperate need to get more Aboriginal people as endorsed midwives. How do we encourage that so that we have more diversity in midwifery care?
I think it relates back to capacity building from the ground up. So, going into high schools, encouraging work experience placed in with our programs. It's also going out to high schools, exactly that, and explaining what we do, talking about it. Because I know that when I did do it back in so many years ago, maybe like 5 years ago or something, the girls would come up and say, "Oh, how do I become a midwife? How do I, I want to be a midwife." And, I would support, that link between, how to, like, say, at any university, and, just encourage them to go to a university. But, the steps to that would be, obviously, schools have career expos, facilitating, going to those, encouraging young people to become midwives in that space. And then, you know, what do we do with those that the young people that, you know, don't get an ATAR of 99 something, you know, like what is the pathway then? So it's obviously programs like what the AHMRC have pathways into, which then, you know, you can then develop, you can have an Aboriginal health practitioner with a maternal and infant component, which is what they do in South Australia, where then, you know, they work in that space and then they can have RPL, recognised prior learning, when they go to university, say, and then, you know, they may not get a lesser time to complete their studies, but they'll have worked and lived experience in it, right? So we also have to think about, you know, the impacts of colonisation on our people in education systems and why our people don't retain all the way up until year 12. So thinking about that when we are actually putting, asking our people to go into university and study midwifery, you know, what lived experience do you have?
That's right, yeah.
You know, and those sorts, like doing, like I know we said we wouldn't put names and stuff out there, but Jumbana at UTS, the Aboriginal, you know, pathway program there, that I was supported through that as a mature age student for my studies. So, you know, it's also about that, and also, you know, mums that are returning to work. There's opportunities there, you know, pathways. You know, what are universities doing to support that? And, you know, and talking about that, mature age women, they go off and have babies sometimes, and, you know, they have a responsibility to look after their families, and then they want to come back into the workforce. It's like, well, what are we doing to support those women financially? So what, you know, like what grants are we providing to those women who want to come back into the workforce? There's a lot to think about, but can't do it all in one day. But
Absolutely. In regards to the birthing on country model that's implemented in the Shoalhaven, obviously this is the sort of program that we need to expand to other areas around New South Wales. What are the barriers to actually expanding that program and making sure that it's statewide?
I'll just do a disclaimer. Not all communities will want birthing on country. So we need to be very mindful about, you know, we're not a one size fits all peoples. We're all different and we all have different needs. So, you know, what works at Waminda is what we do, right? So I think it's important to use frameworks that have been developed, such as the RISE framework by Kilday and Rowe, you know, where it sets out how to implement a birthing on country model in your community, because what we need in that RISE framework is absolutely different to what's needed down the road. You know, like it's individualised.
They're all unique.
Yeah, and birthing on country is every single component, but the gold standard is what we're developing, what we are doing, right? So there's all that. You want to get to that. And each community might only want to have midwifery, they might only want to have a sexual health worker, or, you know, there's just components that they might only want for now. I don't know, but that's my take on that question.
Yeah, I think it's important to take that in consideration, that, like you said, not one size fits all. And I feel like that happens a lot in government. You know, you roll out programs and you do pilots, and then they think, oh yeah, we can take that and we can put that there. It's like, no, you can't. Like, you can take components of it and you can take it to other community members and say, what do you think about this? How does this look? How would this look for you? But definitely, I mean, for an example, we work with the wonderful women from Galawinku, which is up the top end of Northern Territory, and you know, they're part of this Boost project as well. And so for them, they look at Waminda, and they're like, oh, we need our own women's service. You know, that's what we want. But also they want birthing as well. But then it's like, first steps. What's the first step? You know, what is it that you want to establish? What are you already doing? And when we spoke to those women, there's a lot they're already doing. They just need that someone to give them resources to give them flexibility within policy in the NT, because there's some things that there's definitely barriers for them too, and I can't speak on behalf of them, but they've shared that with us. So it's like every community is going to have different things that they need, but we need government to be flexible with that and work with the communities with that. But definitely, you can look at what we're doing with BOC and then take that to another community and say, what do you think about this? What are the things you like? What are the things you don't like? How would it differ in your community? I think that needs to be a reminder. Yeah,
that's good. Yeah,
Can I-
please,
yeah.
Ms. Quayle. Yeah.
So I believe that there is also another service as well, program, Aboriginal Maternal Infant Health Service that we have been trying to push for through the Close the Gap, the national agreement, through the budget bid process in partnership with New South Wales Health. We would have liked to have seen an expansion. It has been stuck in limbo for the last 2 years around a scoping project to have a look at what services are available for maternal infant health and antenatal care. Just the expansion of these particular services that already exist is so crucial. There's evidence there that these services work, and there's a need for them. It's just investing in the community-controlled health sector to be able to deliver these services to our people.
Yeah. Sorry, Ms. Quayle, sorry to interrupt. Is that in your submission, mentioned in your submission anywhere? That
I don't believe we've referred to AMOS.
Okay. Sorry. Yep.
That's right. I also wanted to have a look, Ms. Quayle, at some of the recommendations that you've made in your submission and also in your opening statement, and I was just hoping if we could talk through those a little bit, and I'd be quite keen to get some thoughts from Ms. Briggs and Ms. Wellington too, in regards to what you would like to see as recommendations as part of this inquiry to the government, coming from particularly from this hearing.
Do you want to start? You start. Oh, you're right. Go, Mel.
Well, I don't know, actually. Do you want to...
You don't know?
No, I
Of
do know. Well, we want a national birth... Well, we want birthing on country to be number one. We want it to be, we want to be able to have cultural safety, ongoing for all people working in mainstream services, especially in terms of maternity. We want to be included in decisions when it comes to making policy about our birthing women, and also around, Department of Community and Justice, removing our children. It's really important that we're involved in those discussions and those policies, because we know that women, when they're going into birth, they're thinking about these things. Is my baby going to be taken? Because the system does that, right? So that's another thing. Like a national, well, not national, New South Wales, sorry, I keep saying national. A framework to support, that triangle sort of partnership approach from, Archo University and hospital sort of relationship. What is that? Like, we need to actually formalise something like that. More Aboriginal midwives. More Aboriginal doctors. More Aboriginal people working in services in mainstream.
Yeah, absolutely.
I think broadly, just implementing the priority reforms under the national agreement. So obviously the Productivity Commission done a review on CTG and how governments are implementing those priority reform areas, but we're yet to see any improvement around how they're implementing things. Invest in the ACHIS's sector. That's all we ask, is investment through funding of resources, human resources. there's evidence there that the birthing on country model works, you know, through the systematic and the review that was done. Invest.
Yeah, and it always goes back to we've got to stop comparing Aboriginal people and Torres Strait Islander people to everyone else. We've got to stop that. Like, we are who we are. We have the challenges that we have, and let's be real, the challenges come from colonisation. So that needs to be at the forefront of everything that happens and comes from this inquiry. And when we're talking about our Aboriginal women and Torres Strait Islander women, let's talk about intergenerational trauma. Let's talk about transgenerational trauma. Like, when we're sitting here, it says, you know, birthing trauma, and I was actually in, I'm going to say it. So I was talking to Mel earlier, and I remember being on, what do you call it, when you're on Skype? There was like a panel. Yeah. We're on a panel online, and, you know, Mel and I talked about what it is to be an Aboriginal woman and the traumas that we have. And then another woman, a non-Koori woman, turned around and said, all women have trauma, basically. And it really infuriated me because you cannot compare the trauma of an Aboriginal woman to every other woman. And I'm not dismissing every other woman's birthing experience. Of course, it's significant and it's valued and it needs to be heard. But we need to be heard as First Nations people. This is our country. And what we go through every single day of our lives needs to stop. And that, for me, is the biggest thing that comes from any inquiry. You know, that, you know, when we, like today we're talking about birthing. Birthing is connected to the justice system. Birthing is connected to the education system. Like, it all connects. So when we're talking and we sit here and we talk about deaths in custody, we talk about our children being removed, they all connect. And for me, that's another thing. Like, that should come from this inquiry. Yes, this is about birthing, but look outside of the birthing. What also impacts the birthing trauma of Aboriginal women? What's their birthing trauma? Because their trauma is multi-layered, multifaceted. There's so much more. And so I just want this inquiry to remember that. When putting out recommendations and outcomes and whatever the findings are, that you remember that.
Thank you for that, and thank you for sharing that too.
Can I? Sorry.
no,
So it just follows on, and I mean, you've sort of touched on it now in the answer you just gave. But I think the point that you made before, Ms. Briggs, just about that intergenerational trauma and the, you know, is my baby going to be taken away? Like, these are very real feelings that Aboriginal mothers will be having in hospitals giving birth right now. Like, it's not historical in that sort of sense. And so I think that's really useful evidence for the committee, because before we talked about making sure that particularly the medical workforce is aware of past trauma, and we're talking about it in the sense of birth trauma. But to your point, Ms. Mel, it's so much broader than that for Aboriginal women, and I think that's something we really need to be cognizant of as a committee as well, in terms of it's not just, you know, did you have a previous birthing experience that didn't go to plan? It's much deeper than that, and we need to be very cognizant of that with our recommendations, I think. So thank you. Sorry, that was more of a comment than a question. But
Sorry, just to that, through you, Chair, just a question around the current training. And I know, Ms. Quayle, you mentioned you know, the statistics around that earlier on. I think it might have been your opening statement around the New South Wales health training, and you had some suggestions around having a requirement for someone in the board of an Indigenous background. Just wondered whether there was any other practical suggestions you would have that could form recommendations from the committee. I know, Waminda, you also talked about the training that you've done with Illawarra Shoalhaven Local Health District. That's an example of one LHD, you know, that's, you know, you've started that work, whether that's, you know, whether that would be useful, or, I just invite your comments on how we can practically make sure that this, you know, this education, this information is better disseminated within the workforce.
I was just going to say, because it is true, like there is respect in the difference training.
Yes.
But I feel like exactly what you said, it's not localised enough. So what happens is you get in that training, you can be online or you can be in person. And I've actually spoken to an Aboriginal woman who used to run them many years ago in our health district. She talked about how unsafe it was for her to run them because it was just her in front of all these non-Aboriginal people, and you got really racist comments coming from with her staff, talking to her and making really, and that was really sad to hear that. And then when we met with her, she talked to us about how she then had to go back to her non-Koori manager to then try and explain what that felt like. Again, she was culturally unsafe again. So for me, if you're going to do training, it has to, for me, what works best is if it's external. So if people are coming in, so for us as Wominda, as an Aboriginal Women's Service, that's what we're coming in as. We're coming in as community members, and we're training and we're teaching people and we're educating people from our community who are working with our community. You can't get better than that because it's the truth and it's raw. And I feel like respecting the difference, that's just one layer. For me, if I speak openly, that's surface layer. It needs to go deeper than that. And I'm not saying get rid of it, but that's the start. But then what's the continuation? So like Mel talked about earlier, Melanie, sorry, a ticker box stuff, you know, or people do it once and then it's done. There needs to be continuous training. Like, because when we talk about, you know, Aboriginal history and when we talk about the truth of this country, it isn't taught in our schools. I mean, we were just talking to one of our staff members at work before we came up here, and she talked about how her child is doing this assessment where they have to choose either a settler or all these different people who were the discoverers, and then do an assessment on that. Like, still being taught in our schools that this country's been discovered. So when I think about the truth and when I think about history, it's not taught. It is not taught in our systems. It's not taught in the institutions. So for me, we're doing it like backwards. So for me, like, there needs to be the training. It needs to be mandatory. It shouldn't be a choice. You should have to go and you should have to sit there and listen.
This is the face-to-face component.
That's right, the face-to-face. You can't get better than face-to-face. You know, online, it isn't good enough. It just doesn't hit home the way it's meant to. And definitely, you need that localised voice and you need the local people to talk to that and what that means. For instance, down home, we've got the Bomaderry Homes. So the Bomaderry Homes is the birthplace of the stolen generation. Like, all the babies that were stolen, that were taken in New South Wales, even Queensland and Victoria, were all brought to the Bomaderry Homes, which is in our town, and people don't even know that, who've lived there their whole lives. Like, that's not good enough. That's not good enough. You know, so for me, you have to have that localised view, because then that's who those health workers, they're working with community. That community's walking in. That's who they're supporting, and that's who they're meant to be giving care to. So for them to give the best possible care that's culturally safe, they have to learn from the community and from the Aboriginal community that's there. So for me, yeah, it has to be not just a ticker box, it has to be continuous, and it should be mandatory, all that training.
And paid for.
And paid for, yeah, for people to come in. Yeah.
Because we know, like, exactly that. It's 100% that.
Yeah.
But, you know, it has to be paid for. It's knowledge, it's intellectual property, and it's our people's lives, right? So we've always been asked to come in as a last minute sort of thing, you know, and just expected to do it on behalf of the organisation, but it needs to be a paid workshop. And also, there needs to be a position within, or not, a role within the local health districts and in each hospital where, you know, there's a cultural mentor, there's a person there for the Aboriginal staff to actually, it needs to be a paid position. At the moment we have Aboriginal liaison officers, but they don't have support services around them. They sit within social work departments and, you know, with other non-Koori staff. It's a very siloed position, a very unsafe position. So there needs to be continuous mandatory unlearning and, you know, paid for.
And then when you talk about them liaison officers, they're one person.
Yeah.
In a hospital, that's not enough either.
It's not enough.
You know, I think one part of the cultural immersions and the outcomes that we did with our local health district is we talked about employing Aboriginal health practitioners in the ED. So they're your go-to person. They go and meet with the, the Aboriginal patients that come through, and then, you know, having more than one person employed. So if you're going to have a traineeship, have 2 or 3. But then after the traineeship, have an actual position available. Don't just have a traineeship for 12 months and then have no employment at the end of it. You know, so, and then like you said, you've got to have more than one person. We expect one liaison officer to see all of our unwell community members. That's not fair. It doesn't work. It doesn't work.
Well, thank you all for coming in today. Your evidence and everything you've said today has been extremely useful. I'm not sure if any questions were taken on notice, but if they were, then the Secretariat will be in contact, and certainly if we have any questions that we come up with afterwards, the Secretariat will be in contact. But thank you all again. Thank you for travelling here to give evidence today, and we appreciate the information you've been able to give us. Thank you.
Thank you.
Thank you.
I now welcome our next witnesses. Before we begin this session, I just remind witnesses to avoid referring to specific names, hospitals or medical facilities in their evidence, and to speak generally about the issues raised in the terms of reference. I note that we have Mr. Kennedy in person, and we have Dr. Kathari online on teleconference. Thank you both for joining us. I'll start with you, Mr. Kennedy. If you could state your name and position title and swear either an oath or an affirmation.
Hello, I'm Stephen Kennedy. I'm the founder of the Prepare Foundation, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. Dr. Kathari, I think you might have been emailed an oath or an affirmation.
I'm Alka Kathari. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you. And could I just get you to state your position title for the record?
Associate Professor Alka Kathari.
That's okay. Thank you. Do either of you have an opening statement that you would like to make?
Yes, thank you, Chair.
Thank you.
Thank you for the opportunity to share my story and advocate for greater inclusion of fathers in maternity care. In 2017, my son was born with an APGAR of 1 after an emergency caesarean section. I vividly recall seeing his lifeless body as he was handed to an emergency team. After 4.5 minutes, he was resuscitated. I watched over the shoulders of the incredible humans saving his life, returning several times to the operating table to reassure my wife with words of comfort that I did not feel. In the lift on the way to special care, he needed resuscitation again. We shared skin to skin via my little finger and his clutched left hand through the humidity crib. When he was 6 hours old, the head of paediatrics informed me that he had stabilised well. Her positive demeanour brought immense relief. Overwhelmed by emotion, I broke down. It was at this point I heard her say, "Dad's lost it, get him a cup of tea." I was fortunate to stay overnight in the hospital, sleeping on a narrow bench. This opportunity isn't always afforded to many fathers in similar situations. Seeking support, I requested a visit from a social worker. We were told we would have to say it was for my wife, which we did. My initial experience of fatherhood was marked by post-traumatic stress and depression, a challenging time of extreme irritability, alcohol use and strained relationships. Today my son is a healthy 6-year-old, albeit with behavioural concerns that have prompted visits to a paediatrician, an occupational therapist and a child psychologist. His assessment is ongoing. I can't help but wonder if his traumatic birth or my mental health struggles affected his development. I should point out that my son was born in a metropolitan hospital in Victoria, not in New South Wales. My childbirth experience inspired me to become a subject matter expert. In the topic of men at birth. In August 2020, I founded the social enterprise Birthing Dads, and in November of the same year, I established a registered charity. The Perinatal Relationship Education and Paternal Advocacy Research and Engagement, or PREPARE Foundation. Both organisations support expectant and new fathers, providing vital information and resources to define the role of fathers in the perinatal period. Our work in no way detracts from the focus on mothers and babies. Instead, it enhances women-centred care. We aim to empower fathers to contribute effectively to this care as an essential aspect of overall family well-being. I have appointed an eminent board made up of distinguished leaders from the midwifery, obstetrics, parenting and psychiatry fields. Over the last 3 years, the PREPARE Foundation has developed a Transition to Fatherhood package, a globally unique suite of online resources for expectant fathers. We've heard of staff shortages across maternity care in New South Wales. Fathers are an extra pair of hands that are currently not being utilised. If provided with targeted information, they may, in time, reduce the burden on our strained system. If continuity of care from a known midwife is the gold standard in maternity care, then continuity of midwifery care, in addition to an informed and involved father, is the platinum standard of maternity care. I believe that no individual is to blame for the widespread issues we are discussing in this inquiry, or for the lack of care and sensitivity that I myself experienced. And I extend my gratitude to everyone working in maternity care. Your efforts within a flawed system are commendable. Our society values emotional awareness in our men. Yet our maternity care system consistently undervalues, excludes and underestimates fathers, expecting them to resume normalcy after traumatic experiences. This stark contradiction highlights a fundamental flaw in our societal expectations. Lastly, my heart goes out to fathers navigating the perinatal period without the tools and information to provide the support that we inappropriately expect of them. I hope for a future where dads are acknowledged as a valuable asset to women-centred care and society recognises that the birth of a child is a monumental moment for fathers as well. That's it. Thank you.
Yeah, thank you. And thank you for coming today and providing that statement. I know obviously it's been very difficult for you, but we really appreciate you being here. And we're really glad that you actually accepted the invite to be here today. I know that there was strong support from the whole committee to actually hear from dads as well, so we're really glad that you were able to come today, so we really appreciate that.
It's a pleasure.
Thank you.
It's actually great that that the committee has actually invited a representative from the other, perhaps half of this equation. So thank you all for that. I really appreciate that, and I think it's wonderful.
Good. So we're just going to start with some free flow questions. So we've got.
Alka's also got an opening statement. Yes.
Sorry. Yes, Dr. Kathari. Sorry.
If I may. Thank you for the opportunity to speak today. And Stephen is part of the reason why I'm here today. And Stephen and other dads like me that I see in my practice. And I sincerely applaud this initiative of the New South Wales government for inquiring into this complex and distressing issue, which is obviously extremely important to the well-being of women and their families, including their partners. So as I stated, I'm an obstetrician and gynecologist and a clinician researcher, a current board member of the Prepare Foundation, and I'm also on the governance committee of SMS for Dads, Clinical Advisory Committee for Dads Group, and I've been on the board for the APTA, the Australian Birth Trauma Association, and the Clinical Advisory Committee. And today I want to speak to the terms of reference 1C, physical, emotional, psychological, and economic impact of birth trauma on mothers, on patients, their families, and the health workers, and also on 1C, the legislative policy and other reforms likely to prevent birth trauma. And as an obstetrician practicing in various Australian healthcare settings for more than 25 years, I often witness the isolation of men, even today. I observe fathers being barred from the operating theatre in case of a severe complication or when a general anaesthetic is administered to the mother. I have witnessed fathers standing in the corridors alone, wondering whether their partner and baby would survive. I've seen mothers and fathers share the burden of complex decision-making when faced with a fetal anomaly and grief after a fetal loss or stillbirth. I've just completed my PhD on forgotten fathers in pregnancy and childbirth, which is a passionate journey from the heart and was born from these heart-wrenching experiences and a desire for change. My work is based on the experiences of cisgender heterosexual men partner with women, and therefore I will use the term fathers. My work is now expanded to include gender diverse partners, non-biological fathers, and other family structures. I've also commenced on a 4-year postdoctoral fellowship where I'm developing consumer co-designed educational strategies for healthcare providers to better support fathers and their families exposed to birth trauma, and will develop consensus statements and national guidelines in this space. My work and this presentation are not intended to discount in any way the importance and experience of birth trauma for women. I work with them every day. I feel this enhances our knowledge and capacity to respond if we widen our lens to understand the impact of trauma on the whole family system. I'd like to remind the committee on the 2015 WHO recommendations on health promotion interventions for maternal and newborn health, which highlight that men are essential gatekeepers and decision makers. The WHO advises harnessing men's support and active involvement for improved maternal and neonatal health outcomes. Fathers also form an important untapped resource and support for women who have experienced birth trauma. Currently, we have no systems in place for routine preconception care and screening for men's physical and mental health conditions. There's poor health literacy among men, and even the healthcare providers are not aware of the contribution of men to pregnancy outcomes. Poor sperm quality due to lifestyle behaviors, genetic factors, environmental exposures, advanced maternal age more than 45 years, and paternal obesity all contribute to adverse pregnancy outcomes. We know nothing about the men who walk in our doors of antenatal clinics and our labor wards because we do not screen them for mental health conditions. We do not even acknowledge them properly. In my PhD work, 99% of fathers indicate an intention to attend the birth. With 1 in 5 people born overseas in our catchment area, with some of the families being First Nations, CALD, and other gender diverse groups, they may have poor language skills, they may be financially struggling, they may have unique needs, and I think we need to really cater for them better. Obstetrics, as you know, is a very volatile environment, and complications occur in approximately 1/3 of pregnancies. To give you an example, postpartum hemorrhage occurs in 16% of deliveries, and unexpected resuscitation of the newborn, like how Steve was describing, can happen in 15% of cases. This may result in inadvertent exposure to traumatic circumstances of families with potentially significant long-term psychosocial consequences. I also know that less than half of the partners may attend antenatal clinics, and they may have poor knowledge and what to expect and how to support the mom in an emergency. I see underprepared fathers every day, and some of them may have never even held a baby before in their lifetime. They're fearful, they're confused, and they do not understand what is expected of them, what is their role in this whole childbirth. My research highlights that traumatic events considerably impact fathers' physical and mental well-being, resulting in grief, guilt, self-blame, fear, shame, stigma, anxiety, depression, post-traumatic stress symptoms, and thoughts of self-harm. And I know this because I researched the fathers for the last 10 years. Most fathers struggle with healthcare communication, discussions with healthcare providers, complex decision-making. An example would be to make a decision regarding a termination, relationship strains, and even in 3 to 4 months after a traumatic event, a substantial proportion of fathers self-report ongoing distress concerning high rates of crime and thoughts of self-harm. Another worrying aspect is that fathers most in need of support and counseling after a traumatic event, in my studies, were reluctant to engage with health services. So obviously this raises essential societal implications because fathers struggling with significant mental health concerns may have ongoing responsibilities for caring for a vulnerable mother, a newborn, and other children, in addition to trying to put food on the table. Unsupported and struggling fathers may not be able to support traumatized mothers. Additionally, we know that children of fathers with mental health conditions and psychiatric illnesses have a significantly increased risk of behavioral and psychiatric illness, homicide, and adolescent suicide. After exposure to traumatic circumstances, ongoing mental health support must be made available to both partners. There are also significant health service implications because fathers are patients who need access, including mental health support. And unfortunately, we know that fathers are only treated as next of kin of pregnant women with no support systems built into healthcare services. And a stark example I will give you as an obstetrician, if I have a family who loses a baby, I can't write a prescription for the father because he doesn't have a UR number. He's not my patient. What we need are specifically tailored, targeted, flexible, and father and partner inclusive programs, improving engagement in the antenatal period and contributing to better preparedness for both partners for the birth. What this may look like is preconception screening and education of both partners. We know that pregnancy is a risk factor for domestic violence. We also need to screen for adverse childhood experiences, and one of our group's paper, a meta-analysis, has indicated that exposure to adverse childhood circumstances increases the risk of pregnancy complications by 1/3. And we also know that complicated pregnancy are a recipe for birth trauma. Routine paternal mental health screening, and I cannot stress this enough. We need targeted father-inclusive antenatal education and specialized information, including pregnancy, birth, and postpartum complications. I think this is really important to have a think about how we can deliver this information. I know that in my hospital, less than half of the fathers would attend antenatal classes because the format, the timing, the way it is delivered is not conducive to them being able to attend. We must have individualized discussions about fathers' health role and expectations in pregnancy, childbirth, and postpartum, and individualized communication with healthcare providers because one size does not fit all. We need the whole of family preparation for birth, and fathers need targeted information. Obstetrics is the only specialist area of medicine where people like me perform procedures in front of family members. And the experience of this can be quite distressing and traumatizing. Imagine at 2:00 when you're shooed away out of the theater where your wife is bleeding and you don't know what's going to happen. The degree to which coping style is adaptive or dysfunctional is individual, and it is influenced by background vulnerabilities and strengths. And often a gap between expectation and reality can exacerbate trauma. As one of the fathers in my work said, you expect this pregnancy to be a magical time where everything is perfect, and we don't have it. And we also know that trauma does not differentiate. It also results in significant collateral damage. And as an obstetrician, I can certainly recall difficult experiences from my own career, including giving parents the devastating news of fetal demise when I've scanned somebody, delivering a dead baby at cesarean section, and performing a perimortem cesarean section. We need culturally sensitive and trauma-informed care to support, control, choice, and autonomy without compromising outcomes. The decision to become pregnant, go through labor and delivery, and raise a family is a partnership. Patients and their partners are also in partnership with healthcare providers. To improve outcomes, we also need to take a partnership approach. Based on health equity and social justice principles, we need inbuilt support systems to respond to the care and support needs of families. Obstetric services need a shift towards a community, academic, partnership, consumer design model of care. There's no point having a service if the patients don't think that it is useful. These partnerships are essential to listen, acknowledge, and learn from consumers' lived experiences to ensure the needs are appropriately identified and assessed. Furthermore, health services must develop, test, implement, and evaluate solutions to address health inequities in partnership with consumers. In 2023, childbirth is father and partner's business too. Let us recognize and support them as an essential part of the team. Thank you.
Thank you so much. And apologies again, Dr. Kathari, for skipping over you, and I apologise for that. But thank you, that was a really useful opening statement. The Honourable Sarah Mitchell.
Thank you. Thanks, Chair. Thank you both for your evidence so far, and Mr. Kennedy, thank you particularly for being so open about something which is probably hard for you to talk about, and we certainly appreciate you being here. And I can tell by the way that you talk about your son that you're obviously a great dad, and I'm sure he's very proud of you when he's old enough to maybe understand what it meant for Dad to come to a parliament, but thank you for doing that. I wanted to ask, and I'm happy for either or both of you to answer, just more specifically about your recommendations, and I think Dr. Kathari, you said you're also involved with the Australasian Birth Trauma Association, who gave evidence, I think, on the first day of the hearing. So I'm interested in where you talk about potentially working together with your foundation, the Birth Trauma Association and Health to look at, preparing some better resources to go out to families. I think you talk about online support groups for fathers. Could you maybe expand a little bit more on how you think that would work, what that would look like? Have you done some work already? Partly because I think, the two issues that I certainly got from your submission were how you can better support, women going through pregnancy if you're an informed father, but also not to dismiss that trauma is also a really traumatic experience for the father as well. And I think, Dr. Kathari, you just said, watching your partner potentially be taken away for surgery, not knowing what's happening, your own experience with your son in, the humidity crib, it's a really tough thing for the dads to go through as well. And I don't think we should dismiss that as a committee, nor would we. So have you given much thought to what those sort of resources might look like? Has anything happened in that space yet?
Yeah, absolutely. Thanks for the question. I worked with the Australian Birth Trauma Association to develop an A4 size kind of a bit of guidance around that. I've spoken to Amy Dawes, the CEO, about creating an online, what I'm calling the Dad Stress Initiative, and that would be just a monthly type of facilitated by a psychologist, a men's group, kind of a men's work expert. I've applied for 4 grants for that, and none of them are successful so far. But because I don't think anyone necessarily sees that as a big issue, and so I've spoken to the CEO of Bears of Hope as well. That's a loss charity, and so what it would essentially be a facilitated monthly catch-up where you can drop in and out. You can come in, you can tell your story and get support from other guys. Then there would be a WhatsApp group as a kind of, so that they could be able to be contactable outside of those times. So if a guy's going through a particular concern at some time, maybe you can post to that group, and you know, with social media, I'm sure we could probably do it on other platforms as well. But I do think that there's resources in a sense where it's kind of, and I've done this myself, I've created A4s and stuff like that, but I think men, particularly when there's sensitivities around it, if given the opportunity, they do share, they do actually open up in a safe environment. And so I think, you know, just giving them an opportunity in a like safe environment, facilitated, just a monthly catch-up would be good. I'm also working with a charity in the UK called For Lewis, and we're going forward with this. We're trying to fund it ourselves. Is a monthly catch-up for men who have experienced loss, because that is a real gap at the moment. So that'll be a kind of international effort to kind of get men from the UK and potentially elsewhere to come to these online sharing groups. And again, that's an informal kind of way that they probably be driven by them. I don't know what it looks like yet, because we haven't really tried it out, but I think it would be driven by them, and over time we might get a better idea of what the needs are of these men. So
Yeah, thank you. Did you want to add anything, Dr. Kathar?
Yeah, so in the research space, I've got a $10,000 grant to develop some online health messages to support mental health of fathers, especially after traumatic events. And with SMS for Dads, we're doing some work where we are crafting messages for fathers who've been exposed to trauma, and they've been received quite well. An example would be, you know, I hear that your baby's passed away, and you know, what supports can we provide you? Here's a link to Panda, or here's a link to Red Nose, and you may find these resources helpful. So simple things like that. Also, preventative messages I think are really important in this space. So with the Safer Baby Bundle, you might be aware of it, where we advise the mothers to not smoke, not drink, sleep on the side, keep an eye on the baby movements. SMS for Dads is providing messages to dads to say, hey, keep an eye on me, make sure that I move, and don't steal mom's pillow so she can sleep on the side, things like that. And I think anything and everything that we can do in this space is really important, because if men are not supported, there's no way they can support the women.
Can I just ask one more? It's a little bit different. But one of the things that we've heard from particularly the women who've given evidence who've had traumatic birth experiences has been about that sort of informed consent and really understanding, you know, if you're in a position where suddenly you need to have a medical intervention in the birth or a caesarean section, sometimes if the women have been labouring for hours and, you know, they're not kind of understanding, some have said that they found that process quite overwhelming, and if they had more information prior to giving birth, they might have made different decisions. And we've talked with other witnesses about, I guess, the role that, you know, and I'll also use the term fathers, can play in that birthing suite by understanding what's happening because they're not physically giving birth. Is that something that you think we could also look to improve in terms of this information? And I know you mentioned the antenatal classes and fathers attending, but also because if the woman's maybe, you know, in labour and it's you know, your head's elsewhere when you're having your babies, yes. The role that maybe the dads and partners can play in terms of helping make that informed decision as a couple or as a family unit, rather than it being, you know, less of an ideal process.
Yeah, the first thing we would need to do is actually increase the birth literacy of men, and understand that they were involved throughout the process, so they actually know what her intentions are, so that he might be able to say something in that process of gaining consent, and all she needs to do is yes, instead of actually having to listen to it and be brought out of her, you know, her process. So I would say that it's about increasing the literacy of dads. I don't like the idea of dads providing that consent. That's not.
But just doing it as a partnership sometimes, or having that information more. Does that make sense?
Yeah, and being involved in those conversations and being confident to be able to communicate to health professionals is really important, because that's where dads feel the most helpless. Because they might be talking about a forceps delivery and he's like, what's that?
Right, yeah.
And he's never really come across that before. So seeing those instruments for the first time, and then, as Alka said, it's the only profession where you perform these procedures in front of the family member, so the dads can see perhaps that unfolding, and so he needs to understand those kind of aspects of that is birth. That's part of childbirth and its potential outcome. Alka, would you like to add anything?
Yes, I'd like to add a couple of things. And certainly, you know, when I ran the antenatal classes, I would take a pair of forceps and a vacuum with me, and I would leave it on the table. And I would say to dads, sometimes this is what we have to use in the middle of the night when your baby is struggling. So you're welcome to touch it, feel it, ask questions, you know, feel comfortable about it so that it doesn't come so much as a surprise and it's not as frightening. And, you know, we do have to do things, but if forewarned is forearmed, if you know about it, then at least you're a little bit prepared. The other thing that I need to make a point about is consent is dynamic. So what you may have consented to before may not apply 5 minutes later or 10 minutes later, and the woman is allowed to change her mind. And an example was last week. For example, I was doing a cesarean section for a breech presentation, and as the epidural went in, the baby flicked around, became cephalic, and I reconsented the couple. I reconsented the patient, and I sought, you know, consent from the dad as well, because, you know, the situation had dramatically changed, and the indication for a cesarean section no longer existed. So I really want to make this point very strongly, that consent is dynamic and it has to be sought at multiple times as your situation changes.
Yeah, thank you.
Thanks, Chair. Thank you, Mr Kennedy, and to you, Alka, for appearing today at our inquiry, the evidence and your opening statement. I really want to commend you for that, and thank you for the input. It's an important part of these recommendations we will form. I wanted to ask you a little bit more about the antenatal education and screening that you've obviously talked about earlier, and seek your views as to what would your suggestions be for our inquiry in terms of the recommendations we have to make about this antenatal education. I know Dr. Kathari, you mentioned making it individualised, how that would work in practicality. You've also mentioned you know, your examples of bringing forceps and a ventouse into the education, which I think is commendable. How would we ensure that that was delivered in such a way as to balance, you know, strike a balance between providing enough information about, you know, the potential risks and things, but also not alarming at the same time. So just both your thoughts on that.
I think the antenatal education as it currently stands doesn't meet the needs of modern fathers. It doesn't really explain birth support. It doesn't really kind of go into details of how he can be helpful. Even when it's actually targeted at men, they don't necessarily, they talk about fatherhood more than actual pregnancy and birth support. For example, down in Royal Randwick, they run a session down there, and I went along one time, and it's run by an ex-Wallaby, and he's a big fella who he just kind of says a lot of jokes and a lot of cliches and stuff, and that's their antenatal education. So if you really want to provide antenatal education, it's very difficult to get men to engage in a hospital setting, I believe, like a targeted for them, because they've got all other kind of things, and there's actually a lot of culture that we have to change before they come out of the house to talk about childbirth or to listen to childbirth. And so that's why I've developed everything online, so that they can do it in the comfort of their own home at their own pace. And of course, I'd recommend that you encourage fathers to do my program, but I'll pass over to Alka now to.
Thank you, Stephen. So I think that one size will not fit all. We know, and I know this from my own research, that younger educated fathers have very high information needs, because that helps them to feel more in control, to plan their life and do what they need to do. So the format of antenatal classes has to be consumer core designed. You have to ask fathers what they would like, how they want the information to be delivered, how much information do they want, because like you said, we really need to strike that delicate balance between too much and too little information. And we also perhaps need to invite people like Stephen and other men who may have had good births to share their lived-in experience, to talk about it. And I think some of the work being done by other organizations is really helpful in that regard, because you had these men come in, bring their baby in a pram, and they talk about what it meant to be, going through antenatal classes, how it really empowered them, because they felt they were more in control, they knew what to expect, they were not fearful. It didn't come too much as a surprise, even when their partner had an emergency cesarean section, because they sort of knew what to expect. And they also had the opportunity to ask questions. I think you have to lead by example. And the more we normalize this, the more we say, this is here, this is available at a time in a format, the way you want it, the way it suits you, take advantage of, I think, more uptake will follow. Because in my practice, I see that dads turn up at the first doctor's appointment because they want to know how this is going to run. And then they turn up at about the 36-week mark when we're making decisions about the mode of delivery and what to expect, and if you're making any decisions like induction of labor or elective cesarean section. That's when they turn up. So I think the better engagement we have in the perhaps even to take a step back in the preconception space, because most men do not see their GPs. We talk about, if you're thinking about having a baby, go see your GP, get your blood test, get your screening done. Let's start talking about what it means to have a family.
I'd also like to add to that. Trying to roll something like that out would be a bit of a problem, because I think it's really important that it comes from a male. If it's targeted at males, that, just like if it was targeted at same-sex couples, you would kind of expect a same-sex person to be the person facilitating. So the staffing of that would be difficult. I've developed face-to-face programs, and we went through a process with a local LHD, and it got to middle management. It was all going well. We budgeted it. I was going to provide that for free as a pilot for 6 months. And then it got to the executive and got knocked on the head. So, and yeah, the problems would be actually trying to staff it with men across the state, because I've thought about how we might do that.
And do you have any suggestions? We've heard a lot today about the importance of culturally sensitive care, trauma-informed care, and tailoring care specifically with those sorts of things in mind. Have you any suggestions as how to then overlay this other sort of type of education with those things in mind specifically?
Alka?
I might actually take this question on notice, because I would like to provide you a detailed written response to this question. With the learnings from my PhD, the rest of the literature, and what I learned from the fathers when I do focus groups with them. I think it is really important that we use a consumer core design approach. Yes. Because I feel instinctively that the uptake would be much better. Some dads may utilize resources that are available offline anytime, whenever they want to. Things like what Stephen has prepared for the Prepare Foundation. Other dads might want to be there in person because they feel more comfortable speaking to people. Some dads may want to speak to a male, and it's a great idea to have male peer educators, but we know that they are thin on the ground, and perhaps we could do a targeted recruitment drive to see if male midwives might be interested in performing such a role. I think we really need to have a multi-pronged approach if we're going to win this.
So, sorry, to that, Dr. Kathari, would it be fair to say that we could not provide a sort of standardised one-size-fits-all education package? No.
Well, you could start with that, but remember this, it may not apply to everyone, so you need to have systems in place where you also are able to reach those subgroups that don't fit the big group.
I suppose that they then have to know that it doesn't apply to them, because we're also talking with the complexity around this may be the first time someone has had to encounter, well, even being in a hospital, for example.
Yes.
So that additional layer. Sorry, I think you might have had something to say, Mr.
Well,
Kennedy.
I think you would have to start with a standardised version, and then over time, this is a long-term endeavour. Over time, you would develop, some kind of feedback mechanism to develop it in more detail for other communities, other cohorts. But I will also say, just backpedaling a little, I think it's important that men do understand the different interventions that might be possible, because I feel like if you don't provide them with that, then it's a gap and they might feel somewhat ripped off, for want of a better term, if you take them through a whole process and then you don't actually mention inductions, ventouse, all the other things that might go on. So,
thank you. Thanks, Chair.
Thank you. Dr. Amanda Conn.
We've talked a lot already about the specific needs of partners sort of during the pregnancy and birth, which has been really valuable. But I was hoping to ask you sort of how important is it for partners and fathers to also have their own independent support, noting statistics that men are far less likely to have their own regular GP, for example, let alone choose to go to see them when they're considering starting a family.
Well, you mean kind of after birth or throughout the process?
I suppose in general, so we're talking about these really specific targeted programs for expectant fathers or recent fathers, and I'm interested in a discussion of the role of sort of having regular practitioners, whether it's a GP, a psychologist, separate to your partners. So we've talked about bringing dads into antenatal care, or Dr. Cathara, you gave the example of not being able to prescribe antidepressants to a partner. So what is the role of a partner or a father's own independent practitioner?
Do you want to answer that first, Alka?
Yeah, one of my big concerns is that fathers don't have any dedicated personnel looking after them. The pregnant mom has got the midwife. We are focused on the mom and the baby, and everyone else is. So I think we need to perhaps, and this is a systems issue, you need to have a look at how can we provide support to dads just during normal circumstances, because we know from the research that even normal birth, where everything's gone absolutely fine, can be perceived as traumatic for dads. So I think if you had a designated person, say for example, supporting them, or a designated system put in place where they could link in. At the moment, they come in as a +1. When mums have social work appointments, we say on purpose, can you please bring your partner? Can you please bring dad? And sometimes they can make it, sometimes they can't. But if there was a dedicated system put in place where fathers could link in, during pregnancy and certainly after birth, when things haven't gone as well as they hoped, then perhaps you might get some engagement, because my qualitative work has very clearly shown that they want to be engaged. They want someone to look after them. They're asking for help. And even the society doesn't actually encourage them to seek help, because they're men. They're meant to be strong. They're meant to be the breadwinners of the family. I think we need to make it easy, and we need to normalize it, to say, it's okay to say you're not okay. It's okay to seek help. And we have the systems put in place where it's very easy for you to link it. And whether it's a multidisciplinary clinic where you have a social worker, a perinatal mental health person, a GP, someone that they can, go to when they leave the hospital. I think this is really, really important, because especially when a baby dies, I think we lose those families after a few days. They might come for a couple of appointments, and then we don't know what happens to them. And I think that period is really important.
I'll just add to that. I think that there's a step before actually trying to implement some program and then finding out that dads don't turn up, because that's what we've continuously done in this field for quite a while. So there's a culture change kind of process that needs to be undertaken first, and that is dads seeing themselves as having a role during pregnancy, because one of the things I hear a lot is my job doesn't start until the baby's in my arms. Isn't that right, Steve? And I say, no, you're a father from conception, and they don't seem to get that. So we need to inspire men to be more connected to the fetus during pregnancy, and involved, and fundamentally involved, and knowing that they're important during birth as well, but then actually following that through and proving to them that they're important during birth. I think the only time we're actually going to see like significant change in this space is when men start to share with each other their birth wisdom. And that's a few decades or more, so that the next generation comes through and they understand that they've got a role. That's why I developed something like this, which is just, you know, a little flyer that I developed with the Sutherland Family Interagency. And it's just trying to say, guys, you've actually got a role, and this is what it is. Because men, as fathers, they've taken up the mantle and they've said, okay, I know how to be a dad. They might have a role model from their own dad. They can rely on their peers, or there's actually quite a lot of information for men when they become fathers. So it's still a gap there during pregnancy and birth, and a little bit afterwards, newborn care, which is why we brought this in from the UK, which is the Dad Pad. This is across the NHS in the UK, and this is a newborn healthcare manual, and we adapted it to Australian circumstances. That's actually saying to dads, you've got a role in newborn care, and this is what it is. It's all just, what, you know, as parents in the room, you'd say, oh, this is all really basic information, but it's wonderful because it says to dads, you can be doing all of these things as well, and it takes the pressure off of new mums, because he's picking this up, and he might even be teaching her a thing or two, you never know. So I think dads need to see themselves in this space before they're going to come, and they don't expect anything as well. They don't necessarily, they want the focus to be on their partner, their wife, and they don't really, and so we need to kind of, shift that kind of cultural expectation.
I've just got one quick question for Dr. Kathari in regards to some of these resources that we've just been provided. Could you just take us through some of the main aspects of the research that you've done and the findings? I know it's quite a big question when we're at the end of our time, but just to give us a bit of a heads up on some of this paperwork that we're looking at.
Sure. So, in a nutshell, preconception care for men is not non-existent. That needs to be fixed because they have a huge role to play in terms of their contributions to their offspring's health and future outcomes. Most fathers in Australia, and I did the first study where 99% of the fathers attending my hospital antenatal clinics indicated that they will attend the birth. Most fathers don't feel prepared for it. A significant number said they would like mental health support, because remember, in our antenatal clinics, we're not actually providing them any mental health support. And the small proportion that said they received it may be those fathers where things were not going very well, and we have spoken to both partners, or maybe there's a fetal anomaly, or there's a concern on the ultrasound scan. Fathers are significantly affected when they are exposed to traumatic circumstances, which are unfortunately quite common and can happen in 1/3 of births. There's significant mental health complications, and I've sent you a little thematic map from the qualitative study where you look at the fathers, and if you read that paper, you will know that they're affected right from their physiological being. They're not able to sleep, they're not able to drink, they can't think, they can't go to work. One of the examples I will give you is where a dad, after losing his baby, went to work and said, I was ready to punch someone who said to me, how was your holiday, mate? Because he never told them that his baby died. They don't feel empowered, they don't feel supported. We have no systems in place in maternity services. In fact, we call our departments women's and newborn services. Where is the dad in the equation? There's significant health inequity. They're also ticking time bombs, because after something terrible happens in the pregnancy, they go out in the society, they are still struggling, they're still crying, they're having thoughts of self-harm, and they have to go to work. They are completely unsupported. Imagine going home to a mother who's struggling already after having a traumatic birth, and having to then support her without any consideration of your own feelings. I think we need to do a lot more for fathers, and it has to start right from the very beginning. We have to start normalizing mental health support, seeking help right from when they are young boys, to say, and this is a holistic view I've taken, because we need to normalize help-seeking behavior, because these young boys who grow up in families where the fathers have perhaps a mental health issue and they don't have a very good childhood, have adverse childhood experiences, they grow up and they become fathers themselves. And there's an increased risk of substance abuse. It's a recipe for domestic violence, and so on and so forth. So my PhD work has shown that we need preconception care. Most fathers intend to attend the birth, and they're significantly affected after traumatic circumstances, after birth trauma, and they need urgent support if we're going to support our mums and our babies and the next generations.
Wonderful. Thank you. Thank you both so much for coming today. I think there was a question that was taken on notice, so the Secretariat will be in contact in regards to that, and if there's any further questions that the committee has, the Secretariat will be in contact in regards to that as well. But thank you both for all that amazing work that you're doing, and thank you for coming today.
Thank you.
Thank you for the opportunity.
Thank you. Good afternoon. I now welcome our next witnesses. We have Dr. Austin and Ms. Fiona Davies from the AMA. Could I ask each witness, starting from my left, to please state their name and position title and swear either an oath or an affirmation?
I'm Dr. Catherine Austin, the Vice President of the Australian Medical Association, and I'll speak for the affirmation. I solemnly, sincerely and truly declare and affirm that the evidence now and about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you.
Fiona Davies, CEO, Australian Medical Association. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Do either one of you or both of you have an opening statement that you'd like to give?
Yeah, thank you very much. I would like to give an opening statement. The Australian Medical Association New South Wales would like to thank the Select Committee for the opportunity to provide a submission to this inquiry and for the chance to appear before you all today. I would like to acknowledge the traditional owners of the land on which we meet. My name is Dr. Catherine Austin. I am the Vice President of the Australian Medical Association New South Wales, as well as a practising obstetrician and maternal fetal medicine specialist. I work in both the private and the public hospital system, where I practice general obstetrics as well as the highest risk obstetrics through maternal fetal medicine. I have undertaken additional subspecialist training to also hold this maternal fetal medicine qualification, allowing me to work in the highest risk and the most complex pregnancies for families across New South Wales. I work with an extraordinary group of talented doctors, midwives, nurses, allied health workers, all of whom share the same passion and commitment for maternity services for which I bring today. The AMA acknowledges the experience of birth trauma felt by large numbers of women over many decades. Those of us working in health believe that it is crucial that the system that we work in should be seen, felt and fundamentally be safe, because it is through that prism of safety that trauma can be minimised. We believe it's important to recognise a safe system that needs to involve physical safety as well as the psychological safety of those working within that. It should be acknowledged that Australia has among the world's lowest rates of infant and maternal mortality. This is thanks largely to a strong health system, but also to the multiple forms of intervention available to medical and midwifery professionals to address the multitude of birth impacts. These figures obviously welcome, but we also need to ensure that our strong physical outcomes are matched by similar outcomes of psychological safety. We acknowledge the New South Wales Health Blueprint for Action in Maternity Care. The blueprint has a sound evidence base. It has been well informed by feedback from mothers and families and from those working in the health system. Unlike the previous New South Wales health policy, Towards Normal Birth, the updated blueprint document seeks to provide options for women rather than creating expectations of one particular maternity pathway being normal. We believe there's no such thing as a normal birth. While many births in the state and across the nation occur without complications, every birth, every day, has the potential for risk. We believe that a lack of understanding of the scope and frequency of these birth impacts has contributed to the levels of trauma that have been experienced and demonstrated through this inquiry. We note that many of the submissions of those with lived experience express how a lack of information and understanding has exacerbated their feelings of trauma. What is often not well understood is the prevalence of the many possible physical and emotional impacts of birth that can occur. The Australian Institute of Health and Welfare reports that in 2019, of all the women in Australia who gave birth vaginally, 85% suffered some degree of perineal trauma. Around 1 in 5, or 20%, of women will require some form of instrumental intervention in their delivery in their first pregnancy. The statistic has largely unchanged over time. As I remind my patients, we generally do not know which one of them, though, will be that 1 in 5. Contrary to social and mainstream media suggestions and well-meaning non-medical advice, it is the nature, not the patient, who determines who may require this assistance. We know preterm delivery occurs in approximately 7 to 8% of pregnancies across this country. Preeclampsia can affect somewhere between 3 to 10% of pregnancies, depending on severity. Gestational diabetes can now be diagnosed in up to 15% of pregnancies. Rates of all of these known pregnancy risks are significantly higher in multiple pregnancies. Increasing maternal age, elevated body mass index will also add complexity to a pregnancy. These are simply some of the many figures that demonstrate that pregnancy carries the innate risks that are often unbeknownst to people prior to conception, and that can in many cases endanger their life or the life of their baby. In many, maybe most aspects of our lives, we are used to having some, and usually a large degree of control. What cannot be prepared for is when things suddenly and unexpectedly and quite dramatically can go off plan. We believe that women are not given enough preparation for that significant, overwhelming, and often terrifying loss of control that can occur during a pregnancy or during a delivery. And this can happen to any woman at any time. Birth by nature can be painful and unpredictable, but it doesn't mean that it will necessarily result in trauma. But we believe the best ways to reduce trauma are by a number of factors. By building the confidence of women and their families by providing better antenatal and postnatal education, by informing women of the spectrum of procedures that can be associated with birth, by involving women in decision making as much as possible, and discussing birth outcomes in that postnatal period. Essentially, better education at every stage of the birth journey for a better informed birthing experience. These discussions should involve medical and midwifery input so that women understand and are made aware of that whatever their hopes or plans, they may in fact require medical intervention. The possibility of requiring medical intervention should be seen as a part of the normal birthing process, not an unexpected or traumatic outcome. Many of these submissions in the inquiry refer to the frustrations felt by expectant parents at the lack of continuity of care within the public system. This is a frustration that we share as doctors and the healthcare providers. Lack of continuity is an unfortunate consequence of workforce pressures that we face. I refer you to the Ockenden Review of Maternity Services, conducted in the UK and released in 2022, which we will table. It calls for an appropriately funded model of care which allows birthing units to be properly staffed and to be funded in a way that all forms of care can be delivered in concert. It recognises that safe staffing levels must be addressed, including backfill to ensure staff are able to provide and attend training, as well as measures to address and record rates of attrition as maternity staff burn out and move on. The review calls on regular emergency drills and better training at all levels on antenatal cardiotocography, or CTGs, the monitoring of babies' heart rates, as well as for creation of better systems of training in compassionate care, particularly for families who've suffered bereavement. The AMA believes that the best outcomes are achieved by a collaborative, multidisciplinary, team-based model of care, with each profession supporting and respecting the opinion and the approach of others. When doctors, midwives and other allied health workers act in concert, early recognition of risk factors that may cause pregnancy or birth complications are better identified, birth outcomes are improved, and postnatal complications are reduced. An example of exceptional collaboration is that of medical professionals and physiotherapists. There are many, but this collaborative model of care from which the beginning of pregnancy could provide significant safeguards to prevent birth impacts, including trauma. We believe physiotherapy services should be provided extensively both before and after birth. We do, however, suggest that measures be put in place to ensure that information provided by non-medical advisors does not contradict evidence-based care. We believe expectant parents should receive education in relation to the difference between medical and non-medical advice. For example, being told that a so-called natural birth with no form of intervention is best for your baby, and that all forms of intervention, including pain relief, forceps, vacuums, emergency caesareans, should be avoided at all costs. A natural birth, in which a baby is breech, has a cord around the neck, a shoulder stuck in the birth canal, or many of the other potentially life-threatening or serious complications that can occur, can lead to lifelong implications, or rarely even, most catastrophically, death. These more rare but serious conditions, like a uterine rupture, in which the uterus may break open and a baby's heart rate drops to 0, if left to nature, would most certainly lead to death for a mother and a baby. Doctors want what expectant parents want. We are on the same team, a birth that is medically and psychologically safe for a mother and their child. The AMA believes there need to be realistic pathways to adequately address antenatal education to provide this. Just as important is the scope for postnatal education. Studies have shown repeatedly that when explanations are provided for what happened, why things did not go according to plan, and where necessary, what intervention was required, the level of trauma that is felt is vastly reduced. Education for expectant parents is not the only answer. Among the solutions should be better training and resourcing for those providing the services for them. We believe there should be greater screening for those who may be predisposed or at greater risk of birth trauma, so that trauma-informed care can be tailored individually to address further needs. There must also be robust mechanisms in place to identify psychological distress and clear pathways to access emotional support and specialist support where needed as soon as possible. All of these require significant resourcing and workforce, and simply adding these additions to an already overburdened staff simply cannot be the answer. Working in maternity services is an incredible privilege. We live through every mother's story, every baby, every joy and every loss. We accept that the tragic outcomes are sadly part of our job, but we feel the experience of vicarious trauma among maternity health workers should also be acknowledged and addressed. High-quality maternity services rely on stable medical, midwifery and allied health workforce. There is a concerning risk that the result of this inquiry could lead to a loss of workforce, inadvertently undermining the most important objectives of increasing medical and psychological safety that is afforded to our patients. If the inquiry results in recommendations that are not safe for those working within the system, this could lead to the catastrophic failure to attract and retain a workforce we so desperately need to provide this informed care across the state. It is our hope to work with this inquiry to create a safe maternity service, both medically and psychologically, for all patients and for all those working in the system. I'm happy to take your questions. Thank you.
Thank you. Just to confirm, Ms Davies, you don't have another one? Okay, thank you. Thank you. I will start with the Honourable Sarah Mitchell because I know she has to leave.
I apologise. I have to leave in about 10 minutes, so I just would like to ask, probably just one question, to be honest. One of the parts of your submission, Dr. Austin, and you sort of touched on it a little bit then, is that sometimes doctors are forced to make split-second decisions. Every birth will be different. You can't always foreshadow what will happen. And that's obviously done to save the mother and the baby as well. Earlier today, we did hear from one witness who, in their submission, were talking about criminalising obstetric violence. And I just wanted to get the view of the AMA on that. You've also spoken about workforce pressures. I know that the insurance requirements, again, that's something that's come up throughout today as well. But what would be your view on any move to criminalise obstetric violence? Do you think that's even possible, considering the various circumstances that might arise, and what would the impact be, particularly on the workforce, if that was something that was to come in?
Yeah, thank you very much. I think it's an incredibly important aspect. Drawing back to the fact that split-second decisions are made is an incredibly challenging part of obstetrics, and flashing through my mind are a number of challenging circumstances where we have in fact made split-second decisions which have hopefully saved and in many cases have saved the life of a mother and baby. Obviously knowing that with that comes the importance of discussing post that event what might have led to that decision making and hopefully providing that informed care about what led to it. But in circumstances of criminalising those split-second decisions, I think is incredibly damaging to our workforce. Whilst we don't take away from the trauma that may have encountered in some of those split-second cases, and has been evidenced by the number of cases we have presented in this inquiry, I think criminalising these sorts of obstetric interventions where they are in the purposes of life-saving procedures would in fact decimate the workforce in which we have. I think it would be impossible to practice in a public setting should that be a criminal result, and I think it would be nigh impossible to practice in a private setting. One of the challenges to that is in a private setting we have the ability to get to know a woman over time and talk to her about the role for things like emergent deliveries with a vacuum or a forceps or an emergency caesarean section and episiotomy that might need to be performed. Criminalising those which are known obstetric interventions and happen so commonly, as we said, in 20% of our first-time mothers requiring for example, instrumental birth, meaning that should there be a case where that may not have been performed to the standards or along those lines of where there was event of trauma occurring, we do worry that that criminal process around something that is in fact simply a part of obstetrics would render there be no workforce to undertake maternity care services. Midwives and obstetricians alike would find that impossible to work under those circumstances.
Thank you. I'm happy to. That's all I want to tell us.
Thank you. Dr. Amanda Conn?
Sure. I first just wanted to put on the record my conflict of interest that I'm a member of the AMA, but that I was not involved in the preparation of the AMA's submission to this inquiry. You mentioned in your response to the last question that value of continuity of care that you've had as an obstetrician with your private patients. I'm interested, as the AMA does also represent GPs, in the role that GPs can have either in shared care or GP obstetricians in the country as well.
Yeah. Thank you very much. Look, I think the continuity of care is obviously an exceptionally important part of how we can look at ways to hopefully improve outcomes. And I'd like to think that that is what does come from this inquiry, is improving those outcomes for the women coming behind those who've put their submissions in to try and establish an incredibly psychologically safe system in which we all work. I think the answer comes in multiple ways. Continuity of care can be done through many ways. We know that in the public hospital system, and particularly in the high-risk clinics in which I work in, there is an incredibly good degree of continuity of care. Women meet with myself as the maternal fetal medicine specialist. They often meet with a general obstetrician. They meet with midwives. They meet with allied health social work along the way, and the neonatal teams and anaesthetic teams caring for them. The challenge is when that's done in a high-risk setting, it's obviously, even with all of those challenges, incredibly under-resourced. And I think that's one of the challenges we face in the public system. One of the roles of looking at how we can provide that more continuity of care was to look at the role of GP shared care. And that is something that a number of the New South Wales health districts do have already up and running. But obviously that requires a significant investment to ensure that women do have access to that continuity of care, education around that being an appropriate model for them. And one of the other challenges is obviously, as you well know as a practicing GP, that good care takes time. And unfortunately, any of the MBS funding that goes around GP care, shared care, is for very short periods of time, which doesn't always allow general practitioners to be appropriately funded or resourced for providing the care that those women may need. Now, that said, the GP is the centre of often many women and their families' lives, and is an essential part of how we can provide one aspect of continuity of care through this review. And I think it's certainly something that can be expanded upon and look at additional ways for resourcing and staffing that can roll out further GP shared care programs. And it's one of the many ways that we can look at that. And certainly for women who may fall in a slightly higher risk than a standard low-risk midwifery program, but not necessarily require the resources of staff specialist obstetricians or VMOs within a hospital system, the GP shared care and continuity of care can be incredibly valuable throughout that.
Can I have a few more questions, Chair? The terms of reference of the inquiry were to look at the impacts of birth trauma on patients and their families and also on health workers. Yeah. You mentioned in your opening statement vicarious trauma, and I was hoping you could expand on the impact that those traumatic births actually have on practitioners.
Yeah, thank you very much. Look, I think we take every single birth with us every time. I could probably not detail all of them. There's been many hundreds, if not thousands, over the many years that I've worked. But I think every birth that we do leaves a little piece with you. And I think the trauma when things don't necessarily go according to a plan, or in fact where there are interventions required, do take a little bit of us along the way. And I think the challenge at its most severe, that's burnout, that's loss of enjoyment of one's profession, and unfortunately with that comes often with loss of empathy, loss of ability to sort of walk in a patient's shoes and be able to deliver that joyous and informed care along the way. And that's the very worst situation. Equally, healthcare workers leaving the profession because they simply can't tolerate that anymore. And that's an incredible shame. We know that the obstetricians, the GPs in this country who are skilled and able to provide that care are limited in number. It's a very precious resource for which we hold. And I think there is unfortunately very limited support that goes to the medical professionals providing this support. And certainly speaking on behalf of midwifery colleagues, not in a formal capacity, but those who spoke to me prior to this, obviously the trauma that goes along with them as well, when they can't provide that safe staffing ratios or the care that they would like to give, not only in the antenatal space, but during the birthing process, and equally important in that postnatal setting where women may require additional time to be spent with breastfeeding services or to talk about what might have occurred during a birth, how they will integrate that with other children at home, with domestic violence that may occur in the family, with living in geographical isolation, so many of the different factors for which we send women home to in their environments. But I think that vicarious trauma is incredibly powerful, and I think it's an incredible risk to come out of the inquiry like this, is that where we perceive there hasn't necessarily been an understanding for what the impact is on the healthcare workers. I think it's something that we really, really need to look at and provide those appropriate supports, certainly for our patients, but also for those doctors and midwives who are providing care for the patients going forward, so that they can continue to deliver exceptionally safe physical care, but also to be able to be in a place to deliver that psychological care.
I might jump in now with a few questions as
Sure.
well.
Thanks.
You mentioned in your submission that one of the biggest barriers to continuity of care is the staffing levels, and this actually needs to be overcome as a priority before we can start to look at increasing those continuity of care models. Can you talk a little bit more about that and what needs to be implemented immediately to ensure retention of healthcare workers and the right amount of recruitment and making sure that there are proper staffing levels?
Yeah, thank you very much. Look, I think there are incredible barriers to maintaining good staff within our healthcare systems across both public and private space. Part of that is obviously around the support, not only for the exceptional skill set that the doctors and midwives have in this setting. For example, senior doctors and senior midwives without which birth units are incredibly hard to run very well. Experience is something in obstetrics that is incredibly valuable and is often not necessarily recognised in staffing ratios or in how we staff public or private hospitals, and yet is incredibly valuable. So I think certainly recognition of that experience. Equally, looking at how can we provide 24-hour care across a spectrum of geographical, but also across the increased needs that women of this generation will require. They are older, they have exceptionally good access to social media and other information sources, so good medicine takes time. And I think one of those challenges is really setting up systems so that we can give the patients the time that they need to have that, but recognising that health is a precious resource, that healthcare workers are precious, and that we obviously do have significant resourcing and funding requirements to do that. But I think across all of that public and private mix, that recognition, now that may be beyond the scope. We always know that health has a limited dollar, but I think spending that money sensibly and looking at the resourcing and staffing that is required would be exceptionally important as far as delivering better and ongoing psychologically safe healthcare services.
Thank you. And just sort of following on from that, you mentioned in your submission some of the reimbursement amounts for different appointments, and they seem quite low numbers in regards to those reimbursements. And I know you've made a recommendation that that whole space is reviewed. What would you really ideally like to see come out of such a review?
Yeah, look, thank you very much. I think it's lovely to hear that you agree that they are low, and that I think for the incredible value of bringing life into the world and obviously the complexity that takes with it, it is under-resourced and undervalued. I think it would be hard to give you an exact number today. I'm sure we'd be very happy to come back to you with figures that have been appropriately worked up over time. But I think looking at the complexity of what is required, not only from a physical examination, but obviously also from psychological examinations and the psychological input that is required into ongoing birthing care services, certainly for midwives, but also obviously for the doctors, and how that is done across those different reimbursement items, and how different numbers of visits may be required for different patients, and that they carry with it different and appropriate funding sources going forward.
Thank you. And yeah, if you could take that on notice, some of those more specific figures, that'd be really useful to get.
Yep, and I think maybe just to add to that, one of the other things we have put in our submission is looking at the additional services for women, such as physiotherapy, such as midwifery services that do have and carry rebates for women of this state and of this country, so that doctors don't work in a vacuum. We work best when we work in multidisciplinary care teams. Obviously, part of that is the appropriate education so that women are given accurate advice around what is available to them. But I think that's incredibly important to look not only at the medical space but also across those additional healthcare spaces so that everyone in the team is well supported to provide that care.
Absolutely, thank you. And you do mention in your submission as well care provided by other medical staff such as physiotherapists, and we had a submission this morning that that physiotherapy after birth, despite how needed it is often not available to most women. Is that something that you think should also be part of the review of the MBS item codes or some other review in regards to what care is provided to women?
Yeah, look, I think certainly speaking on the fact that we know physiotherapy services can be incredibly valuable in that education space, also for physical birth preparation, and then obviously for postnatal recovery. In my private practice, I have a number of midwives which work very closely with us, and I encourage most of my patients or all of my patients to see physiotherapy support, not only for birth preparation if that's a vaginal birth that they're aiming for, but also for caesareans. I think we know that whilst the literature is somewhat mixed, and I'm happy to provide further information about that in time on some notice, but we do know that anecdotally women who see physiotherapists, who see women's health trained physiotherapy, that is obviously a small subset of the physiotherapy training. In the nicest way, the physio that sees the guys for the hips and ankles of the rugby league players is probably not the ideal person to perform a vaginal examination and assess obviously a pelvic floor. But we do know that women's health specialty is incredibly developing and growing over time, and something that I think we should enable to grow and develop in this country to provide women with those services. One caveat I will say to that is that that obviously needs to work in conjunction with a concert of practice. We have unfortunately anecdotal stories of physiotherapists telling women that they should tell the doctors not to do a forceps on them, it'll ruin their pelvic floor. And obviously that can be incredibly damaging when, for example, a woman is fully dilated, a baby's head is very low, too low potentially or it's never too low, can be low, that would cause an incredibly dangerous caesarean section and may not in fact be appropriate for a vacuum delivery. Obviously the nuances of performing a vacuum or a forceps or emergency caesarean take many years and many years of training and expertise to find those nuances. But I think working as a part of that team to know that whatever that situation may be, talking about that in the antenatal space, ensuring that women feel appropriately educated going into the birth, knowing that there are a number of situations that can occur, and then having that postnatal rehabilitation can be incredibly valuable and an incredibly important part of that healthcare team.
I've just got one other question. I noticed in your submission you say that you talk about unrealistic expectations of control that women have. And I think from reading a lot of the submissions that have come through from individual women, the feeling of, and this isn't every submission, but a lot of the submissions seem to talk about feeling a lack of control because there was no information. And I note obviously in your submission you highly support this desperate need for information and education at all stages. And I'm just wondering, do you feel that if we commit to that idea of informed consent and making sure that all that education and information is provided, that helps to overcome this feeling of lack of control that a lot of women have come to this inquiry expressing? Is that part of the solution? Because obviously there's going to be those split-second decisions and those emergency situations that happen. But what we've heard so far from most people that have come forward is that if they had been informed, or if they had been informed during or asked questions or anything, or even just warned that things could happen where they had absolutely no idea, that they wouldn't have felt that loss of control. So I just wanted to get your feelings around that.
If I could take this to start, and I'll say from the outset that I am not legally trained, nor am I a doctor, so I'm going to give very general comments about this. If we're talking about informed consent in a formal sense in the medico-legal environment, then that is an area we need to be incredibly careful about. That is because informed consent is part of a legal framework, and that legal framework is very well developed and is part of the system by which we regulate healthcare practitioners. So there's a very significant distinction, and I'd actually encourage this committee to consider getting formal advice on the potential implications around making recommendations that may change the legal frameworks of informed consent, as opposed to the need to provide better information for people. What doctors are obligated to do, midwives and other health practitioners, in terms of their practice about consent, is that they're required to follow what a reasonable, and this is a dramatic simplification of a very complex system, but they're required to follow what would a reasonable peer do in the circumstance. And again, dramatic simplification, so please bear with me on that. And that is a test that you can, as a doctor, know and understand what that is and how to ensure that you are complying with it. Or a midwife or a healthcare. And this is a very regulated space. All healthcare workers are subject to the Healthcare Complaints Commission, the Guide to Good Medical Practice, and a range of regulated spaces. If you were to seek to change the legal framework of informed consent, you would really need to consider what that was going to mean for healthcare workers and how they discharge that obligation. So we just want to be very clear on the need for this committee to separate the provision of information from potential changes to informed and well-developed models of the obligations of consent. Because once you move to what appears to be potentially contemplated here is a test where it would be very difficult to guide the doctor, midwife on what would be required to disclose that discharge, that obligation. So again, we just want to be really clear there is a difference between changing legal models of informed consent and the provision of good information. They are just two different processes.
Yeah, thanks very much, Fiona. And I think certainly in that setting, it is incredibly challenging to know the full spectrum of information for which to give a patient. Obviously, it's essential to give open disclosure about the situations that can occur, but at which point do we find that that is what a reasonable person would give you? And I think that's incredibly important about that antenatal information provision, and being very open about what birth entails and what is required or may be required in certain circumstances, through to then obviously what the legal frameworks may be around that.
Can you just explain to me a little bit, as a layperson in this area, what you mean by what a reasonable person information would be given? Particularly sort of in relation to, I'm not quite sure if you're aware of a lot of the evidence that we have heard, but you know, a lot of these women are feeling that they haven't had a significant amount of information that could have been provided beforehand. Can you just explain that terminology that you use, just a little bit more detail?
Sure. I think part of the antenatal piece, for which we call, is education around the things that we often are not spoken about. Things like forceps, vacuums, emergency caesarean sections, need for episiotomies, some of what would be potentially considered birth intervention, but we know in fact occurs in such a significant number of patients. And I think one of the challenges is the system isn't always set up to provide that. Women who maybe go through low-risk models of care may be perceived to be low risk, and therefore this couldn't happen to them. And one of the most challenging things is birth is often low risk until it's not anymore. And I think therefore provision of all of that information is obviously essential to every pregnant woman going forward. The degree of that information obviously is open for testing and challenging as time continues, and for every person they will need probably a differing degree of that. And part of that is the nuance of developing rapport with a patient through whatever provision of model of care that may be. That may maybe through a general practice model of care, a midwife, but obviously that every part of that healthcare team is providing that information regardless of someone's model of care. And I think it is incredibly challenging for doctors when we may meet that person for the very first time and they've not been given any information about this, and yet we're at a point where then we're expected to perform a potentially life-saving procedure for mother or baby with very limited time and with limited antenatal education surrounding that.
Thank you.
Chair, through you, I've just got a couple of questions.
Yes.
Just following in this line of consent, if that's all right. Yeah. Thanks so much to you both for appearing today. In terms, and we have heard somewhat about consent in previous hearings, including our first hearing where we heard from Bashi Kumar-Hazard, who's the chair of Human Rights in Childbirth, who described how consent should occur for a woman who was required to have an unplanned forceps birth. And she stated, and I'll just read because this is a quote, Ms. Kumar-Hazard stated that someone to come into the room 10 to 15 minutes beforehand and say, this is something that we need to do, or the alternative is that we would recommend that you have a C-section. Then you step out and give her the 5 minutes to think about it and talk with her partner about what she would prefer. Could you explain if this is an appropriate and realistic method of giving consent?
Thank you very much. I think in some circumstances it can be, but I think one of the challenges that we've all talked about today is sometimes the time challenges for which we're faced in obstetrics. The other challenge is those very significant nuances around what is decision making in obstetrics, and again, believe that does require a significant years of training and education, for which our specialists in this country are obviously educated and trained for, and undertake rigorous examination to be considered a recognised specialist obstetrician. One of the challenges is that whilst in some cases we may have appropriate recognition that a labour may not be progressing as we had hoped, or that in fact intervention may be needed in time, and in which case certainly time is often given to patients. And I've been in a number of situations where myself or my juniors have given women that information, suggesting that as time progresses, they have a little bit of time to consider those nuanced discussions around what we talk about. One of the challenges is to provide all of that information in what is often a very stressful situation. A woman may be in pain, a woman may be sleep deprived after a number of hours of being in labour. For them to take on that information in that setting can be incredibly challenging. Part of that information obviously does need to then be provided in that antenatal setting, so that women, if they may then find themselves in this situation, feel they had more understanding about what that might be. One of the other challenges is saying, how do we provide that information appropriately so that time can be given, respectful practice can occur so that women can take the time they need, notwithstanding the physical safety that may occur if in fact decisions are need to be made in a split second. And that is obviously not all the time, but is something that's incredibly challenging to work with and is inherent in the nature of obstetrics.
And how should consent occur for a forceps birth? And do processes need to change in these time-critical emergencies? Earlier on, you spoke about an instance where a baby was low, but not quite low enough, but then there's no such thing. But, you know, and just if you could just talk us through, as lay people, the process of developing that expertise and that nuance and understanding, but then also the risk of not getting that baby out, like what happens?
Unfortunately, there is no risk-free way to have a birth. Well, when it goes well, that is fantastic. As we talked about those very challenging situations of, for example, caesareans at full dilatation, so where the cervix is fully open, a baby would otherwise hopefully be born, but for whatever reasons the baby is not coming through the birth canal. Now, that may be that a woman has been pushing for a period of time, and in fact we can give her more time to hopefully allow that baby's head to descend and she has a normal birth. Or that the head becomes low enough that it would be safe to do a vacuum delivery, for example. Or that in certain circumstances a baby's heartbeat may drop dramatically at that point in time, in which case, for those doctors trained in using forceps, that can be a very safe and appropriate tool. Forceps often get a very bad reputation. We know that they do have concerns around longer-term pelvic floor function. However, a lot of this information comes where women haven't had appropriate pelvic floor rehabilitation. Forceps were actually designed to protect a baby's head, and a forceps in an appropriate setting can actually help expedite birth, meaning baby could be delivered over a short interval of time, 1 or 2 contractions, rather than, for example, waiting for 20 to 30 minutes, where a baby's oxygenation drops very rapidly in that second stage, meaning that actually we've put not only a baby at risk, but also a mother at risk for performing a very complicated caesarean section. When a baby's head is very low in the pelvis and may be deliverable vaginally with forceps, there is a risk of things like tearing very badly into the large blood vessels that supply the uterus. There's a risk of damage to not only the uterus, but the bowel, the bladder, other organs that can be in that area. And most importantly, a significant risk of bleeding. The other major consideration is that there is also a risk for future pregnancies for caesareans performed at full dilation, a risk for preterm delivery, a risk of the scar causing complications, and a risk of placentation issues. Now, obviously in this setting, it feels like there is no good way out, and I think that's where there is that very subtle discussion and nuanced approach to my specialty, where we decide what is the safest way to deliver that in consultation with the patient, but explaining those nuances of why these are challenging things to do. Now, it's probably taken me about 3 or 4 minutes to even go through that in a very calm and non-distressed setting.
Yep.
Obviously, that's why there are challenges to doing this in obviously an emergent situation. And obviously, respectful practice has to be the cornerstone of that, and I'd like to think that in every situation we can still do these nuanced discussions very appropriately. That's part of being able to develop rapport with a patient very quickly, which is what my specialty of doctors and midwives do, particularly when we all work on the same team and the midwife who's been caring for a patient for that 6 or 8 hours in labour says, this is true, this is a situation that really needs the doctors, these are part of my team, we all work together to do that. And when obstetric works best, in fact, they're often not the births that may in fact have those significant trauma. It's often where that missing piece of education and information, but then also that postnatal debriefing has obviously not necessarily discussed those nuances. And that leaves a woman potentially scared and frightened about what occurred, but also what may occur into the future.
And so it would be fair to say it may or may not be appropriate to offer a woman an emergency caesarean section as an alternative to a forceps birth.
Correct. Sometimes, in fact, that may be a significantly higher risk operation to offer, and I can't speak for individual circumstances, but may account for why sometimes a forceps delivery was performed rather than, in fact, an emergency caesarean section.
And you talk about the second stage of labour, which is something we haven't really heard much about in this inquiry as yet, and the baby's oxygen level dropping and having that marked drop in heart rate. Could you just explain more for committee members what is happening there and what are the risks?
Thanks. So we know that babies are designed to tolerate the second stage of labour very well, which is why our population continues to grow. But obviously in some circumstances, babies can become distressed during that second stage for reasons that sometimes aren't even clear to us, even with our best medical technology that's available. Obviously, the role for monitoring can detect that a baby's heart rate is dropping. That may go from intermittent heart rate auscultation, which is performed in a low-risk situation, to then needing to apply a cardiotocograph or CTG monitor. That can give us a detection of what baby's heart rate is showing us during labour. CTGs are very good at predicting when babies are healthy. They are less good at predicting when babies are undertaking distress, but do have very significant signs of certain circumstances where that can lead the medical and midwifery teams to have to recommend action. And I think it's important to recognise it's not a trial of the baby. Obviously, all mums and all babies would like to be delivered in good condition. And so part of seeing that recognition of a baby's heart rate dropping may mean that birth needs to be expedited. So rather than giving women time for that baby's head to descend, rather than letting the second stage, which is the pushing stage, happen more naturally, sometimes that baby's delivery may need to be expedited. And that's where we have the consideration for those roles of instrumental births, for example, sometimes in episiotomy, and obviously occasionally a caesarean section will still need to be performed at that time.
Thanks, Jess.
I've just got 2 questions. You've mentioned a couple of times about being trained in forceps delivery. Is that a requirement, or is it that it's a skill that people should have?
It is part of obstetric training, is the role for instrumental births. Varying places around the world will have differing levels of expertise with forceps, but it is something that here in Australia, the vast majority of obstetricians are trained in how to use forceps. That depends a little bit on the centre for which they practice. Different locations will have different expertise. Medicine is obviously still in many ways an apprentice model where you learn from the seniors teaching you. But obviously also different demographics of population will mean that sometimes instrumentals can be subtly chosen for the idiosyncrasies that are required for certain demographics. For example, we know that in areas with a high Asian population, they do unfortunately have higher rates endemically of perineal trauma, and so forceps may exaggerate that, in which case a vacuum may be a more suitable instrument. These are obviously all the subtle features that we work towards. It's something that I believe we should continue to utilise, but utilise in an appropriate, informed, and obviously with that rehabilitation that goes along with any delivery.
And my other question is around some multicultural health plans, and also, and you referred to the blueprint that was released early this year. Some of the feedback we've received is partly that these plans aren't necessarily filtering down, but also that more work needs to be done. I'm just interested to hear from both of you, your views in relation to, I suppose, the plans that the government has already in place and how that is actually being delivered in the districts.
Yeah. Look, part of that I would probably refer you back to New South Wales Health in that it's the delivery of their blueprint. But certainly in New South Wales Health maternity services, one of the biggest challenges is around staffing and workload. And I draw your attention back to that this is the high level advice of what we would all aim to have maternity services to be. The practicalities of shifts where they're not staffed by enough midwives, where in fact there are vacancy rates across the VMOs and staff specialists of their obstetric workforce, make it incredibly challenging to deliver these services as a whole. But I think it's certainly something we continue to strive towards, and obviously with appropriate reforms in place could look at delivering those services, particularly to those women who need, from culturally and linguistically diverse backgrounds, our Indigenous population of Australia, to really provide those specific areas of care that are outlined in that blueprint.
Okay.
And we do recognise and acknowledge the newness of the blueprint. We're very supportive of it, and we're really keen that it's given the chance, given the work that's gone in. The AMA does not say that lightly. We do not endorse all New South Wales health policies, but we actually recognise the work that's gone into the development of the blueprint and the opportunities it presents.
Okay, thank you.
Through you, Chair, I have another question just around midwifery and continuity of care. It's something we've heard about a bit today and along the course of the inquiry, including that midwifery continuity of care should be provided to all women. Now, women with some risk factors should obviously be also seen by an obstetrician. Can you advise the best way this collaborative care should be achieved and could be achieved to ensure best outcomes for both the women and their babies?
Look, I think one of the things that we do know is that from probably an early visit and linking and engaging early with maternity services can in fact streamline women into appropriate care models, so that women who are low risk or have had uncomplicated pregnancies before can then certainly be linked with the lower risk models of care, and that may be midwifery continuity of care services. For those women who may fall into a higher risk model, obviously there are still a number of continuity of care services such as the private obstetrics, such as general practice and shared care that we've talked about, that provide a bit more of that medical element to that. One of the most important things though is continuing to expand and develop those services within the workforce constraints. And I think one of the biggest challenges around all of this is that workforce and resourcing is obviously incredibly vital to ensure that that continuity of care service can be continued to be developed, so that women have a lead clinician as a part of that, but recognise that the New South Wales health budget simply does not and cannot account for a single obstetrician to care for you in a public hospital throughout your birth. But there's no question that aiming towards that continuity of care to provide those education services, be that through those different models that we've discussed, is obviously something to aim for, but recognising the practical implications of what that might mean for our health service and how we can deliver that.
And in terms of the care that women receive more generally, we've also heard about women wanting to receive more respectful care that's trauma-informed, so that they can make informed decisions and provide valid consent, indeed. Can you describe some key actions and ways that we could achieve this also?
Sure. Look, I think one of the biggest challenges, and I keep coming back to this for the purposes of the committee, but is really around that resourcing and looking at workforce development. We know that respectful care occurs beautifully where there is appropriate staffing levels, where women feel they have the appropriate teams around them to care for them for all of those, not only physical aspects of birth with the medical components I've spoken about today, but the psychological aspects, looking at their emotional well-being, looking at physical recovery, looking at things like breastfeeding and midwifery support rates in the postnatal setting. And all of those obviously come back to appropriate resourcing and infrastructure to ensure that we have the ability to care for women through that way.
Thank you. Thanks, Chair.
Thank you. Is there any further questions?
If there's time.
Yeah.
We've had some mention in submissions, particularly from consumer representative groups, about some of the changes that have taken place in Queensland. Some of that was to do with their informed consent model, some of it was to do with endorsed midwives. Interested in the perspective of the medical profession on those changes in Queensland and how they've been received.
Yeah, thank you.
We were really interested to note the evidence given around the Queensland roundtables because there's been very significant concern across the country about the state of maternity services in Queensland. It's not melodramatic to suggest that actually in large parts of Queensland maternity services are on the brink of collapse. And in fact the roundtables have been called by the Queensland government in response to the crisis in the delivery of maternity services. There are large centres now currently struggling to attract doctors to work in those areas, and so that has driven the crisis and roundtable response. We would not want to... we should learn from all jurisdictions about places where there are good models, but I think we need to be incredibly careful about the situation in Queensland because it's been watched around the country as a place where people in large centres are not able to access or are running the risk of not being able to access maternity services. We need to be really clear that but the role of doctors and the role of midwives are critical to the provision of maternity services, particularly in large regional centres. And so I think it's really important for the committee to just review the context of what's happening in Queensland. Our understanding of the issues are that they are working through them with roundtables, but it is a very significant matter. There is a national shortage, in fact an international shortage of skilled workforce. We certainly wouldn't want to see in New South Wales any further reductions to the access to, particularly, well, we can comment on medical specialists, but it's a matter that people should be very concerned about.
Yeah. And I think following from that, even in tertiary centres in Sydney, there are a number of vacancies across obstetric medical positions, and certainly obviously that challenge only becomes greater as we step further away from metropolitan areas, and that's a significant challenge to obviously provision of obstetric services and all of those ambitions we have to provide excellent care to women.
Through you, Chair, I just might, with the indulgence of the committee, you mentioned your endorsement of the blueprint, which comes as great news and something that's not given away lightly. But if for this inquiry, we will obviously make recommendations to the government. If you could suggest anything as a recommendation, what would that be?
Do you want to start? Or? Look, I think our submission actually sets out very much the requirements. I think, firstly, we would really strongly urge a caution about the potential to do harm. So actually not making recommendations that may seem well-intentioned, but actually could be catastrophic to the delivery of services. If there was one most critical recommendation, that would be the main one we would make. We don't want to actually inadvertently make this system less safe and harder to work in. So that's probably our number one recommendation. And yes, number two is resourcing and workforce.
I think absolutely that challenge from today of concerns around what that might mean for obstetric practice being held to different account is obviously incredibly concerning for obstetric practice, not only for obstetricians but for midwives on the ground in our birth units in this state as we speak. Obviously anything that would harm that provision of safe care is incredibly challenging and would be something that I think genuinely has the capacity to decimate our services. Notwithstanding obviously the importance for the psychologically informed care and emotional well-being that goes with appropriate care for women. But I think part of that really is addressed through that appropriate workforce and resourcing that comes behind giving that very best in obstetric care.
And given the challenges facing indeed the world internationally, you mentioned the shortage of certain skills. Have you got any suggestions for us as a committee on recommendations that we could make around that? Acknowledging as well that obstetrics is certainly a very honed area of medicine and takes many years, in fact decades, to really refine your craft. So how can we work so as to make these positions attractive but also keep people in them?
Yeah. Look, I think I'm not an HR expert, I'm an obstetrician, but I think working in that is obviously recruitment and retention strategies need to be first and foremost, in that if you have a happy, healthy, safe workforce, all of those things can and should flow down to providing that excellent and empathetic care that we all want to be able to give our patients. So I think looking very specifically at the appropriate resourcing for positions, recruitment, retention, appropriate funding and salary models for both midwives and obstetricians in the public and obviously the private sector, and how those are supported appropriately would be incredibly valuable.
Thanks, Chair.
Thank you. Well, thank you both for coming in today. I do note that you did take some questions on notice, and there may be also some follow-up questions from the committee members, which we would send through as well via the Secretariat, and they will be in contact about those. And thank you again for your time.
Thank you very much.